morning. Welcome to third World Day of Regional Anesthesia and Pain Medicine. We are joining you live from Newcastle upon Tyne, UK. I've got Nat Haslam, the ARIA UK President, who is also joining us to deliver this session for the benefit of all of you. We have an exciting program today. We're going to start with introductions from the World Societies and also the Sister Society presidents, followed by the Evidence Club, associated with also live scanning sessions throughout the day. And then we go through the same program with other sessions of scientific sessions joined by speakers on stage. Feel free to enjoy the day and also post your questions and comments on YouTube. We will pick it up as we go, and we can help you answer those questions. So we're going to kickstart the day with Dr. Nat Haslam, ARIA UK President, joining us. Thank you, Nat.
Good morning, everybody. Morning, everyone in the room as well. It's an absolute pleasure to be to welcome you all to the third day of World Day of Regional Anaesthesia and Pain Medicine. It's a real privilege in the Northeast to be part of this. I'd like to say thank you to Eleni Moka, who is the ESRA President, and to Sebastian Bloch, the President-elect, for organising the whole event. And thank you to Nuala Lucas, who is our very own Professor Nuala Lucas from the UK, who is chairing the event today. For everyone who doesn't know, the World Day has grown to become a completely global phenomenon now, and we're proud to make our contribution in the Northeast by streaming live for English-speaking countries, and especially to our friends and colleagues in low and middle income countries. We, as part of ESRA, have teamed up with the American Society of Regional Anaesthesia, ASRA, the Latin American Society of Regional Anaesthesia, LASRA. We are streaming with our colleagues from Africa, from AFSRA, and from the Asian and Oceanic Society, AOSRA. So it is truly a global event today. We're promoting equity, access and pain relief through regional anaesthesia. We'd like to say a big thank you to our sponsors, to Rob Atherton, who helped us set up yesterday, and to Pyank, and to Adam from GE at the back there, who's provided machines and systems so that we can bring some live scanning to you today. We'll start with an introduction from Eleni Moka, who is President of ESRA. So we've got a pre-recorded message from Eleni. Hopefully she'll be able to join us live a little bit later on.
Dear colleagues and friends, the third editions of the World Week and World Day of Regional Anesthesia and Pain Medicine have already unfolded with inspiring initiatives taking place worldwide. In this context, we unite across continents, cultures, and languages around one powerful message and belief: that no one should suffer in pain when relief is possible, that equity, access, and relief are fundamental in our clinical practice. As the President of ESRA, I proudly stand along with our sister societies, ASRA Pain Medicine, AFSRA, LASRA, AOSRA PM, as co-organizers in this activity, with the strong support of the World Federation of Societies of Anesthesiologists, and with the endorsement of World Institute of Pain, EFIC, and the Obstetric Anaesthetist Association. And in this context, the strong statements of the WHO KOL are other powerful testimonials highlighting the importance of our mission. This week, in almost 200 cities worldwide, with more than 800 speakers and experts, and more than 50,000 delegates across all continents, one message rises above all others. Pain relief must be accessible to everyone. Pain is universal, but access to safe anesthesia and effective pain relief, unfortunately, are still not. And this is not only a medical issue, it is a human issue, because behind every patient in pain, there is fear, vulnerability, and loss of dignity. Regional anesthesia and pain medicine are not and should not be luxuries. They are a human right. For this event, I would like to express my deep gratitude to Professor Nuala Lucas, chair of this extraordinary initiative, Sebastian Bloch, the next president of ESRA, and Dr. Fanny Alevrogianni, our trainees representative, for turning in a collaborative spirit a vision into a global reality. Also, many thanks to the entire ESRA office team for working behind the scenes tirelessly. Heartfelt thanks to every speaker, every organizer, and every participant. You are the heart of this movement. So today, wherever you are in the world, let us make one promise, that geography will no longer decide who suffers, that knowledge will travel faster than inequality, that compassion will guide our science, because the future we are building is simple, and it is just like that. Where care is possible, pain should not exist. Thank you for being part of this global movement. Together, we are changing the future of regional anesthesia and pain medicine care. Enjoy the week and enjoy the day. Thank you very much.
Okay, and next we are very pleased to introduce you to Nuala Lucas, MBE, who is a professor in the UK.
Hello,
and president of the Obstetric Anaesthesia Association.
Hello, my name's Nuala Lucas and I work in the UK. I want to wish you a very warm welcome to the third World Day of Regional Anaesthesia and Pain Medicine. I'm absolutely delighted you're here. This year our theme is straightforward: equity, access, relief through regional anaesthesia. I think we can all agree these are three words that should never be controversial. Regional anaesthesia is one of those rare parts of medicine where you can genuinely say this makes patients safer, more comfortable and more functional, often with less opioid, less nausea and less misery all round. What's not to like? But, and it's a big but, the reality is that not everyone gets access to these benefits. Too often it depends on geography, resources, or whether there's a local enthusiast available to teach the next person. So today is about being practical and ambitious, helping make safe neuraxial and peripheral techniques normal, reliable and deliverable, not just in the best resource centres, but in busy theatres, emergency departments, trauma and maternity units globally, settings where people are doing little miracles with very little kit. Working with ESRA and our sister societies around the world, we're focusing on sharing what works, building local capacity and making training accessible, so that regional anaesthesia becomes less of a luxury and more of a standard. Thank you for joining us, for your generosity with your time, and for everything you do to turn knowledge into better care. Equity, access, relief. Happy World Day of Regional Anaesthesia and Pain Medicine.
Hi, Eleni.
So, hello Eleni, can you hear us? Hi Eleni, can you hear us?
Yes,
Eleni, hello.
but there is...
Sorry, we had a few technical glitches there, but now our tech is working nicely. How are you?
I'm okay, I'm super fine.
It's an absolute privilege to talk to you today.
It's a great pleasure for me.
So we've introduced you as the president of ESRA, and we've discussed Nuala as chair of the event, and said a shout out to Sebastian Bloch as well. We've introduced this as a truly global event, but it is, as I say, a real privilege to have you join us here today.
Thank you very much, Nat. Thank you very much, Kieran.
Thank you, Eleni, for joining us.
Apologies, I hear my voice 2-3 times, like there is an echo. I hope you can listen to me. My message will be short and from my heart. Just a big thank you to all of you for your tremendous efforts, for the support, for the energy to participate in this massive activity, the third edition of World Day of Regional Anesthesia and Pain Medicine. Not because only you did the efforts, but because you believed in the vision. And this is the fundamental part for every success. You believed in the vision and you make it mission. And we have so many examples from your team there, from Nat, from Kieran, from other colleagues in your area who truly believe in the message, in equity, in access, and in relief as a part of a universal health coverage, as a part of a safe anesthesia practice and a safe perioperative journey for our patients. And the activity belongs to you, not to ESRA. Belongs to the participants, to the organizers who have done so many efforts. You have been working tirelessly these days to stream your activity to countries that struggle to have the knowledge. And this is the key of the day, that we are here in the Western countries maybe with more equipment, with more luxury, if I may say, but we never forget our colleagues elsewhere who are thirsty to learn, but they do not have what's needed in their countries. And those patients deserve equitable care as well. So thanks from my heart to all of you, to the organizers, to the audience that are there Saturday morning attending you, learning, eager to learn, to the sister societies that have embraced the activity, to the other organizations that have endorsed the activity. And I have to dare to say that I feel very, very proud to see that even the World Health Organization understood our vision and mission and supported with very, very strong messages that you have in your website and app portfolio. What we do, that we know, that we wish, and in a working environment, a patient care pathway that has no boundaries, geographical, cultural, language, whatever those are. Congratulations from my heart. Good success to all of you. Thank you for the trust. And I truly hope to see you soon in similar future endeavors. Thank you.
Thank you, Eleni, for joining us.
Thank you ever so much, Eleni. We're really excited to be streaming today, and it's a real privilege that you could join us. So thank you ever so much.
Thank you. Thanks a lot.
Next, we're going to have a short video from Professor Ezat Aziz, who is the president of the African Society of Regional Anaesthesia, who Kieran and I have had the pleasure of working with closely on various projects in Africa. And he's going to introduce the World Day of Regional Anaesthesia from an African Society perspective.
of the African Society of Regional Anaesthesia. I would like to welcome you all in a big event next January for the World Day of Pain Medicine and Regional Anesthesia. It's indeed a World Day. All the 5 societies, all eminent speakers, and in different languages, we can provide the information to people across the African continent, across the world. I really would like you to join, and I wish you the best. Thank you.
So thank you to Professor Ezat Aziz for the introduction from the African Society. So the idea today is that we're going to stream live to predominantly low and middle income countries. And what we thought we would do is intersperse our lectures with some live scanning sessions. And so in the UK, we have the concept of the Plan A blocks. So Plan A blocks are 7 blocks which are, have very good coverage of the body. We try and limit it so that we can teach everybody these blocks, so they are high value blocks. The 7 blocks are the Interscalene to cover shoulder surgery, Axillary to cover more distal upper limb surgery, elbow and hand surgery, the Rectus sheath block for midline abdominal incisions, ESP blocks for rib fractures and breast surgery and chest wall analgesia, and then for the lower limb we have the femoral. As a motor sparing alternative to femoral, we have the adductor canal, and then to cover the foot and ankle we have the popliteal sciatic. So these are our 7 Plan A blocks. The initial paper that discussed the Plan A blocks, I can't quite believe it was a long time ago now. You can see there 2020, it's 5 years since this concept was introduced. This is by Lloyd Turbot, who is the current treasurer at ARA UK, Ed Mariano from the US, and Professor Kareem El-Bogdadli, again from the UK. And they wanted to limit the number of blocks we have to teach everybody to get coverage of all of the area of the body, so it's not just for experts in regional anaesthesia. This is something that, since changes to the curriculum in 2021 in the UK, every anaesthetist should be able to complete their training being able to do. So this is what we're going to focus on today. So there are Plan A posters. These are downloadable for free from the ARA UK website. And you can see here they show the anatomy, they show the sono anatomy, and they have some overlays. We'll have some live overlays via the nerve blocks technology with GE's system today, which hopefully we'll be able to show you. Now, I work in a centre where we do lots of regional anaesthesia. We're a kind of a big regional anaesthetic centre. But 70% of the blocks we do in my hospital are Plan A blocks. So this is a really important area to be able to learn. We're going to start off in this first session concentrating on the Interscalene and the Axillary block. I'm going to be scanning this with my colleague from Sunderland, Dr. David Hay, one of the other consultants. We'll start off with the Interscalene block. We're very happy to have Maria as our model today. She's going to help us with this. And so we'll move on to our first scanning session. So this will be Interscalene and Axillary blocks. I think you can see Maria. Yes, you can see Maria here. I can look at the split screen. That's nice. And so the first thing when we're doing Interscalene blocks is to have a nice position for the patient and to get the patient into a position that is comfortable for them and is ergonomically useful for us to scan. So we normally have the patient slightly sitting up for this block. It's more comfortable for most patients than lying completely flat, and indeed, some patients just can't manage to lie completely flat. So we have a pillow, but not too big a pillow, because that will limit our access into the interscalene area. What we often do for needling, I won't do this today so much, but Maria, if you could just lift your head up, we can move the pillow right over, and then if you can just turn your head slightly over to that side, not too much, that's perfect, then that gives me lots of room to be able to come in with my needle. Just because of the ergonomics in the room, I'm not going to have it here, but we would normally have the ultrasound machine over the other side of the patient so that I can scan here, and I can needle here, and I can look directly across at my ultrasound machine. So that's going to be the best. That's going to be the best setup for interscalene block. Okay. This is a little bit of a voyage of discovery because we haven't pre-scanned Maria at all. So we're hoping the anatomy is going to be nice. I'm sure it is, Maria. So a bit of cold jelly now. I'm using a linear probe, so this is you can see the linear probe here. This is a high frequency linear probe. It's a 4 to 20 megahertz probe. So just for people who are not so familiar with using ultrasound, the higher the frequency, the better the resolution. The lower the frequency, the better the penetration, but you lose some of the resolution. So I'm expecting, especially Maria here, but most people, their interscalene plexus will be very superficial. So we want to use a high frequency probe for that. So David is going to help me point on the screen here, and I'm going to start scanning. Could you do the... Yeah, thanks. So we just we've put the probe on here. It's immediately we can see it's a little bit too glary there. So yeah, I'll just take a notch of depth off there. So generally it depends on the machine you're using a little bit, but often you can set a focal point. If not, a lot of machines, the focal point is best in the midpoint of the depth image, and we're getting a nice view here. And so if we can use the pointer, we can just, we're just going to get the pointer on here. And we're going to demonstrate some of the anatomy for you. Brilliant. So yeah, we are live streaming. That's just to prove we are live streaming everything today. So it sometimes will take us a little while to get everything set up. But okay, so in the middle of the screen here, you can see the subclavian artery. So we're just going to demonstrate the subclavian artery for you there. The subclavian artery is sitting on the first rib. So deep to the subclavian artery is a bright hyperechoic line of the first rib, and below that is an acoustic shadow. To the right of the screen, which is lateral, so the right of the screen is lateral, you can just about see the pleura. David, can we have maybe one more notch of depth? So we're just going to increase the depth slightly just to demonstrate that for you, so you can see lung, and this is pleura, so that's lateral pleura. And then we'll just demonstrate the medial pleura for you. So this is, that's medial pleura that's lung and medial pleura. So medial and lateral pleura would join together, other than we've got a shadow where the first rib the ultrasound will not pass through the first rib, so we've got an acoustic shadow. Okay, so we'll keep that depth for now, I think, actually. So we've got subclavian artery sitting on first rib, and to the posterior lateral side, so that's on the right-hand side, is the brachial plexus. So this is the brachial plexus here. I'm angling, you can see that from the split screen. I'm angling my probe down behind the clavicle, so this is probably the divisions of the brachial plexus here, and we get that bunch of grape-like appearance. Next, I'm going to scan more proximally, and you can see those hypoechoic nerve roots start to sandwich into an interscalene groove. We can see the two scalene muscles forming. So we've got the scalenus medius here, which we're demonstrating, and the scalenus anterior muscle, which is across to the left-hand side of the screen, which is anterior. I'll just go back down to the supraclavicular view. There's our divisions with the subclavian artery coming back up again, the scalene muscles forming, the two scalene muscles forming, and we've got the nerve blocks technology is starting to highlight the brachial plexus for us there in the interscalene groove. So what we're going to do now is just demonstrate the individual nerve roots. So if you could you show me the C7 nerve root there, which is in the middle of the screen, I think. Yeah, so that C7 is here. I'm scanning cephalad now, so the C7 nerve root is going to dive down. And what we'll see is the transverse process, the C7 transverse process with its deficient anterior tubercle, because that's where the vertebral artery is going to sit. The C7 nerve root disappears behind the transverse process of C7. The next nerve root we're seeing coming into view in the middle of the screen there is the C6 nerve root. Higher up, that's often split and bifid, and that's what gives us our traffic light appearance that people talk about. But here it's disappearing just behind its transverse process. So that's just there. That's C7, and then, yeah, C6 there. So we've got a much more, the C6 transverse process is much more bifid. It's got both a posterior and an anterior tubercle. You can see it just disappearing there. And then if I carry on scanning more cephalad, we see the C5 nerve root is just, can we have a little bit more gain? Yeah, we've just gone a bit dark. So we're just, maybe not quite so much. We're optimizing our image as we go along here, which is good practice. And then coming back down, we can see the C5, C6 and C7 nerve roots all lining up into the interscalene groove there. Okay. So once we've counted our nerve roots and we've identified the individual nerve roots, we can then perform our interscalene block. So we can now take a little bit of depth off the image. And Maria has a very nice interscalene groove here. It's a very classical view. In some patients, the nerve roots will go through the muscle bodies themselves, and it's more difficult. So sometimes residents in the UK will come through and they'll say, I'll ask them, what are you looking for? And they'll say, I'm looking for the traffic lights. And that's absolutely fine if that particular patient has a single C5 and a split C6. But sometimes that's not the case. So you need an alternative way of identifying the individual nerve roots. And so identifying the shape of the transverse process and counting up from the supraclavicular view is the best way to identify those individual nerve roots. So now we've identified C5 and a split C6. We can see it nicely in the interscalene groove there. This is where we can now perform our interscalene block. So there's a couple of things we need to think about. Our needle is going to come in from posterior lateral. So it's going to come in from the top right-hand side of the screen. Can you show us what the kind of needle trajectory? Yeah, so it's going to come through the scalenus medius muscle and into we're going to inject on the posterior lateral side of the brachial plexus. Now there are a couple of things we can see coming through the scalenus medius muscle. There's a little dorsal, so higher up. Yeah, it's there, yeah. So it looks like a tiny muscular cutaneous, but that is the dorsal scapular nerve just coming through the body of the scalenus medius muscle. So if we're doing an in-plane approach from posterior lateral, We just need to be careful to avoid the small nerves. There's a long thoracic nerve more deeper within the body of scalenus medius, but usually it's that dorsal scapular nerve which lies superficial, which may be in the trajectory of your nerve pathway. So be aware of that. Why are we going to inject on the posterior lateral side of the plexus? Well, because over the anterior side of the scalenus medius muscle, if we can just point it out there, we have the phrenic nerve. So the phrenic nerve, it's like the little it's a small hypoechoic area just coming over there. That's it, just to the right. It's there. You see? Yeah. So just coming over. So as I go more distally, the phrenic goes over the anterior side. As I come more proximal, it comes over towards, because it's going to come off the C3, 4, 5 nerve roots, isn't it? C3, 4, 5 keeps the diaphragm alive, as we all learned in medical school. So the more distal we go, the further away that phrenic nerve is from the interscalene groove. So I'm coming down here to almost where we would do an upper trunk block. So the idea of doing an upper trunk block is to inject local anaesthetic around the C5 and C6 nerve roots where they've come together to form the upper trunk. We're a little bit further away from the origin of the phrenic nerve, and we're a little bit further away from, because the phrenic has gone a little bit more medial. So what we're trying to avoid is diaphragmatic paralysis with that. So this is this is the interscalene block. It's sometimes a little bit one of the more difficult plan A blocks to do. The anatomy is a little bit variable. So if you see the traffic lights, that's all fine and good. If you don't, you need to learn how to start in the start with the supraclavicular view. That's the most reliable starting point because the subclavian artery has to be at the base of the interscalene groove. Scan more proximally, counting the transverse process, and then we're looking to perform an in-plane injection from posterior lateral to anterior medial with local anaesthetic in the posterior lateral side of the plexus to try and avoid phrenic nerve involvement. And if we can, maybe inject a little bit more distally around the upper trunk. So that's the interscalene block. Okay. So next we're going to have a look at the axillary block.
Right. Is my microphone on here? Thank you. So we just the axillary block is will you pop your arm there? Is that okay? Yeah. Is a brachial plexus block at the level of the peripheral nerves once they've divided. It's one of our Plan A blocks, as Nat mentioned earlier. In fact, I think it's a Plan AA block. It's really useful for avoiding general anaesthesia in hand surgery, in awake hand surgery, and a really useful and safe block to learn. So in terms of ergonomics, in our practice, again, we'd normally be on the other side of the patient, looking this way, which can be useful to keep an eye on the patient's reactions and so on. So then the probe lies in the axilla, like so, and the ultrasound landmarks that we're looking for are the the conjoint tendon of latissimus dorsi and teres major, and the axillary artery.
David, just hold still there, I'll demonstrate this for you. So we've got axillary artery sitting in the middle of the picture here. This linear structure, so if we have a little bit more depth, this is the humerus here, and then the linear structure coming up in this direction is, as David says, the conjoint tendon of latissimus dorsi and teres major.
Okay, and at this level, we can identify the 4 peripheral nerves from the brachial plexus, and there's between the muscles biceps and choriobrachialis, we can see a nerve sliding through there, and that's the musculocutaneous nerve. And if we scan up, we can see that joining, possibly. You can see that joining the brachial plexus proximally.
So just going back to the level of the conjoint tendon here, this muscle here is coracobrachialis. This muscle here is the short head of biceps. So yeah, as David said, musculocutaneous sandwich between coracobrachialis and the short head of biceps.
The anatomical pattern of the other nerves varies to some extent, but they're usually found around the axillary artery. So there's a hypoechoic nerve superficial to the artery. I'll just get you to.
So yeah, we often describe them as like a clock face around the artery, don't we? So this is the artery here. So were you looking at the?
Yeah.
So at the 12 o'clock position here is the median nerve. So that hypoechoic structure sitting on top of the axillary artery there is the median nerve, and that normally sits between 9 and 12 o'clock in relation to the artery.
And if we scan distally down the arm and follow that nerve, what we'll find is that it stays with the artery right down the arm, and that's a characteristic feature of the median nerve, and it's a useful way to differentiate the nerves at that point and then back up to the conjoint tendon.
It often splits into two, doesn't it? You often see two, like a pair of spectacles, and that's because the median nerve is made up of from the lateral and the medial cord coming together. So to watch out for that as well. It'll often look like, you can see almost there, it's like a pair of spectacles with two hypoechoic areas there. And the musculocutaneous is swimming up towards the median because the musculocutaneous comes from the lateral cord as well. So the median and the musculocutaneous origin is similar.
At about 1 o'clock to 2 o'clock to the artery, there's another large hypoechoic nerve structure. We'll just highlight that. And then if I scan distally down the arm.
So what's this one, David?
This is the ulnar nerve.
Yeah, cool.
So that's the ulnar nerve, and that separates from the artery, scanning down the arm.
So in the midpoint of the arm, it's sitting on top of you. We've just go down a little bit. Yeah, so perfect there. So this muscle here is triceps. So the ulnar nerve sits on top of triceps. It's the only linear structure that you can scan down the arm that sits superficial to triceps. So it's really easy to identify. It's heading between the medial epicondyle and the olecranon into our ulnar groove, and it goes over very superficially over triceps. So if you're struggling to identify it at the level of the conjoint tendon, just scan down the arm a little bit and pick it up in the midpoint of the upper arm. Yeah, so that's ulnar.
Ulnar nerve. And then the nerve which is often the most difficult to identify lies generally on the conjoint tendon, and that's showing it there. This is the radial nerve. And as we scan down the arm, what we'll see is that dives deep towards the humerus. Yeah,
I'll give you a little bit more depth. Yeah, I'll give you a bit more depth, notch more depth.
And yeah, and dives into the spiral groove of the humerus.
And we'll see it.
So we can
coming back up towards the axilla now. It all gets a little bit difficult to see just before the conjoint tendon forms, but you can see the radial coming up here. Then as we scan proximally, the conjoint tendon sort of snaps shut, and we can see the radial nerve has to go on top of the conjoint tendon because it's coming from anterior from the plexus to get to the posterior into the spiral groove. So it has to cross over the top of the conjoint tendon. So that's why the conjoint tendon is such a useful landmark to be able to identify. So I'm just going to take a little bit of depth off again here. So different people have different ways of needling this, but often we'll start from the anterior side coming through biceps, and we'll block musculocutaneous. You can see a little tail of fascia here coming off the musculocutaneous. So if we put our needle in here, we can split the two layers of fascia between coracobrachialis and the short head of biceps. And a little bit like doing a tap block, we can unzipper that layer and we'll get a nice musculocutaneous nerve block. The angle in Maria will be quite steep here, so I'll probably be looking to bring my needle back into biceps and then make a more superficial injection, and I'm going to go deep to the axillary artery onto the conjoint tendon. The trick here is to be as superficial with your needling angle as you can so that you don't partially go through the conjoint tendon, and you can inject deep to the artery, and we're looking to lift the radial nerve up off the conjoint tendon. We're looking to get spread that comes superficial, maybe around ulna as well. We don't want to see spread that's coming down in this direction because that will be deep to conjoint tendon and will be not effective. So once we've got local anaesthetic deep to the radial nerve, we'll come right back into the body of biceps with our needle, and then we'll make a second pass superficially over the top of the axillary artery. We'll look to identify and block the medial cutaneous nerve of arm and forearm, which lie just in the superficial fascia, just deep to the superficial fascia over the top of the artery, and then get spread around the ulnar and radial from this side. Local that spreads along the superficial to the conjoint tendon but deep to the superficial fascia in this direction is useful because that will head towards the intercostobrachial nerve and give us analgesia towards the axilla, which is useful for tourniquet as well. We'll look to use between 20 and 30 mils of local anaesthetic for this block. It's essentially for individual nerve blocks of the major branches of the brachial plexus. In my practice, and I think you use the same, David, don't you? We use ropivacaine for speed of onset and duration of action. Nice, easy block to do. Again, the anatomy is a little bit variable, but it's a really safe block, and it's very effective for both elbow and hand surgery. So this is our Plan A block for more distal upper limb surgeries.
Okay,
great.
Thank you very much.
That's good. Have we any? We're just going to swap over to some recorded lectures now. But have we got any questions from the room about any of that, or is it all completely clear? Yeah.
There's a mention of when you are adjusting the depth of the width of the figure, keep the focus in the center of the screen.
Yeah.
So that,
yeah.
That's for every block, or that was just for Interscalene and Axillary?
No, that's a general principle for every block. I know the GE machines, you can set the focal point where you like on the depth of the screen. Some ultrasound machines you're not able to do that, and so having the thing that you're interested in at the centre of the depth of the image is going to help you to get the clearer view. Also, you don't want to make everything too small by having too much depth on. But equally, you don't want to have everything so superficial that you end up missing something that you would have liked to have seen. So what we talk about often is, we used to talk about doing a harbour cruise, so we would have a look at all the anatomy, so we'd maybe set the depth a little bit deeper than we thought we needed, have a look at all the surrounding anatomy, and then focus in on the this area that we're particularly interested in. So for Interscalene, we'll set the depth quite deep. We see where the pleura is, because it's important. We know if we're sticking a needle in the neck, it's important we know where the pleura is. And then once we've identified that, and the transverse processes, if we need to do that, then we can set the depth very much more superficially and get really nice high resolution image of the superficial tissues. Same for the axillary. block, maybe set it a little bit deeper, identify the humerus and the conjoint tendon, identify your levels, and then you can set it a little bit more superficially. And if you have a machine where you can adjust the focal point, then do. If you don't, then make sure you have that image in the center of the depth.
Another question, if I can.
Yeah, sure.
So in G machine, I've noticed that you can have different settings for like a nerve block, for a vein, for vascular and all that. Do you prefer any particular setting, like ESP block or tap block?
Yeah, so I think for what we're simple creatures as anaesthetists, aren't we? We want things to work out of the box. We want to pull them in and work out and have them work out of the box. So G have very kindly for us put together a number of presets. So it's going to set things like gain, depth, dynamic range, and try and optimize the image. So if you imagine if it's vascular access, then you want veins and vessels to look black, and you want everything else to look a different colour, and that's all you want. And that's a very different preset to nerves, where we saw, the subtlety of the dorsal scapular nerve within the medial scalene muscle that we saw there. So it's a very different image. So yes, absolutely use the presets that the companies have given us. My preference is to start on the nerve preset for whichever machine I'm using. Occasionally the musculoskeletal preset might improve things if you're doing something like a fascial plane block like an ESP or a rectus sheath block. But for the vast majority of patients, it's a nerve preset setting that will be best for you. Yeah. Okay, so next we're going to move on to the Evidence Club. And so our first session will be a recorded session. Dr. David Hay, who you may not have seen, who's now on the big screen, he doesn't realise it, but he's on the big screen, is going to chair this session with me. But we're going to have three recorded sessions. The first one is from Professor Steve Coppens. He's going to talk about his top regional anaesthesia papers of 2024 and 25. Steve Coppens works in Belgium and has just completed a PhD and is an expert in fascial plane and abdominal wall blocks, but is generally all-round fantastic regional anaesthetist, and I'm really interested to hear what he has to say about his favourite papers for the last year.
For the honor to present here for the World Day of ESRA. And I was asked by my good friend Nuala Lucas to give a little bit of an overview of the literature, which I found very interesting in the last couple of years. So it is always very difficult to choose the things that you interest, and always these choices are very personal. So probably my list will be completely different than other people's list, but I will explain you why I chose these particular articles. So first off, I would like to start with a nice editorial by Graham MacLeod and Miguel Reina. I have a huge admiration for both these guys. I am a clinical scientist, but to be honest, these guys are really fantastic basic and clinical scientists, and they have in 2024 they produced an editorial about nerve block, nerve damage, and fluid injection pressure, overturning the myth. It was a hugely interesting editorial which has changed my practice, and I always use neurostimulation but never have used pressure monitoring, and now I'm pretty certain that it wasn't needed either. And like all good research, they challenge the given ideas, and they also ask new questions and challenge the future to come up with new ideas and better ultrasound to envision where the local anesthetic needs to be put to have the best effect while having a much higher safety margin. So this concludes my first paper. The second paper is a paper which just was published in November last year, and it is very interesting because it looks at the association of peripheral nerve blocks with increased postoperative pain and opioid use in orthopedic surgery. It is, although it is a retrospective cohort study, and you know retrospective data always has some bias, it is rather large, more than 20,000 patients, and it is also published in the British Journal of Anaesthesia, which has a high impact factor, and they convey a message which I've always believed, that our single shot blocks are not always great. So I think that single shot blocks can lead to rebound pain, whether that is a physiological thing or just a not good management of multimodal. That's of course another question, but it challenges again the idea that you are very good off with your single shot block and your patient is good at the PACU, but don't care what happens on the wards. No, you have to or use catheters or use repeat blocks or make your multimodal transitional pain service perfect. So it's a very interesting, thought-provoking retrospective cohort study. And in that same message, I'm still completely in awe by the epidural analgesia during labor and severe maternal morbidity population-based study by Rachel Kearns and colleagues. This was a fantastic publication looking at 500,000 and more labor patients in the UK, and showing that there was a decreased maternal morbidity up to 35% when patients had epidural analgesia. Now, again, it is, of course, retrospective data, and probably it doesn't really mean that the epidural leads to to less severe maternal morbidity, but that looking at your patient and observing your patient is much better than not observing your patient. And it's a little bit the same as I published an editorial a couple of years ago on ERAPM, and I always said that looking at your patient is a good thing, and it's also very important in regional anesthesia. And probably looking at your patient makes the whole process so much more safe. And that also means that probably regional anesthesia is also very good for trauma patients, where you are sometimes afraid of compartment syndrome, but actually looking at your patient while providing regional anesthesia is also safer. So it also has implications on other research. And to conclude, because these were my top 3 papers, to conclude, I will give you 2 papers which I think are a little bit in the same margin, and these are my runner-ups. I think the peripheral nerve stimulation for chronic pain, which is a systematic review by somebody who you should keep an eye on, Ryan D'Souza. He's an upcoming big name, I think. And they looked at the implementable peripheral nerve stimulation for chronic pain, showing that it is, in fact, a very, very good system to reduce your chronic pain. Now, eventually, we have a systematic review showing the real benefit on that. And in the same light, I would say the percutaneous analgesic device enabling both local anesthetic delivery and electric stimulation by Brian Ilfeld and Sanjay, who developed the catheter, is actually because the other paper is on chronic pain, is actually the idea of using it for acute pain, which is more in my interest. So I think these papers show the future, and I think electrical stimulation is the future, and I'm very, very interested in more research on these things. And I have to keep it short. And I think actually keeping it short is sometimes also much more comprehensive. And you will have the QR codes here. And please, all these articles which I now discussed are actually free of access, and the QR codes show you the link to where you can see them. So I hope you will enjoy the rest of the World Day of ESRA, and I'm pretty sure it's going to be an amazing day, like it was last year as well. So to Europe and the whole world, because more than Europe, there's a lot of other centers joining in. Please enjoy the rest of the day, and regional anesthesia is a fantastic thing. Thank you very much. This is Steve.
So, thank you very much to Steve there. It's great to hear his thoughts on what are the best regional anaesthesia and chronic pain papers from the year. We're really pleased to have Professor Graham MacLeod with us here today at the Newcastle event. He has come all the way from Dundee, and he's going to talk to us about innovations later, so stay tuned. He was Steve's #1 paper of the year. So we're now going to hear from another colleague of ours from the UK. This is Dr. Rosie Hogg. Rosie runs the POCUS workshops at the RA UK meeting, and is a general all-round POCUS guru. So it's really interesting to see what papers have been shaping her practice over the last year.
Rosie Hogg from Belfast in Northern Ireland, and it's great to be with you all today on this third World Day of Regional Anaesthesia and Pain Medicine. So I'm going to spend a little bit of time with you talking about some point-of-care ultrasound papers that you may have missed in 2025. So even if you're an experienced user of point-of-care ultrasound, or you've never done anything at all to use this in your clinical practice, I'm hoping that these 4 papers will give you a taste of why I think point-of-care ultrasound is so important in our day-to-day clinical practice. We haven't got a lot of time, so let's get started. So the first paper I have for you is this one. So it's a single center study of 72 parturients, and this was in IJOA last year in 2025. And what it was looking at was the number of patients that you can get really good images for clinical decision-making, not just using the phased array transducer, which is what we commonly use for cardiac point-of-care ultrasound, but actually using a curvilinear probe. So something that you would have on your obstetric unit all the time that the obstetricians would be using. And why is this important? It's because many of our sites don't have a phased array probe to use, particularly in obstetrics. But as patients are getting older, they're getting larger, they may have other cardiovascular comorbidities, it's really important that we can do cardiac POCUS on these patients as and when we need to. So other secondary outcomes in this study looked at the comparison of the 5 point-of-care ultrasound views that we use in cardiac focus. So this is focused ultrasound, trying to get these 5 images and getting yes, no answers to questions. And as you can see here, you can actually get some really nice views using the curvilinear transducer. And we often think this isn't possible because it's got a larger footprint. But this study showed that you can actually get some good views, of course, dependent on the patient. So what was found here? So looking at these individual cardiac views, they were really looking for non-inferiority, in particular which views were easier to get than others. And throughout this study, what was shown, and these were in residents who didn't have a lot of cardiac ultrasound experience, is that in certain views, particularly the parasternal views, using a curvilinear transducer was actually non-inferior to using a phased array transducer. But this was particularly in those parasternal views. And I just want to highlight that actually in the apical and subcostal 4 chambers, the views weren't as easy to obtain. And you can imagine, particularly in that subcostal view, it's going to be difficult in a pregnant patient. And again, in the inferior vena cava view, there really wasn't a non-inferiority established there. But what about measurements? Because we quite often like to measure in cardiac POCUS as well. And actually, in quite a few of the images that were obtained by these people who didn't have a lot of cardiac POCUS experience, you were able to get some good measurements, but only if you got the view. So in particular patients that you were able to get a good view with the curvilinear probe, you were able to do a number of different measurements. And this is going to be really, really important for if you've got a patient on the labour ward who's particularly unwell. So what's our key takeaway from this study is that anesthesiologists with limited experience in cardiac echo can actually achieve clinically useful focus assessment in over 90% of proturients using a curvilinear transducer, but this is particularly in the parasternal views. So this is a great study to show that even if you don't have a phased array transducer on your obstetric ward, you can, in many patients, able to achieve maybe 1 or 2 views to give you that extra clinical information. But again, for measurements or obtaining other views, a phased array probe is recommended. And I would say that if you can get another probe for your labour ward, definitely get a phased array probe. So this is a bit of a whistle-stop tour through some of these papers, but it's just really to give you a little highlight as to what's out there in the POCUS world at the minute. So here's another study, and I thought this was really interesting because it was looking at the prevalence of ghost scans in point-of-care ultrasound for trauma patients. So you might be wondering, what's a ghost scan? So a ghost scan is whenever you scan your patient and do your POCUS assessment, but you don't record that assessment anywhere whatsoever. So this looked at 4 level 1 trauma centres across the Northeast USA, and it was a retrospective chart review of over 6,000 patients. And as you can see here, there were 4 different sites, all of which had a similar number of site visits every year, but some did a lot more POCUS with 20,000 POCUS examinations per year, but all of them did a significant amount, with the lowest just being 7,500. And again, these are sites that have emergency resident programs to be able to train in POCUS as well. So what did they find? Well, the really interesting thing in this study was the variation across the number of sites. So these were the percentage of ghost scans and the difference between if there was blunt trauma or penetrating trauma. And again, when they were doing the scan they were doing here in particular was the fast scanning. So that's looking at a number of different areas to see whether there's blood in the abdomen or free fluid. So you're looking particularly around the liver, the spleen, the bladder. And again, it's the variation across the sites that's really, really interesting here. And one of the things that came out was why there was the variation across these sites, or sort of thinking about why it was. So at site 1, they required a specific login. So this can be difficult to access that, especially if you're in a hurry in a trauma situation. At site 2, where you can see there was a lot of ghost scans, there was no POCUS image manager. So that meant it wasn't very easy to link between the electronic medical record and the POCUS scans that you're taking. In site 3, which you can see had the lowest number of ghost scans, there had been a quality improvement initiative here to try and reduce the number of ghost scans. So there was regular emails sent around to remind people, and also there had been a yearly review of how many of your scans you hadn't uploaded to the system. So it's simple things like this which are really good. And what was really interesting at site 4, where there was a huge percentage of ghost scans, one of the biggest problems here is that there were lots and lots of different people recording scans. So there were trauma residents and surgical residents and ED residents. And again, there wasn't that sort of consistency and the sort of culture of reporting. So why does this matter? Does it matter when we take a scan if we don't record? Because many of us, when we're doing nerve blocks or doing POCUS, we don't always record our scans. But sort of going forward from here on in, I think it's really important that you do record your scans. And the reason for that is that it's got actual implications for patient care, because if you've done a scan and then you want to review again and you haven't got the previous scan, you've nothing to compare it to. And in many countries, you're going to lose your billing opportunities because you can bill for the POCUS scan, or you can actually add to your department's kudos and things by doing this sort of thing. And if you can't produce those scans, you're going to lose those opportunities. And I think most importantly as well, you may increase your medical legal risk, because if you've made a decision based on one of these scans and you've got nothing to prove it, it's going to be really difficult to stand up to that. So the key takeaway from this is record all of your POCUS scans, be it ideally to your electronic medical record, or record them somewhere anonymously, but be able to link to the patient. So here's another study that came out in 2025 that you may have missed, which I think is a really interesting one. So again, it's looking at cardiopulmonary point of care ultrasound. So this is using both cardiac and lung POCUS to be able to make a differential diagnosis in patients who've arrived to the hospital with shortness of breath. So what I thought was really interesting about this study is the primary outcome was actual hospital length of stay, which is really important for both patients and for the hospital system itself. And secondary outcomes were total direct hospitalization costs. And of course, this will depend where you are in the world. But again, length of stay for patients, getting patients up and going and getting them home again is really, really important if you ask a patient what their patient-centered outcome would be. So this is a large single US tertiary center, and there was 5 internal medicine teaching teams. What was interesting about this study is that the images were reviewed by cardiologists, and the scans were done by a team of people who were quite well trained in POCUS. And I think this is one of the really interesting things. But what did it show? So there were about 208 participants in total. And as you can see from this, they're fairly similar in the groups. And they had a number of different cardiac conditions, a number of different comorbidities, but they were quite similar across both of the groups. So these are patients just presenting to the hospital needing treatment for undifferentiated shortness of breath. And what came from this study? Well, the thing that was really interesting for me was that there was an over 30% reduction in the expected length of stay when using POCUS, which is kind of a crazy number, isn't it? Because it reduced the mean length of stay from almost 12 days in the control group to just over 8 days in the POCUS group. So that is a massive difference to not just your hospital, not just to the system. You know, in many places we're struggling with beds, we're struggling with getting patients admitted to the hospital. But there's 246 hospital bed days saved overall in this small group. But again, there was no increase in 30 or 90-day readmissions, with a direct savings cost of over $750,000. So this is applicable across the world to any site that you're working on. And the main thing from this is, I think, it's that you're getting the diagnosis really, really quickly, and you're able to treat that patient. You know exactly what's wrong with them. You know if it's heart failure, if it's a pneumonia, you're able to diagnose that really quickly. But not just that, you're able to treat and then rescan again. And that's what's really, really interesting about point of care ultrasound. So the key takeaway from this is that POCUS is associated with a shorter length of stay and lower costs. But again, they really highlighted the need for more training and integration, because there was only about 20% of the hospitalists in this particular hospital that were able to do POCUS to this level. So what we really need to do is focus on training and integration in clinical practice, because we've seen again and again from these papers that there's a definite improvement in patient-centered outcomes. So I don't have a lot of time to spend with you today. Honestly, we could have spoken about 20 different really interesting papers, but I just want to highlight one more paper that's really, really critical that came out last year in RAPIM. And this is from Stephen Haskins and many other fantastic POCUS enthusiasts across in the US. And this was the ESRA PMedicine narrative review on gastric point of care ultrasound in more complicated patients to assess aspiration risk. So gastric ultrasound is about the most exciting thing of point of care ultrasound at the minute. You know, with all the GLP-1 agonists and patients getting more challenging, it's really, really important that everybody is able to do this very straightforward technique to be able to assess whether a patient has got any residual gastric contents and assess their aspiration risk. So this narrative review looked at assessing the gastric contents in the highest risk patients, sort of medically complex patients. And this is just a quick infographic, and it showed that there's really good support for doing gastric point of care ultrasound in diabetic patients and patients that are in active labor. So there's lots and lots of evidence to say that it's really important that we should be doing gastric POCUS in these patients, because there is a risk of a higher increased risk of residual gastric contents. There was, interestingly, conditional support for patients who are taking GLP-1 receptor agonists, even though we're seeing lots and lots and lots of papers and lots of discussion about this. And that's really just because the evidence isn't there yet. And again, for obesity, emergency surgery, or patients who've got NG tubes. And I think the conditional support part of this is really just reflects the lack of evidence. And gastric ultrasound is something that we really need to be doing more and more studies in. The problem is obviously because aspiration is such a rare event, you would need to review millions of patients to be able to see whether a gastric ultrasound reduces the risk of aspiration. But what it really does for me, it gives me a patient by patient personalized assessment of their gastric contents. And honestly, once you start doing gastric ultrasound and you see that patient, particularly the patient who's coming in for emergency surgery or the patient who's taking a GLP-1 receptor agonist, and you see those increased residual gastric contents, you'll want to do it on so many of your patients. And this paper particularly supports doing it in a number of different patients. So again, gastric ultrasound is rapidly becoming an essential tool for patient assessment and clinical decision-making, particularly in these higher risk patients. So thank you for listening today. That was very much a whistle-stop tour through some of the most interesting papers that I've seen in the last year. I've added the QR code so you can go and read these papers yourself. But I'm really glad that you've joined us today for this World Day of Regional Anaesthesia and Pain Medicine. It's wonderful to have so many people from across the world. And I'm really glad that you're all so interested in point of care ultrasound. And you're going to hear a little bit more about our first ESRA point of care ultrasound course. But look all around the world, there's lots of point of care ultrasound training going on everywhere, and make sure you use it as much as possible. Thank you.
So thank you very much to Rosie Hope from Belfast. Amazing review of recent POCUS papers. If you want to hear more from Rosie, she'll be running the POCUS workshops at the RA UK meeting in Bristol, which is on the 7th and 8th of May this year. So come along, and Rosie will be teaching there along with Professor El Bogdadli. So that will be an amazing event. Next, we have a Dr. Pablo Zamora. Pablo works with Andre Kroll down at St George's in London, and he'll be talking about recent papers shaping phantom limb, the treatment of phantom limb pain.
Hi everyone, thank you for having me here. My name is Pablo. I'm an anaesthetic trainee and a pain fellow in South London. And it's an honor for me today to be presenting Needles in a Haystack, my review of top papers for phantom limb pain of 2025. And also a big thank you to Dr. Kroll, my mentor, who has been supporting this project. Phantom limb pain remains relevant in 2025 because it's the invisible epidemic. Literature tells us that it has an extremely high prevalence. In some cohorts, up to 90% of the amputees suffer it. It's chronic, intractable, and there's no right way to treat it. There's no standard. However, it does have a major impact in quality of life. You're taking previously functional members of society that go through a traumatic event and may never go back to their baseline, which is a huge toll in their mental health, and eventually it also becomes a healthcare burden. However, 2025 did deliver some new and interesting progress. The first paper that I bring today is the relationship between neuromodulation, pain, and depression in patients with phantom limb pain. And it's a systematic review and meta-analysis where they analyzed and identified 56 papers out of all of the literature and kept 17 RCTs with the inclusion criteria of RCTs, adults, and phantom limb pain in the non-acute phase, a total of 510 patients. And they divided neuromodulation into two groups: central, that had 10 RCTs, and peripheral, that had 7. More interestingly, only 2 for peripheral nerve stimulators. And they looked at 2 primary outcomes: pain, all 17 RCTs looked at that, and depression, Only 3 of them looked at that, and they were mainly about central neuromodulation. And what they found was causation, a significant pain reduction in patients that underwent neuromodulation versus control. And they understood clinically meaningful effect as a reduction in the VAS score below 1.4 points. Overall, neuromodulation reduced VAS score by 1.6. Central neuromodulation, mainly stimulating area M1 of the brain, reduced in TMS by 1.4, direct current stimulation by 1.6. And in peripheral neuromodulation, PNS had a great effect, nearly 1.9. On the contrary, TENS was just about 0.46, not clinically meaningful. And furthermore, they found no relationship between depression and central neuromodulation. So this study has some interesting strengths. It's a multi-technique comparison. Sensitivity analysis suggests a robust pain signal reduction. However, there are limitations. These RCTs tend to be small and heterogeneous, and they only focus on the short-term data. However, there's no standard of delivering this modulation. Parameters and targets are all over the place, which makes it very difficult to replicate their results. So in conclusion, dose and duration matter. And we see this mainly in central neuromodulation, where the bigger the frequency and the more regular the sessions, the bigger reduction in VAS score. However, there's no standard, as we mentioned. So everyone does a different technique. Peripheral neuromodulation, mainly PNS, seems to be more effective. However, there were only 2 RCTs identified, despite a growing body of observational studies. There's no clear effect on depression. There's no clear strong evidence for invasive modes yet, such as SCS. So we've seen that neuromodulation can reduce the intensity of phantom limb pain. But this is when phantom limb pain has already appeared. What can we as anesthetists do to prevent this from happening? Can we stop the appearance of phantom limb pain? And it seems that the answer may be yes. In our center, we've been inserting perineural catheters for more than 20 years, working behind the hypothesis of the amputation happens, a perineural catheter is inserted at the end of the procedure with the intent of reducing the acute pain after the surgery, therefore potentially reducing the central sensitization in hopes of reducing phantom limb pain. And there's a growing body of evidence, mainly observational studies, case reports, cohort studies, but there are very few RCTs. And in 2025, they analyzed the effectiveness of this. They created a systematic review where they identified 357 studies, but in the end, only included 1 RCT in evidence synthesis. In this study, they had 144 patients and they left the perineural catheter for 6 days. And what they saw at 4 weeks was a significant reduction in phantom limb pain intensity. The mean pain reduction was around 1.5 points in NRS scale. And also, it went hand by hand with an improvement in the functional impairment. Authors classified this evidence certainty as moderate because it's a single study. So in conclusion, perineural catheters are a potential therapeutic option for phantom limb pain. Current evidence, however, is limited but supportive because, as we've just seen, there's only one RCT looking at this, but there's, as I mentioned, a growing body of evidence of cohort and observational studies supporting this practice. And as I said, we've been doing this for 20 years in our center. It is our standard of care, and we normally audit our findings and our results regularly. And this year, in 2025, we published an abstract of our audit, where we did a retrospective observational audit of 40 below-knee amputation patients that had their operation 2 years before. So addressing the gap of knowledge of short-term outcomes, looking at long-term outcomes. These patients had had their catheter left in for 7 days with a continuing infusion of local anesthetic, and we surveyed their pain at 2 years and also their quality of life. And with the results, we saw that, unfortunately, around 30% of this population had passed away. This goes in line with what literature tells us to expect. And out of those survivors, more than 50% agreed to participate. And the results were interesting. Around 90%, so 14 out of the 16 patients, had no phantom limb pain. What they did complain about was about stump pain, and this was around 50% of the population. And when they complained about their stump pain, was due to the prosthesis use, or that the fit wasn't good enough. And those that complained about phantom limb pain, so 2 out of 16, they said that it wasn't quality of life limiting. Therefore, it could be classified as phantom limb sensation. More interestingly, there was an 85% reduction of analgesia requirements down to first step of WHO pain ladder even. And obviously, there are limitations. It's a small sample size, it's not an RCT, there's no control group, but because it's also standard of care at our center, it's a retrospective design, and we lost some patients to follow up. However, it does add, as I mentioned, to the conversation. It does add evidence to this growing body that we said. So what does 2026 have for us for phantom limb pain? There are very exciting RCTs going on. However, 2025 gave us a glimpse of what may be coming. We saw a prospective pilot case series of a new device, and as anesthetists, we love new devices that can deliver a single shot block, a continuous infusion, and can modulate the nerve at the same time. And this was in an acute pain setting, looking at ambulatory care in moderate to severely painful surgeries. These catheters stayed in for 7 days and went with the patient home. The main focus wasn't an efficacy trial. It was a feasibility and safety trial. However, what they found was that the average pain for 7 days was 2 in NRS scale. And the worst pain was less than 5 after the first day in most patients. And the average of oxycodone use for the whole week was around 43 milligrams. And it has limitations. No control arm. We don't know what's working. Is it the local anesthetic? Is it the neuromodulation? However, the take-home message here is that it is promising new pain technology that is coming. And it also potentially, it could open new possibilities to all these conditions that we know that in a chronic setting, we can modulate them, we can prevent it. And for those conditions that are in an acute setting and can chronify. So overall, 2025 has left us with some answers. Phantom limb pain may be preventable and treatable, but we as an anesthetist have a key role in this, and it starts at the very beginning in the OR for us. We can start very simple. We can try and avoid it from happening. Think about regional anesthetic. Think about using a perineural local anesthetic catheter. The evidence, slowly growing, is there. And when it happens, we know that neuromodulation is a proven non-invasive control option for phantom limb pain. And lastly, new technology may open new frontiers in 2026. Thank you, and happy World Regional Anesthesia and Pain Medicine Day.
So thank you very much to Pablo for a very interesting talk. Amazing session. We've given you some live scanning and some pre-recorded videos. Please join us back at 11 o'clock when you'll hear from Professor Graham MacLeod, this year's RAUK Bruce Scott Lecturer, and he will be talking about innovation in regional anaesthesia. Please join us at 11 o'clock for our next session. Thank you. Welcome back, everyone, to our second session of the day. This is, I'd like to introduce Dr. John Womack. He's an RA UK board member and consultant anaesthetist at the RVI in Newcastle, and he'll be your chairperson for this coming session. So, John, over to you.
Thank you very much. So this session has got the intriguing title, The Power of Three. So I think that's because there are three different components to it, and the first component is going to be Professor Graham MacLeod. So Graham is a professor in Dundee. Worked at Ninewells, or works at Ninewells, and is one of the UK's leading researchers in regional anaesthesia, particularly in basic science and conversion to clinical work. He also has run cadaveric teaching for a number of years in the in Dundee, an excellent cadaveric facility with one of the only places with teal cadavers in the country, and was involved with the UEA MSc for very many years as well. So it's a real pleasure to have him here, and he's going to talk today about new technology in regional anaesthesia, which is really his special area of expertise.
Thank you very much, Jonathan. I was going to give a little history lesson to start with. This is Galileo. Now, he is a very famous astronomer, and he was the first individual to discover the 4 moons, big moons, going around Jupiter. And they're called Io, Europa, Ganymede, and Callisto. You've probably heard of them. And there was a mission 30 years ago named after Galileo, and in fact what they did is they sent the spacecraft straight into the middle of Jupiter. Now, he wasn't too popular. His big mistake was bringing out something called the Starry Messenger, for which he got in trouble with the Pope, no less, and was called a heretic. He gave up for about 10 years, then got back to his first love, was just trying to show that the planets actually revolve around the sun. And it was eventually tried and confined to his house, and this is in a little village just near Florence. In actual fact, he was a real innovator, because now, at the last count of yesterday, there were 97 moons going around Jupiter. And this little picture on the right is tracking all these moons, and it shows that, in fact, what you see in the sky, like ultrasound, is not necessarily all there is to see. If you go up to the hinterland of Northumbria, you will see open skies and things that you will not be able to see in the middle of Newcastle. And therefore, it should be remembered that what we see on an ultrasound isn't real anatomy. It's actually a surrogate of that anatomy. It's a picture which it guides you, but it is not everything that actually goes on. So so I can take 2 things from Galileo's work and what I do, is that you really have to look at reality before you start designing things. You have to look lower and lower, smaller and smaller, get to the microscopic scale. A lot of engineering now is very microscopic. You cannot simply go on personal opinion what you actually think. You have to have the data. When you go to the engineers, they have to be convinced of the basic fundamental first principles that you're actually using here, and only then will they take that idea on and innovate. The other thing is that innovation should be completely and utterly disruptive. There's no use just wanting a little bit extra here and a little bit extra there. You've really got to shake things up absolutely, completely, for it to make any real advance. And if you look back at anaesthesia, what are the things that really worked? Well, I suppose the laryngeal mask, TIVA, and ultrasound. But other than that, there's nothing really else which has been completely disruptive. The problem at the moment, of course, is trying to convince people that there are things beyond the ultrasound. And based on ultrasound and basic science papers in the last 20 years, there are assumptions being made by many of you as to what is actually going on. For example, this is a picture of a median nerve, and there are black things within that nerve which individuals think are fascicles. They're not. It's just an aberration of the ultrasound. It has no relationship whatsoever to this underlying histology. We also think that local anaesthetic flows unimpeded towards the nerve, and that injection should occur at a tangent to the nerve. Well, we would actually disagree with that, and moreover, if you touch the nerve, well, you're in big trouble because it's clearly going to damage it. We assume that there's going to be uniform expansion in the nerve after intraneural injection, and that this causes high pressures, particularly by injection into fascicles. Moreover, the dye studies using India ink, which is actually water-soluble, not lipid-soluble, apparently indicate intrafascicular injection. We would actually argue against all of this, and you have to do that in order to invent new technology. So I'm delighted to say I work with Miguel Reina, who's professor in Madrid, and Andrew Bozart, who's now emeritus professor at University of Florida, Gainesville, and our team has produced several papers in the last few years looking at the micro-ultrasound and high-resolution histology of nerves, not just statically but also dynamically as we inject mainly into anaesthetised pigs. And what we've actually seen is that the nerves are actually surrounded by adipose tissue compartments, and that the local anaesthetic in the main remains within these compartments, and it's the changes in bioavailability of the local anaesthetic into fascicles from these compartments that actually determines the quality, the onset and duration of the block. In other words, from a macroscopic point of view, you may think that you're actually injecting perfectly, but from a microscopic point of view, using micro-ultrasound, you may be in one of, oh goodness, beg your pardon, one or two or three compartments, and that's the slide in the middle but below. So we don't really know where we're actually injecting the local anaesthetic, and this provides the engineers with a real challenge as how to actually combat this problem in order to improve the accuracy, reliability, and ultimately the predictability of regional anaesthesia. The other things that we've found are that on the left-hand side, we've found in fact that there are perineural invaginations of the fascicle into the fascicle from the perineurium, which are give the impression of intraneural injection, but with using India ink, but in fact aren't, using heparinized erythrocytes, which are these tiny red things that there's tiny red things, there's number 7 on the far left-hand slide, actually shows these erythrocytes which are, when injected into the fascicle, actually remain within the perineurium, but do not actually enter the fascicle at all. And therefore what we feel is that because the needle is 3 times the size of the average fascicle, it is almost impossible using a block needle to actually inject into a fascicle itself. Now this work was done initially by Salablanca and isolated cadaver specimens of nerves, and we've just repeated it. The one situation is in the middle, is when the fascicle is more than twice the size of the needle orifice. And that obviously occurs in the nerve roots coming out the neck where there may be 1 or 2 fascicles. The original studies by Hadjic actually were done on dogs, and what we've now realised is that the dog only has 1 fascicle, whereas pigs actually replicate the Coumadin condition much, much better. So that's why this theory of intra-high injection, intraneural pressure injection, is where it comes from. but in fact we think that in pigs and probably in humans, that what happens is that the needle goes into the nerve and the nerve bundles actually rotate, and it's actually extremely difficult with nerve block needles to actually enter that fascicle. On the other hand, if you use a sharp needle, sharp bevel needle, that's an entirely different thing, and that can actually impinge on a fascicle. So, what other technologies do we have? This is a little favourite of mine. This was developed by LightSense in Switzerland. The inventors are Saporito and Capdevia, very, very well known, and they use a Fabry-Pro interferometry technique, which consists of a fibre optic with an air-filled diaphragm at the end, and light as the fibre optic is placed inside the needle, and as the needle actually encroaches upon tissue or the nerve, that the diaphragm is bent and the light actually changes, and from that you can then measure the pressure at the tip of the needle, not in line. What this means is that this pressure at the tip is actually accurate and gives us an idea continuously of what the pressure changes are and where that needle may well be. Now, there's a recent paper that's gone into REPN from the same group, which has shown this an extremely sensitive tool and may well be able to indicate intraneural injection very quickly. So I would imagine that this will become commercial in the next few years. On the other hand, old as I am, I was actually trained in paresthesia and then on nerve stimulation. And just a shout out for nerve stimulation, which I've gone completely back to, because I think it gives me better accuracy, and what's more, actually tells me what nerve I'm actually dealing with. I inject between 0.2 and 0.5 milliamps, and I must say I'm getting very good results, and I'm at the stage where I'm advocating both the combined use of ultrasound and peripheral nerve stimulation for motor nerves. Another innovation is something we've done, which is just been published in the British Journal of Anaesthesia, which tries to deal with the problems of epidurals. As we all know, thoracic epidurals are particularly difficult to do. They have about a 20% failure rate. So what I thought is that actually, given that the fact that ultrasound is still quite difficult at that particular level, why not actually create a 3D image of the anatomy, superimpose it on a cadaver, and then test it in two different groups, one using the hologram and one without, and see what the differences actually were. Now, if this it hasn't actually, I was going to show you a video, but unfortunately it's not going to run. So this is the study design, and we recruited from consultants, senior trainees, and junior trainees from 3 centres: Aberdeen, Dundee, and Edinburgh. And funnily enough, and repeated the insertions at 10 different levels to get a dose response curve, to get a learning curve. And surprise, surprise, we actually found there was no difference at all between any of the groups, other than with regard to global rating scores, other than the degree of hand manipulation that was going on in the hologram group. Those using the hologram, half the number of hand manipulations compared to those not using the hologram, which in many respects is okay, it wasn't the primary endpoint, but actual fact would be good for patients. Nevertheless, what we did find is that there is a cohort of individuals who, now if I could somehow play this, I don't know whether it will this thing play?
Yeah, and then
yeah, there it is there. There is a cohort of individuals in the upper quartile who had particularly bad technique, and their hand movements ranged from about 8 to 71, putting in these thoracic epidurals. On the other hand, there was a cohort of a quarter of individuals who could put this in very, very easily within 2 or 3 hand movements. So there quite clearly is a difference in technique and abilities within anaesthetists regarding thoracic epidurals, but no difference, I would emphasise, between level of training. So that is one thing that we're looking at, and I think does show potential, but it really depends on the demand and whether or not people are going to keep putting thoracic epidurals in or not. So the other things that we're doing, we're looking at clothing, we're looking at wearables, and this is a paper we brought out from Heriot Watt, whereby we're looking at the strain of a strain clothing that can fit over, it's a sock that can go over your calf, and you can measure the strain and distension of the calf with compartment syndrome. On the right I must admit, I have an interest in this because I'm part of the patent, but this was a coloured needle which vibrates at 20,000 hertz. You can see on the cadaver, but hasn't really been it's been sold to a company down south, and guess what? They're now using it for removing tattoos. But it just shows you that innovation doesn't necessarily go in the direction you actually want it. This is another example of another type of innovation which we developed, and this is hip fracture modelling. This is using the power of R, the power of new digital technologies. It's called R Shiny, and it's called a digital nomogram. So let's just see what we can do here. We've got a whole variety of things like female, age, BMI, white cell count, lactate, creatinine, and that's for a fractured hip. And if we could see if we could try to, no, that's not working, typical. I'm sorry about that, but that was actually supposed to actually provide you with a prediction plot for an individual within confidence intervals, looking at mortality after fractured hip. But nevertheless, it gives you an idea of how we can actually start to individualise patient care with technology based on data from huge databases, as is what we have in Dundee. So, apologies for that. So that's the end of the talk. So in summary, innovation and technology is booming in surgery at the moment. I think it's important that as anaesthesia we actually follow. I'm actually lucky I work in a technology university in Heriot Watt in Edinburgh as well as in Dundee, where there are very interested engineers who are interested in regional anaesthesia. They see it as a real challenge. The idea that you can go from point A to point B and get it right every single time, that they are doing that in robotic surgery just now, and they now want to apply it to regional anaesthesia. So I think the future is bright, and it's very exciting. Thank you.
Great, thank you very much. So next up we've got a video from two big personalities in regional anaesthesia. One is the ex-ESRA UK president, once removed, Amit Power, and it's a transatlantic debate, so his opponent is Jeff Gadsden, who they both present the Block It Like It's Hot podcast together, so I'm sure this will be entertaining. They're going to talk about the use of AI in regional anaesthesia.
Welcome everybody to World Day of Regional Anaesthesia and Pain Medicine. I'm Amit Power.
And I'm Jeff Gadsden. We are so delighted to be here to share our thoughts on artificial intelligence and regional anesthesia here with you on World Day.
Now, Jeff, this is one of our kind of podcast-inspired episodes, so am I allowed to start with a joke?
Oh, listen, time is a bit short, so let's keep the jokes on the, keep it a bit minimal if you can.
Well, I never miss an opportunity to get a joke in somewhere. Does that count?
God. No, man. Why?
Okay.
Well, listen, let's move on. So I want to talk about AI, and I want to talk about the role that AI in ultrasound imaging can help us, how it can help us and stay safe, be more precise, improve quality and efficacy. The question I have is what is the problem that AI is promising to help us with? Is it safety? Is it precision? Is it learning? What do you see the role of AI?
Well, I think we know from, if I think back to my early days of learning regional anesthesia, one of the things that we teach everybody is pattern recognition. You'll say you stick the probe on the neck, and you're looking at interscalene brachial plexus, you want to see two ovals and a triangle over the top, and you look for the gap in between, that's the interscalene groove. You say that to somebody, but whether they can take that home with them and remember and interpret that on the screen. So I think it helps us with pattern recognition. It's sort of, you stick the probe on, you try and make sense of what's going on, and you turn on the artificial intelligence device, and it will immediately help you identify the pattern. So I think pattern recognition is important, but the other thing it does is it helps you get to the endpoint faster. I can think of when I first started scanning, I stuck the probe on, and I took ages before I could identify structures. And when you're working in a time-pressured environment, that can be an issue, right?
Yes, absolutely. So I do think, I've always said there's two main skills in regional anesthesia. One is pattern recognition and one is driving the needle. And this helps tremendously with that first one. So we see trainees come in and, like you said, you'll put the probe on and it takes you a good 3 or 4 or 5 minutes to, explain this is this, this is this, this is this. Imagine if you could start with that and then paint over top and say, see? This is what the computer thinks, and this is where all the structures are. And what I like about a lot of these models, it's not just the nerves, it's the muscles, it's the fascia, it's the pleura, it's the vessels, those sort of things. So it really, I agree, it helps to accelerate that pattern recognition database in your mind.
And when you think about the learning curve, I think about the number of blocks I had to do before I felt that I was competent. Maybe it took me 50 attempts or 50 blocks to get good at remembering, how to do the interscalene brachial plexus block. I'm sure it probably took you the same amount, or maybe less. I don't know.
It took me 8.
Yeah,
I'm just kidding. No, it is
whatever. I mean, you're
but your point is well taken. I mean, it does. It takes time. To build, because nature throws a curveball at us once in a while, and there's the structures that are just outside the 2 standard deviations away from the norm. So you get a nerve that's over here, and a blood vessel looks a little bit different. And what the crazy thing about this, a lot of these AI models is how sophisticated they are at determining that yes, that's a nerve that doesn't live there normally, but actually is here, and it gets it correct. So it's a testament to the number of scans that have been fed into these models and then validated by actual human beings.
I think, and again, these devices are only as good, or the software is only as good as the number of scans that have been fed into them. So I think that's a really important point. I'm also trying to think about the reality of doing a list. So if you get one of those patients who has slightly unusual anatomy, or you're at the beginning part of your learning curve and you've gone to a course, you've learned how to do something, and then you're trying to translate it into clinical practice, if you're taking 15 or 20 minutes to identify those structures or build up your confidence in identifying the structures, that can have an impact on productivity and throughput of the list. So potentially something that can reduce your cognitive workload and make you identify those key structures quicker, I think has a big advantage. And that's where I think it has a role. Pattern recognition, shortening your learning curve and increasing your productivity, and the speed with which you identify nerves and fascial planes, that's where I think it's really advantageous.
I'm glad you mentioned that, because I think sometimes we're at risk of putting a tool like this into the bucket of, that's just for teaching environments. But I don't think so. I think this has universal appeal, because in a busy private practice where there are no learners, you still have to identify the right structures. And if you're doing 20 blocks a day, here's how I see this happening. You put the probe in the skin, you say, okay, I got a sense of where things are. Let me just confirm right before the needle goes in if I think, if what I'm thinking is correct. And I think that has a lot of merit in terms of, finding out some potential aberrant anatomy and or just confirming that, hey, you know what, I was right about that, and that gives me a bit of confidence to proceed safely with this block.
It's confidence and it's like a sense check. Yeah, I knew I was right. But also, if it shows you something that's a little bit unusual or you weren't expecting that, you should then start to apply some anatomical interpretation, some clinical judgment, and trying to say, well, does that make sense? Have I missed something, or is the system wrong? We all sound very positive about artificial intelligence and regional anesthesia, but clearly there must be some risks. Do you see any risks with this particular technology? Because I'm nervous about some things. What are you nervous about?
I think the biggest risk is that I'm going to be furloughed and sent home to relax while this.
So you're worried that you might lose a job.
No, I think it's a tool. I think it will help me do my job even better than I was doing before. So, but in terms of risks, I think the biggest risk that is quoted about this is that it's a crutch, and it's something that, you know, if left unchecked, and not done in a thoughtful way, intentional way, maybe a learner could get through his or her training and be reliant on the computer interpretation rather than use it as a confirmation. Do you know what I'm saying?
I do. I think if you've only ever learned regional anesthesia and then had this extra tool there to support you, and then you suddenly go somewhere where it isn't there, you might feel uncomfortable. But do you know, does that remind you of anything? I'm trying to remember when ultrasound was first introduced for placing central lines, right? Do you remember those guys are like, oh, it's not very good to use ultrasound because then you'll forget the old ways. I wonder in regional anesthesia whether artificial intelligence, we're going to be saying the same thing about that. You know, if in 20 years' time we've got a system that doesn't have artificial intelligence, we'll be thinking, oh, we're doing something wrong. At the moment, we're nervous and we're scared about change. So anything that's different or new makes us feel a little bit on edge. But I wonder whether in a few years' time it will be essential to have some of this stuff integrated. I don't know. I think over reliance on a tool and then suddenly finding you're somewhere where it's not there makes me worried, and I think that's a risk. What about if it labels the stuff incorrectly? Because at the end of the day, it's only as good as the data it's fed. What happens if the AI labels something incorrectly? What do we do then? Because that's something, you know, if somebody blindly follows that tool, that makes me feel a bit nervous. So is that a risk?
I think so, and that's why we need to use this intentionally and thoughtfully. And so when we're implementing this into our workflow, the idea is you're still going to be an expert. We're still going to teach you how to do these procedures as if the AI wasn't there, but it's an additional augmentation of your interpretation. So the AI is not going to replace experience, but what it can do is it can compress that journey from zero to competence, right? So and allowing you to do things safer, quicker. And let's face it, there are now 40, 50 different blocks that
maybe even more.
An expert needs to know how to do. So if it takes you, half the amount of time to do an interscalene brachial plexus block, that other time can be spent learning the next block.
I think you're right. But I can't stress enough how artificial intelligence should not replace us having a basic anatomical understanding of the areas that we're scanning. I think that's probably my biggest fear. So, number one, wrong data. Number two, over-reliance on it. But basically, people don't bother to learn. So they stick the probe on. They say, it's going to tell me where to go. And then you've got blind faith. So you have to remain skeptical. You have to have anatomical knowledge. You're going to say something smart. Go on.
I rarely say something smart, but what I was going to say was, I think actually the tool can be used to highlight and reinforce that need for critical thinking. So you put the probe on, you see what you see, you make an interpretation, then you turn on the AI, and there will be times when those two interpretations don't match.
Yeah.
So I think that will and should prompt a clinician to say, okay, I really do always need to use my own clinical judgment in these situations. So, I think it, rather than being a crutch that you just rely on blind 100%, this is always right.
Yeah,
I think it'll reinforce the need for comparing, and why did it think that was correct when I didn't think so, or vice versa?
Yeah, absolutely. I think there are a few different systems that are available out there, and there are some that are standalone machines that you have to plug and play into different systems. You get two screens, and there are other systems where the artificial intelligence is integrated into the machine. So one of those is the NeuroBlock software that is integrated into some GE Venue systems. Have you used it? What do you think about it?
Yeah, it's amazing. I mean, that's one of the big advantages is it's baked into the system itself. So you don't need another whole box or computer or cable and, oh, the battery's dead, so I got to plug it in, sort of thing. So what's brilliant about it is you get your image you like, then you flick a switch, and up comes the painting on over top of the nerves and the vessels and that sort of thing. So you can turn it on, turn it off, which I think is really critical in terms of using that as the tool in the way that it's meant to be used. Not always on, not always off, but able to flick, 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 flick back and forth.
I'll tell you one of the things I do like about the system, which I think we talked about in some of our other podcast episodes, is you get a quality meter when you're doing the scan. So it gives you an indication of how closely the image that you've generated matches what it says in his logbook. So you kind of, if it's looking like it's not a great image, it will spur you on to try and improve the image. So I think that's quite useful.
Yeah,
and I think you've already.
I'm still waiting for that. I'm still waiting for that voice activation feature where it's like, move that probe 2 centimeters to the right, sort of thing.
Who knows? That may be coming soon. I want to know whose voice they're going to use for that, though.
Obviously, a robot.
Yeah. But the other thing, I think you've stressed it once already, and I think it's really important to say again, if you are going to use these tools to help support your decision making, it's important that you don't have the artificial intelligence on whilst you're doing the block, because then it obscures a lot of the image that you're looking at. So you want to basically have put the ultrasound on, make an assessment of what you think the things are, turn on the AI to confirm what you think is the case, and then turn it off while you're doing the block. You don't want to have the AI stuff on while you're doing the block. But I think there are a lot of potential roles where it can be a benefit. So we've talked about high turnover lists, but what about a senior consultant who's gone to a workshop and is late to learning regional anesthesia? They've gone to a workshop. They were a bit embarrassed because there were lots of younger people there. They've got some skills, and then they want to start doing their first block, their first femoral nerve block, or their first tap block. There may not always be somebody they can ask to cross-reference or to corroborate. So they apply some of that knowledge. That's where it has a role.
I agree. This is a very common scenario. So we teach workshops around the country, and 90% of the people that attend them are over 50.
Yeah.
The people that didn't get to learn ultrasound as a resident, they've had their job for 20 years, but guess what? Now there's a new surgeon that wants blocks, and the hospital is saying you have to learn this, and so this is their mandate. And so the challenge there is, I could teach them all they want for those 2 days at a workshop, but then they go home and suddenly Jeff or Amit's not there over their shoulder. Wouldn't it be great to have this little confirmation that this helps build that confidence? And I think this is a really great use case, which is why I always say, like, I've had people say to me, oh, the AI stuff, that's just for novices, just for beginning learners. I disagree completely. I think there's a lot of role for this, no matter what stage of your career you're at, because it can provide that little confidence boost, especially if you're busy, tired, fatigued, overworked, distracted by lots of other things going on. Putting that image on right before the needle goes in, huge potential.
In a similar manner to the way that we would often say, well, let's put the color Doppler on before we needle this area to make sure there are no aberrant vessels. This is adding that extra interpretation. So I think it definitely has. I don't think it definitely has a role. But also, one of the problems we have in the UK as well is that the level of regional anesthesia training we have across the country isn't uniform. So you might work in one geographical area where there are lots of regional anesthesia enthusiasts, and then you might move to another area where there aren't. And that might put some initial learners off putting or performing regional anesthesia if they haven't got somebody else there to help them. So I think it's quite nice. It takes some education out into the community. So I don't know. I wonder in a few years' time whether you might, in the same way that we're skeptical when ultrasound came out for central venous access, when it comes to AI and regional anesthesia, I wonder whether we might think, hey, you're not doing things properly if you haven't got something there to help you out as a cross-reference. I don't know. It's something to think about.
I wouldn't be surprised. I mean, there's a lot of work to be done out there, for
Absolutely.
sure.
But it's important. We just got to emphasize again. You still have to, as a clinician, you turn it off and you've got to interpret and look at the data, look at the information you're getting, and say, does that make sense? You just don't blindly follow it, because this is like a GPS. So you know the direction you need to go. You're pretty sure, but you're just going to cross-reference with this and make sure it's highlighting the areas that you think. But you've got to then you interpret the information you're given sensibly as well.
Yeah, it's not, to carry on with your analogy, it's not self-driving car. You're not sitting there with your hands behind your head and your eyes closed. It's GPS. It's guiding you. And the AI is confident even when it's wrong. So we need to maintain that skepticism and build our own libraries of what an image should look like in all these anatomical variations.
Absolutely. And listen, Jeff, I mean, AI is not going anywhere, isn't it? I think the future with regional anesthesia definitely is going to include some kind of intelligence, but maybe it's not just artificial intelligence, maybe it's augmented intelligence.
I think you're right. Well, it's been a great chatting with you about AI, and I hope you guys at home really enjoyed our thoughts. If you want to hear more about our thoughts on artificial intelligence or nerve blocks or anything, you can always join us at
www.blockitlikeitshot.com
or scan the QR code.
Guys, I hope you have a fantastic rest of your World Day. Happy World Day. Enjoy the rest of your meetings wherever you are. Take care. Bye-bye.
Great. Thank you very much to the Block It Like It's Hot guys. So next up we've got the Equity Club, which is Kieran Canetti, who is a consultant at Sunderland, who does both anaesthesia and pain medicine, we've travelled across the world together, really, haven't we, Kieran? We've been to lots of places, particularly to some low resource settings, and so Kieran's going to talk about improving access to regional anaesthesia in those. Thank you very much.
Thank you, Jono. Happy World Day of Regional Anesthesia and Pain Medicine, everyone. I hope you are all enjoying the program at home with all the live scanning, the lectures, and also the debate sessions that we got from ESRA. So the next topic, as Jonah introduced, is equity. So do we really have equity in terms of regional anesthesia across the globe? I mean, you just heard Amit saying that even in one country, like advanced Western country in UK, there is a lot of regional favoritism, and sometimes in some areas don't have the same, as you can see in certain areas. So it actually spreads. So what we're going to discuss about here is mainly in terms of access to regional anesthesia and also analgesia, like for pain relief in low and middle income group countries. What about the medication? So WHO essential medicines, and is there access for everybody for them? And how do we go about strategizing for training without use of ultrasound, because that is most of the expensive kit in the whole game. So the key points. First, we have to understand the importance of safe anesthesia and analgesia across the globe. Focus mainly here on this talk is about low and middle income group countries and what are the barriers that they have in accessing this, and then about our practical strategies. So why regional anesthesia matters? I know there is a lot of stigma about regional anesthesia even when I started my training, and that has been changing significantly. And it significantly benefits the low and middle income group countries. Especially it reduces the reliance on general anesthesia and complications and the expenses and the access to medication that are associated with it. It also lowers the perioperative complications and the need for expensive analgesics or inaccessible analgesics sometimes. And it's possibly one of the cost-effective options for many surgeries. What I have to emphasize here is there is a significant global anesthesia gap in this, not just in terms of access, but also in terms of providers. So this is from the WAFSA slide. It's been there for a while. If you look at anesthesia practitioners or anesthetists across the globe, per 100,000 population, the dark green is the one where you have about 20 per 100,000. And even if you look at the graph, there aren't many areas where they have access so widely. And you have on the other side, there are possibly no anesthetists or possibly less than one anesthetist for 100,000 population in the red countries, which are predominantly spread across in Africa and also in the eastern part of the world. Now, in terms of provision of regional anesthesia, there are other modes apart from access to the equipment, like ultrasounds. This is a survey done about 22 by one of our colleagues from the African Society, looking at access to nerve stimulators, which could be one of the measures in terms of delivering safer regional anesthesia. And you could see that nearly 50% didn't know about the presence of nerve stimulators, and some had access to it, but sadly didn't have training to use them, and some were using it in various perspectives. As you might not know, in many countries in Africa, especially where myself, Nat, and Jono have also traveled delivering safer regional anesthesia. In many countries, there are no doctor anesthetists. There are what we call it as the anesthetic practitioners. So the non-doctor, or you can call it nurse practice anesthetists or anesthesia providers, and they're usually catered for delivering safer general anesthesia, mainly for labor anesthesia and things like that. Excuse me for the small slide where it's in small print, but what it actually says here is they are not encouraged to be trained in regional anesthesia because of the risks of being closer to the vital structures, and they're extensively trained for labor anesthesia. So it's important that this shift where they are the primary providers of anesthesia in some parts of the world can be encouraged to participate in this, and that can advance for better. In terms of number of access to ultrasound machines, that's one of the equipment that we have in delivering safer regional anesthesia. So this is a survey conducted mainly looking at access to ultrasound machines in hospitals, especially teaching hospitals, where there are more than 100 beds across Africa. And I don't need to say anything. As you can see, there are very, very fewer machines. And we probably know the reason for that. It's the expense. Then they face the most tragic circumstances in terms of war, or sometimes with the trauma, even providing simple labor anesthesia and things like that, with minimal availability of even monitoring equipment or the provisions that come along with providing anesthesia. And when we listen to them, I mean, these are the common comments that they have. They do not have possibly access to learning. They do not have possibly have access to medication and delivering safer regional anesthesia. So if we look at the predominant one, what I'm talking again and again is about resources. Next comes the staffing or availability of personnel, then training, then we have workload, and some of the time the reason why they cannot provide regional anesthesia is because of the increased workload, and lack of quality assurance or clinical governance, and then administrative problems as such, along with there are beliefs that some people do not want to have or be awake for operations and things like that, and lack of support, along with sustainability. So sometimes they do have some equipment, but it cannot sustain beyond a certain stage. So WHO has got a list of essential medications that has to be updated every 2 years, mainly looking at providing the essential medication across the globe. And most of the countries use this as a guidelines for, guiding them to procure them and also use them. And obviously, it is not supplied without any cost. So, the country's budgets sometimes limit to access these across certain countries. So when you look at essential medicines for anesthesia, in terms of local anesthetics, we have lidocaine along with bupivacaine, and also lidocaine with epinephrine or adrenaline. And for preoperative areas, we have midazolam, morphine, atropine, etc. And for provision of other anesthesia, also you need other medications. So for general anesthesia, we have oxygen along with ketamine and propofol. The next is to continue the safe pain relief in the perioperative period. We also need analgesics. So the commonly available paracetamol and brufen is accessible for many, but there is a limitation of use of opioids, which again, we can take it to the other level, where we have opioid crisis, predominantly in the West, with excess use of opioids. Now, moving on to the next aspect of training without ultrasound. So, what are the limitations? I mean, as I've already said, the main limitation is, affordability, and then it comes to the practitioners. But we do note that ultrasound is beneficial, but not necessarily the training must not depend, or the provision of regional anesthesia cannot be dependent mainly on the availability of ultrasound. So traditionally, as we all learned, landmark-based techniques are still available, and predominantly for spinal anesthetic, epidurals and things, we don't need ultrasound, and that's also part of regional anesthesia. That can be well taught for being used by even practitioners. And then we have advanced equipment like nerve stimulators. Even though we have all used them to an extent, they can be easily accessible and can assist in proper, safer delivery of regional anesthesia. So the 5 pillars, if you look at in terms of strategizing how we can make this progress, first important aspect of is training, or training in a different way possible. Look at you train the trainers, and then that can multiply the training. Equipment, or possibly not just ultrasound machines, and also accessibility for needles, nerve stimulators, and medication. And then slowly build this capacity to multiple levels. So the training can be offered in various ways. Possibly the low-cost, simple one is using simulation and also skills practice, just like what we deliver in many courses. And this can build confidence, especially with on the user side. It can also be done by using remote tools, using online resources, just like what ESRA has promoted in terms of World Day on Regional Anesthesia and Pain Medicine. Can be used remotely, even through the mobile apps and also blog guides, which I have also used for a while. And then having peer mentoring, which we've also done here for a few years now through video conferencing, just to support them locally. So this can possibly help with the support of regional and continental societies, mainly in increasing the capacity by using the local trainers, and then nationally by incorporating the regional anesthesia training into anesthesia curriculums or training curriculums, and also for the perioperative guidelines. This can be done with partnership with various organizations, as mentioned. As Jonah has mentioned, we have had greater interest and also been keen to promote the training aspect of it as much as possible. So we've traveled to a few places in the past, to Rwanda and Kigali, where we explored what are the possibilities and how we could assist in terms of training. Teams from across the country, Dr. Madan Narayanan here has attended in Tanzania, and they do have annual programs where we have seen significant shift in some terms of training the trainers and then multiplying the local resources for them. You can see our Nat Haslam from RA UK along with Karim. This was in Morocco. We do travel to different parts of the Africa so that we can choose where we can possibly scale this up further. And this is the whole team from nearly most of the Europe and also Middle East, who have attended again in Morocco to promote Safe Regional Anaesthesia with the invitation of African Society of Regional Anesthesia, which has been a very important aspect in terms of promoting and also bringing access to regional anesthesia in Africa. This has also been enhanced by a few other providers, especially in the Western Africa, where there is Francophone countries, French-speaking people, where there have been limitations with the trainers. And Xavier Rangevel from France, along with his team, has also been doing this for a long time and promoting this. And in terms of also bringing knowledge base by using different educational material, and also and the websites like Surgery Hub where this can be taught. To summarize, I want to emphasize that regional anesthesia improves the safety outcomes, as we all know, especially more important in low and middle income group countries compared to general anesthesia. The access to medication and the resources, that's something that we can always, we're also looking to support from the rest of the organization, not from the WHO and also anesthetic societies. And ESRA has been promoting a committee mainly in terms of providing access to this in the near future. And promoting the training, and hopefully we'll have equity in terms of ultrasound machines as the economies progress across the globe, and also with donations. I wish you all a safe learning all day, and thank you so much for the opportunity.
Great, thank you very much, Kieran. Moving on, we've now got Nat Haslam, who is the current RAUK president, who is going to talk about, and who's talked quite a lot today, so I don't think he needs another introduction. He's going to talk about PrEP stop block, which is vital to try and make your regional anesthesia as safe as possible.
Okay, hello again, everyone. Nice to be back at the podium. This was a request as part of the kind of safety initiative in regional anaesthesia. PrEP Stop Block is the national UK safety initiative to try and prevent wrong-sided block, which I was involved in setting up. So we'll have a sort of 15 minutes or so just to talk through this. I realise that this is UK national guidance. Some other countries may have their own guidance, but we'll talk through this because there are many of countries in lower and middle income areas that may have no guidance at all. So in the UK we have a body called the Safe Anaesthesia Liaison Group, and that is made up of representation from both the Royal College and the Association of Anaesthetists. The Royal College sets standards and examines in the UK on anaesthesia. The association sets guidelines and has clinical input into our day-to-day work. The new step PrEP Stop Block guidance was made with input from both the Safe Anaesthesia Liaison Group and Regional Anaesthesia UK, RAUK. So what I'm going to talk to you about today is outlined in the editorial that we published in Anaesthesia in 2021. This was PrEP Stop Block, refreshing stop before you block with new national guidance. And we wrote this in conjunction with Nigel Bedford, who's a consultant in Nottingham, and was the author of the original Stop Before You Block guidance. And J.D. Pandit, who's Professor of Anaesthesia in Oxford, and at the time was chair of the Safe Anaesthesia Liaison Group Committee. So a little bit of kind of history about this. In 2009, in the UK, we had the establishment of a never event framework, and this was introduced into the NHS, and this said that there were certain events like wrong-sided surgery, retention of a foreign body within a patient after surgery, or mistaken identity. These were never events and should actually never be occurring in any patient. So this was back in 2019. In 2010, two things happened. Firstly, the World Health Organization, WHO safety surgical checklist was introduced and established as gold standard practice within the UK. And secondly, At the same time, SALG, the Safe Anaesthesia Liaison Group, detailed learning points from 67 wrong-sided blocks. They recognised that this was a problem, and they wanted to publicise. Part of SALG's role is to publicise issues so that it's brought to a wider audience. So rather than just being reviewed in individual hospital, this becomes a national alert. In 2011, following on from those details and learning points, the initial Stop Before You Block campaign was launched. This was done in conjunction with RAUK and SALG, and came out of the Nottingham Trust, as I've already said, from Nigel Bedforth and his group down in Nottingham. In 2015, for the first time, wrong-sided nerve block was classified as a never event. Now, we can discuss whether this is a good thing that wrong-sided nerve block is a never event or not, whether it should be, but the fact is that if we put a block in the wrong side for a patient, this is classified in the same bracket as if we took the kidney out on the wrong side, if we amputated the wrong limb, and we mistake and get completely the wrong patient. So this is a big deal, and in the UK, this is what your chief exec will get really cross about, and there'll be a lot of paperwork. So it's not good for patients, and it's really not good for you as an individual clinician if you do have a wrong-sided block. So let's look to begin with at the original Stop Before You Block protocol. Completely reasonable and very well-meaning. This was the first iteration of what we did in the UK to stop ourselves putting the block on the wrong side. So first of all, it said that the stop moment should occur immediately before the needling, so before the needle goes in, so that reduces the chance of you getting distracted and then inserting the block into the wrong side. It emphasised that this should be a two-person check, and it should be checked between the anaesthetic assistant and the anaesthetist themselves, so you've got a friend who, a wingman who's helping you make sure it's on the correct side. That we look at the surgical site marking, and that we check the site and side of the block. So completely reasonable on the face of it. So as I say, in 2015 we introduced Stop Before You Block, and my colleagues from the UK will all be very familiar with this. And what happened? Well, the incidence of wrong-sided block before Stop Before You Block was about 1 in 6,250. After we introduced Stop Before You Block, the incidence remained exactly the same, and unfortunately we had no reduction in incidence of wrong-sided blocks with the introduction of this particular initiative. Why was that? Well, as I've already outlined, there were two things happened around about the same time. The WHO checklist became mandatory in the UK, and this was done for every patient. Part of the sign-in is to check the identity of the patient, the consent form, and the site and side. So a lot of people were getting the WHO organisational checklist confused with a Stop Before You Block moment. So rather than doing it, doing the check immediately before the needle goes in, they were doing the check as part of the WHO checklist. And we all know that that can occur maybe 20 minutes before we actually do the block. We may do a spinal before we do a block. We may do a complicated general anaesthetic that takes some time before a block. And so we've got ample time to be distracted. The second thing that happened, and this is completely understandable, is that the Nottingham group initially said, if there's anything else you can think of that will help us to reduce wrong-sided block, then incorporate that into your practice. That's absolutely fine. Now, unfortunately, this introduced local variation into the Stop Before You Block process and caused confusion. So some centres would put an arrow on the side that they were going to block in addition to the surgical site arrow. Now, unfortunately, some centres would put an arrow on the opposite side saying this is not the side to block, so don't be blocking this side. Even more confusing, some people introduced a sticker system, and they would stick a sticker on the side saying this is a side to block. But then, as you can see from this picture here, other trusts would say stick a sticker on the side that's not to block, so that when we uncover that we can see that it's not. So you can understand that if you're a doctor working between trusts, then this might be very difficult. Rotating as a resident through different trusts, this is going to be really confusing for you. And these are additional layers of error that may be introduced into your practice. So, in 2018, the Department of Health in the UK introduced a new body. This was called the Healthcare Safety Investigation Branch. And this was a body set to look at clinical problems with patients that cause clinical harm. And this is not just anaesthetic problems, it's not just regional anaesthetics problems, this is all patient harm within the NHS. But the first thing that they actually decided to look at, and this was their main focus of their first investigation, was a wrong-sided block. So this is the report, their very first report from, the HSIB is still going, their very first report from 2018 was into a wrong-sided nerve block. So if we look at what triggered this, this was the report of an incident. So I'll just walk you through this initial incident. It was a 69-year-old man who was having elective surgery on his right ankle. The plan was for this man to have a general anaesthetic, and he was going to have the combination of a sciatic and a saphenous nerve block for his ankle surgery. Perfectly reasonable and clinically indicated choice of blocks. Present was a consultant. At that time we called them trainees, we now call them residents, and an ODP, that's an operating department practitioner as we call them in the UK, an anaesthetic assistant. The WHO checklist was completed as recommended. And the initial thing that they did was to have an awake patient that they asked to lie onto their tummy, so they turned them prone, and they performed a stop before you block moment, and they did a popliteal sciatic nerve block. But so far so good. The second thing they did was reposition the patient, and they turned them from prone to supine, or the patient turned themselves because they were awake, and then they were put off to sleep. Now unfortunately, after induction there were some airway issues. The supraglottic airway device wasn't fitting quite so well. And so the resident and the ODP went to reposition the airway device. I think it was an LMA in this case. And this is a quote from the HSIB report, and it said, airway intervention was ongoing and the consultant proceeded with the second nerve block. So this was written in black and white. And of course, you know what's going to happen. The consultant who on their own performed the saphenous nerve block did it on the wrong side. So I'm sure you all have ideas about why that happened. Some are fairly obvious. We're all very familiar with the Swiss cheese model. And the things that immediately come to mind is, first of all, we started with an awake patient who could say, hang on a minute, you're doing the wrong side, to having a sleep patient who couldn't tell them that they were doing the wrong side. They changed positions, so they went from prone to supine. So as you look at the patient, the left and right hand side were changed over completely. There was a delay between the stop before you block moment and the needling. There was obviously a big distraction in that the airway issue was ongoing, and the ODP wasn't involved in the saphenous nerve block at all. The consultant just did that on their own. However, as with all these things, there's a number of layers of Swiss cheese, and I'm sure we all work in busy theatres, we all work in busy environments with lots of distractions, and there were a number of other things going on at the same time. There'd been a change of plan regarding the second block. They weren't initially going to do a saphenous nerve block, but the trainee had said that they would quite like to see one done, and it was clinically indicated, and the consultant had decided that that was okay. The surgical drape had obscured the mark and the TED stocking, so they couldn't actually see which side was marked from the surgical point of view that day. This particular hospital used blue tape as a sticker, and that wasn't available, so they didn't have a sticker on to say this is the side. Again, you know, we're all short of certain equipment at certain times. The ultrasound machine wasn't on the usual side because the ODP wasn't familiar, so that just added an extra thing. The consultant was anxious about the popliteal sciatic block. It hadn't gone very well, and they felt they were losing momentum on the list. The surgeon was there at the window with, peeping in and saying, "Come on, come on, come on." There's all these things happen. So, and this is life, isn't it? This is the environment that we work in. It is difficult sometimes. So, what did the HSIB say? Well, firstly, they said. They made the point right back then, it's unclear whether Stop Before You Block had any impact on our incidence of wrong-sided blocks. There was significant variation, which is understandable. It had been encouraged in the practice of Stop Before You Block. No one had actually looked at whether Stop Before You Block was working in practice. And there was certainly no formal training or supervision in Stop Before You Block. It wasn't part of the curriculum at that point. So they recommended that the Royal College established a working party, which was done through SALG, and that human factors was taken into account when we looked at any revamping of the guidance. Oops. This was a working party, so Professor J.D. Pandit, who you've heard about before. Professor Pandit is a professor in Oxford. He'd already done some work on wrong-sided block. And actually, he'd come up with the mock before you block concept. So you pretended to do a block, and then you stepped back, and then you actually did a block with the feeling that if you did that process twice, then you were much less likely to get it wrong 2 times. I was representing Regional Anaesthesia UK, and my fellow board members said, Nat, if you come back and say we have to pretend to do our block each time and then do a block, then that's not going to work in a busy theatre. So please don't come back and tell us we have to do that. There were representation from the college, and as I say, from the simulation working party. Now, fortunately, we had a big database at South Tyneside and Sunderland of blocks that we'd done. We know the incidence of wrong-sided blocks was around about 1 in 6,000, and at that time we'd done just over 20,000 nerve blocks and hadn't had a case of wrong-sided block over that period. So we knew statistically that the probability of that occurring by chance was really, really rare. It's less than 0.035. So we know that we've got a system in this particular hospital that works. So background evidence for PrEP Stop Block. We carried out an RA UK members survey. These are people who have an interest in regional anaesthesia and are likely to have put steps in process to be able to mitigate wrong-sided block. There was a huge variety in variability in practice, and so we knew that this normal the first Stop Before You Block process wasn't working very well. We reviewed our South Tyneside and Sunderland data, and that was a formal review by the working group party just to make sure that everything was as we said it was. And then we did a multi-centre observational study of the draft SOP, where we introduced human factors evaluation, which was part of the initial recommendation. So this is what we came up with. This is we split the performance of a block into 3 sections. My UK colleagues will be familiar with this. We have preparation, we have the stop moment, and then we have the block itself. So, what's preparation? We'll split this the algorithm into 3 parts. The preparation it starts with the drawing up of the drugs and the equipment. Once the local anaesthetic has been drawn up and the needle is in place, that's handed over from the anaesthetist to their assistant, and so it's not immediately available for them to pick up. The preparation involves any pre-scan that you do. It involves positioning the patients and cleaning the site. And then any kind of formal sterile ultrasound scan that you're doing. And it's only at the point that you're just about to put the needle in that we recommend that you do the stop moment. And we recommend that you use a kind of formal form of words. So in the same way as there can be a lot of chat going on, but then when you're doing a rapid sequence and someone says cricoid off, everyone knows what cricoid off means. That's a moment to pay attention. So what we recommend here, it's kind of analogous, is you say, okay, I've completed my prep, let's stop before you block. And that is that's the moment that your assistant knows to pay attention, and that's when things have to happen. It feels a little bit stilted at first, but now I feel it's a thing I do once I finish my scanning. I just say, okay, I finished my prep, let's stop before you block. And that just, it feels really unnatural not to actually say that now. The assistant says, okay, let's stop before you block. And at that point, we check the mark. So this is a surgical mark, no additional anaesthetic marks. We check the consent of the patient to make sure that the consent says it's the correct side, and if the patient's awake, then we check with the patient as well. That's likely to be the least reliable of the three methods, because sometimes a patient will, you say, is it the left side, and they'll say yes, it's the left side, and then they'll say, but that was the bad side, you're supposed to be doing the right side today. So it would seem foolish not to check with the patient if they're awake, and most patients would be very helpful, but it's the mark and the consent that we're really going from. And then, immediately after we've done the stop moment, the ODP will hand, or the assistant will hand the needle to the anaesthetist, and that's when we perform the block. So there's the immediacy is a short period of time to prevent us having distractions between the stop moment and the actual block moment. If there's any delay to that immediate block, then we go back to our preparation and we start the process again. It doesn't mean we have to do the scanning and the drawing up the drugs again, but it just means mentally we're coming back from the top of the algorithm through the stop moment and into the block phase. This is all in the editorial, and there's paper and supporting evidence to go along that, but we had some frequently asked questions. First of all, I'm inserting a perineural catheter. This is, you're going to be sterile and gowned, so you will have access to the needle, and we just emphasize that it's important that you use that formal form of words in that scenario. You're not going to be able to rely on not being able to pick up the needle, so get used to, as soon as you're ready to do the needling, say, I've completed my prep, let's stop before you block. That's your formal form of words. What if you're doing more than one block on the same patient? Well, this is particularly important, as we saw in the reference incident, where if there's a change of position, then it's really important that we do two separate stop moments. So we're doing this twice. So this is from supine to prone, or from lateral to supine. It's really important to do a second stop before you block. If the two blocks are distal from each other on the body, then it's important to do two stop moments. If it's something like a fascia iliaca, where you may be doing a femoral and a lateral cutaneous nerve of thigh, then that's less important. And an ankle block, where it's a number of injections around the same ankle, then that's not important either. But definitely for any change of position, then do two separate stop moments. The one time we recommend actually putting a mark on a patient is if the block is very close to the midline, where it might be very easy to get on the wrong side of the midline, and it's really hard for your assistant to tell you that you're on the wrong side. The whole prep stop block routine is designed to say, come on, actually we're supposed to be blocking the right hand today and you're blocking the left, that's ridiculous. But asking your assistant to know whether you're 1 or 2 centimetres either side of a midline is really difficult. So we need to mark the midline, which helps them to tell you whether you are actually on the incorrect side. Importantly, when we set up the guidance, this was Salganara UK, but we also involved the College of Operating Department Practitioners and the Association for Perioperative Practice. So we had buy-in from the anaesthetic assistants, and also this is the formal process that the Royal College of Surgeons of England agreed to use for their blocks as well. The resources are all on the ESRA UK website, so you can download a poster. There's a template there, the summary of evidence, and a copy of the editorial. There's a YouTube video. This is Nigel Bedforth in Nottingham. So there's a YouTube video of how to perform stop before you block or prep stop block, and that's available for you to look at. Implementation. It was a national safety initiative when it came out in the UK. There's a poster that's downloadable from the website with a QR code. There's educational sessions with a video and SOP, and we recommend that people do that. An ongoing audit. There's a QI compendium in the UK for people to do audits, national audits, and stop before you block or prep stop block is one of those audits. So that's in the QI compendium. So key takeaways, the initial Stop Before You Block initiative didn't reduce the incidence of wrong-sided block. We've got new UK national guidance, which is Prep Stop Block, and I would recommend that you adopt that if you're in your country you don't have any guidance on this at the moment. All the information is available on the ESRA UK and SALG websites, and the resources should form an educational package that should be aimed at all staff in this field. Okay, thank you very much. And just a quick advert for this is the ESRA UK Annual Scientific Meeting. There's a QR code. Come and hear Professor Graham MacLeod speak at the meeting as Bruce Scott lecturer. This is the 7th and 8th of May this year.
Brilliant. So we're progressing towards lunch, but before then, I do know, don't worry. We've got Romualdo Del Buono, who works in Milan, talking to us about when he appears to have published very extensively, but he's going to talk about when blocks fail, which is something that I'm very familiar with. So looking forward to this.
Good morning, everyone. Today we are going to discuss a very interesting topic, the situations in our daily practice where we face failure, specifically related to regional anesthesia. In the early days of regional anesthesia, blind techniques had higher failure rates, making failure an accepted part of our daily practice. The advent of ultrasound has made these techniques much more precise and refined, significantly reducing the incidence of failure, but without eliminating it completely. Failure is not a matter of if, but when, because it happens and it will happen again. So let's put our ego aside for a moment and try to investigate the reasons for failure and, above all, start thinking about an algorithm, a plan B and a plan C, should this failure occur. Let's start by defining failure. It's not binary. There are many shades of failure, and it is not all about pain. Failure can also mean an excessive motor block after surgery, preventing early rehabilitation, or an insufficient duration of the effect relative to the surgery. Causes can be operator-dependent, for example, lack of skills, poor technique execution, wrong technique selection, or dosing errors. Even if a technique is performed flawlessly, it might simply not work adequately, like, for example, a patchy spinal anesthesia. Another source of failure can be surgical. The procedure may take longer than expected or become complicated. The patient can also be a factor. An anxious patient might become agitated even with a perfect block. Furthermore, anatomical variations can also play a role. And finally, the environment also matters. Equipment unavailability or technical malfunctions can occur. I also mentioned timing here because sometimes what looks like a failure maybe just needs a little bit more time to develop. Given the critical nature of our job, the first rule is to always have a plan B and a contingency plan. In the aerospace industry, this is known as a fail operational fail-safe system. In space missions, due to the huge amount of money invested in it, every device has at least 2 backups alternatives. This allows the crew to handle not just one, but two or more malfunctions. This implies having a plan A, a backup plan B, and an emergency plan C. We, as anesthesiologists, should apply the same mindset to our practice. And returning to our scenario, when faced with failure, I must first analyze it. I need to question its nature. Is it technical? Is it anatomical? Or is it a timing issue? But be careful. Before we blame something, we must look at our own psychology. We are vulnerable to cognitive traps. First, beware of confirmation bias. Sometimes, looking, for example, at a poor ultrasound image, our brain tricks us. We see a nerve because we want to see that nerve. We interpret ambiguous shadows as a confirmation of our plan. Always ask yourself, am I seeing the real anatomy or am I imagining it? Second, when we struggle, we enter a tunnel vision or task fixation. We obsess over the needle and the screen. We lose situational awareness. We forget the patient is uncomfortable or that 20 minutes have passed. That is why we need a pre-planned algorithm, because under stress, our brain is not reliable enough to improvise. And this leads to the third trap, the sunk cost fallacy. Humans have a tendency to continue investing in a failing project just because they have already invested in it. If a strategy failed the first time, why should it work if you repeat it the exact same way? Let me give a practical example. I am doing a transgluteal sciatic nerve block. The image is pure, I struggle, the block fails. But if the block fails, repeating it at the exact same site with the same poor visibility, it's a classic sunk cost error. It will be wiser to break the fixation and ask, should I change the approach, maybe go parasacral or subgluteal, or maybe switch to sedation? Finally, how do we manage the patient itself? If you need to perform a rescue block, watch your communication. Avoid the nocebo effect. Never say, oops, I missed, I have to stick you again. This destroys trust and increases pain perception. Use positive framing instead. Say, as part of our protocol to ensure perfect comfort, we are going to add a specific supplement. And this applies to the surgeon as well. To maintain your credibility and not look incompetent, manage their expectations. Don't say, I don't know why it's not working. Instead, use strategic language. Say, for example, I am optimizing the anesthesia coverage to ensure a smoother surgery. Make the plan B look like it was part of the plan A all along. You must look in control. Once we understand the cause, we can decide on our plan B. In this infographic, you can see a pyramid of all available macro techniques, ranging from general anesthesia at the top down to the super selective distal blocks. We don't necessarily have to go up. We can also move down the pyramid, choosing our strategy based on the patient and the surgery. If the technique I've performed is not working, do I have the time and ability to perform a rescue block? Yes, I do it. No, for example, I can move up towards sedation or general anesthesia. Moving up or down this pyramid does not mean compromising, but it's quite the opposite. And there is just one warning I want to give you. If you choose to perform a rescue block, always keep an eye on the cumulative dose of local anesthetic to avoid complications. A relatively frequent and frustrating cause is a failed spinal anesthesia. Failure here includes partial blocks, insufficient dermatomal spread, or poor quality analgesia. Reasons for spinal failure are manifold. If I decide to repeat the procedure, I must consider, did I have technical difficulties? Can I improve the successfulness by using ultrasound? Because if the failure was purely anatomical, a second injection is unlikely to work better. There are many alternatives to neuraxial anesthesia. Not all of them can replace neuraxial anesthesia entirely, but they can be combined with sedation or light general anesthesia. In these cases, we draw from our toolkit of chest and truncal nerve blocks, effectively moving up and down the technique pyramid. Obviously, the same logic applies to the limbs. Take the brachial plexus block, for example, for the shoulder arthroscopy. In case of failure, we can move up or down. Moving up means, for example, converting to general anesthesia, or alternatively, we can perform more distal blocks, like moving down the pyramid, such as the suprascapular or the axillary nerve blocks combined with light general anesthesia. Actually, there are many newer approaches like the pericapsular shoulder block infiltrations, but we do not have the time to discuss them all, unfortunately. It's up to us to choose the right tool when failure occurs. Regarding more distal surgeries, like those of the arm and forearm, we have many more options. For the arm, we can pick from 3 overlapping techniques, like the supraclavicular, the costoclavicular, and the infraclavicular blocks. Having 3 equally useful options allows us to switch to a different approach if the first one fails. The further we go into the periphery, and the more rescue options we have. For forearm and hand surgery, we can selectively block the radial, median, and ulnar nerves at the elbow or even at the wrist. And the same identical logics applies to the lower limb. In case of neuraxial failure, we can focus on lumbar plexus blocks or parasagittal sciatic blocks for proximal surgeries, essentially with just one more step distal to the neuraxial anesthesia. And as the upper limb, for more distal surgeries, we have many, many rescue blocks available for the lower limb as well. Unfortunately, we did not have time to discuss all the details of each technique. However, I hope I've conveyed the main message. Analyze the failure critically, avoiding fixation errors. Always have a plan A, a plan B, and a plan C. In case of failure, know that you can move up and down the pyramid towards, for example, general anesthesia or down to the peripheral nerve blocks. How we will act depends on 4 things: time availability, skills, surgery and the surgeon, and of course the patient itself. And I think that's all. Thank you for your attention.
Good. Can I invite all the speakers up? So that's Professor McLeod, Dr. Haslam and Dr. Canetti. And then I'll take some questions from all of the crowd. I don't think I'll be able to take everyone's questions, but maybe 1 or 2, if anyone has one.
I don't know.
Yeah. Yes.
So, in your clinical practice, do you use any adjuncts like dexamethasone or fentanyl, or is there any favorite of yours?
Open it up to the guys.
Personally, no, I don't. I don't like mixing things unless I have to, and so there's now good evidence that using IV dex in conjunction with local anaesthetic has a very similar effect to using perineural dex. So dex would be dexamethasone, that is, rather than dexmedetomidine. Dexamethasone would be the would be the thing that I might be tempted to add perineurally. But now the evidence is that you can give it systemically and have the benefits of nausea and vomiting and all the rest of it. Then I would give IV dex and use just a plain local anaesthetic regime for my blocks. So if we want a fast onset with a decent duration, then I'll use ropivacaine, because I think that's a nice agent to use in that situation. We used to mix 0.5% levobupivacaine and lidocaine and hope that we got the onset of the lidocaine and the duration of the bupivacaine, but of course you don't. So rather than mixing and introducing the potential for a mixing error, I would rather just stick with the local anaesthetic that I think is going to do the best job in that situation.
Coming back to my talk, the key thing is actually where you put the local anaesthetic. And where you put the local anaesthetic differs every single time when you do it and when everybody else does it. And that actually overwhelms any effect of the dexamethasone. So in fact, we are Although it may seem on the macro scale that you're doing a good block, on the micro scale, you're putting it at a different place every single time. That overwhelms any model of outcome.
Mm-hmm. And okay, so sorry, just before we move on, for our international viewers, I'd just like to highlight a case that happened recently in the UK. There was an unfortunate case of a woman having a hip replacement who had local infiltration from the surgeon, and she unfortunately died of local anaesthetic toxicity. There's been a recent prevention of future deaths notice issued from a coroner in the UK, and part of the reason that occurred was a dilutional error. So I think this is particularly topical actually at the moment. It's a good question to have asked and to be able to highlight this, that what we shouldn't really be doing unless we can avoid it is mixing drugs and diluting drugs. And certainly we should be observing very carefully the upper safe dose limit that we know that we should be calculating and discussing at the WHO checklist.
That brings me to another question. What should we be doing? Is it ideal body weight calculations or lean body weight, or like the few days back I had a high BMI, short statured lady with a weight of about 90 kgs or something like that. And what I went was, I didn't calculate honestly the ideal body weight, but going by her BMI and all that, I went by the weight of somewhere around 70 kgs. But then my colleague, who is doing a bit more, regional than me, and he was keen on doing ideal body weight. What I thought was, if I would have gone on by ideal body weight, it would not have given me enough volume to inject for that patient.
Yeah, I think it's a really interesting question in that we don't actually know very well what the safe maximal doses of local anaesthetics are. All the studies are done either on animals or on fit, young, healthy volunteers, and those are not, fit young people are unlikely to be the people that we're running into trouble with. I think in terms of whether you use actual body mass or lean body mass, ideally you would use lean or ideal body mass. But that requires a calculation which in itself introduces the potential for error. When the college were coming up with their statement that they issued following the death, the coroner wrote to the college, and the college had to then produce a statement to try and keep us all safe. And they shied away from saying that. I think practically what we should be doing is putting an upper limit. And so in the same way that the TIVA pumps won't allow us to go over 100 kilos, because it's clearly not going to be ideal body mass. A practical solution to this is to say if someone's over 100 kilos, we're going to cap the local anaesthetic dose at that as a maximum at 100 kilos. So that's what I do in my practice for people with higher body masses, where it's not lean body mass.
Sorry, I didn't get the last bit. So what do you do with your practice? Let's say you have a patient of 5 feet and weighing about 95 kgs.
Yeah, so we cap it at 100 kilos. So if the patient's over 100 kilos, we don't give more than, say, 2 milligrams per kilogram of levobupivacaine. So we use that as a practical rule that we can use on every day on the ground. Not everyone has access to an ideal body mass calculator. I know we all have an iPhone, or other phones are available, but we all have a phone in our pocket. But reception's not always there, and so making that a national guidance wasn't felt to be practicable.
Thank you.
Anyone else has any?
Just a few things about presuming this is working.
Yeah.
A few things about using drugs in regional anaesthesia. So the first is obviously the only additive that I sometimes use is adrenaline, but that's already pre-mixed in in lignocaine, obviously, and like Nat, tend to give IV dex if I want to prolong the block. One of the things I think more broadly that from a personal point of view is that in our cupboard we have levobupivacaine 0.25%, 0.25%, 2.5 milligrams per mil. You know, we refer to it in loads of different ways. The absolute dose is obviously the main thing, and I think personally feel that we should move towards communicating the milligrams of bupivacaine that we're going to give like we would for any other drug, and then it's very clear that we're giving that amount, and then you work out the volume that you're going to give it in. So I think to me the master drug is really important that we move towards communicating that, because that makes people think about what dose we're giving, whereas you know, X mils of this percent, which it doesn't even say on the box. Like our boxes don't even say 0.25%. So you know, yeah, it just gets confusing, and no wonder people make errors.
I'll just add one point. Sorry, in terms of mixing allays.
You did. Yeah.
Yeah. So in terms of mixing allays, we were at a meeting in Milan, and there's a lot of evidence coming up about having microscopic crystals which are being developed when you mix the drugs. So obviously the effects of which we don't know yet, but that's something to be mindful of, that you need to be very careful when you start mixing drugs. What effect does it have inside the body, especially in young patients? You're putting those drugs in the nerves, like Interscalene or epidural. To be honest, that lecture was like eye-opener, and I'm absolutely scared to mix anything now and give it to young patients.
The other thing is you're shooting yourself in the foot a little bit, because you're not giving, if you think about it, if you're giving 0.5% bupivacaine mixed with 1% levo, you're actually making it 0.25% bupivacaine and 0.5% lignocaine. So you're half diluting your drug, and if it's half diluted, then the onset will be slower. So yeah, I think Nat's going to ask Graham a question.
Yeah, it was just a really interesting talk. Thank you very much, Graham. I've got a situation in mind. So this is maybe a little bit controversial, but would you ever recommend that we use a sharp needle for a block, or if you were the expert witness standing up in court after my nerve injury, would you have something to say about that?
Yes, I would actually, and I think there's no doubt there is a difference between blunt, short-beveled block needles and long-beveled needles. They look entirely different. The Sala Blanc study from 2009, it was in the BGA, looked at 520, I think, nerves from cadavers. And the only needles that actually, there were 3 out of 520 actually entered the fascicle. And of those 3, they were all long-beveled needles. This could be a potential problem, because I know we use 27-gauge needles for ankle blocks, and they are long-beveled. And I'm very worried actually about this. Not only that, the 27-gauge needle is really quite small and does have the potential to actually enter a fascicle at that particular level. I think it's only about 400 micrometers wide. So it's encroaching upon the actual diameter of the fascicle itself. So I am against long bevel needles being used in regional, and I think we should stick to the short bevel needles.
So yeah, this is where I find it slightly difficult, and this is where science research meets clinical practice, isn't it? And you know, I think with ankle blocks, if you use a short bevel needle, you pop through the skin, and then rather than moving into relatively insensate muscle, you hit either periosteum or bone, and the patient moves and jumps, and I think that might be more dangerous than using a sharp needle, a 27-gauge needle, as you say, that they don't feel go through the skin actually. but I would, and I know that this is common practice around the UK, which is one of the reasons I'm bringing it up. But I think it's really important to stop short of the nerve and inject ahead of your needle and let the local anaesthetic do its work for you. We're not getting to anything like a maximum safe dose with an ankle block, so you've got a little bit to spare. But in that scenario, I would still use a sharp needle, but just be very careful about how I did it and make sure that I can absolutely see the tip, which you can see, and then the shaft of the needle for an in-plane approach for an ankle block. Don't know what you think.
I think that's entirely fair comment. It's very practical, and I actually use the sharp needle as well. And I, as you say, just inject far away from the nerve. I don't touch the nerve at all. It's just being sensible and knowing what you're actually handling. And of course, it would all be solved if the drug companies actually brought out 27-gauge block needles.
Because they're not NR fit, are they? Which we're supposed to be using.
It's one of the going on to Kieran's talk. It's one of the issues with low resource countries, particularly in my experience, African countries is actually, nowadays, we're talking about lots of bits of equipment that you need to do a block to our standard, short bevel needle, which are moderately expensive, and they're not only expensive, but they're actually quite difficult to get delivered. So if you don't have a supply chain to your country, it becomes even more expensive. And whilst regional anaesthesia is really safe and reproducible if you've got all the right equipment, that becomes much more difficult if you don't. And a cheap, easy to manufacture locally block needle for low resource income countries would potentially have a lot of sales if any manufacturing companies are watching. Yeah, one more.
I don't know if it's working or not.
It is, yeah.
All right.
That's good.
Just continuing the question about the needle and about the blunt and the sharp needles. So you said you never touched the nerve, but in case you touched the nerve with a blunt needle, if I understood it right from the lecture that you gave, you said it will never even penetrate the nerve. It's not going to penetrate the fascicles. Is that right?
If you use a blunt needle, the chances of penetrating a fascicle are virtually zero, because the fascicular bundle will rotate out the way. If, on the other hand, you have a sharp needle, then the chances of penetrating that fascicle are higher, okay, because it's a much sharper object. So the other problem, of course, is that we don't know whether we're actually in the nerve or not, because we can't, because the ultrasound doesn't give us sufficient resolution to tell us. And often intraneural injection can be a crescent-like effect rather than a sort of big sort of circular sort of blow-up that we think it is. So some people have actually said our best blocks may well be due to partial intraneural injection under low pressures. So the problem is that we don't know precisely where we actually are. But if we are in the nerve and we are touching the perineurium, the likelihood is it will remain within that perineurium, the perineurial septae, and not actually go into the fascicle.
That's not in turn is going to cause any nerve damage, right?
It's unlikely. I think there's another reason for nerve damage. I've written about activation of piezoreceptors on the nerve due to excessive force. That makes sense to me. So Alan Winnie used to say the cause of nerve damage is actually proximal to the end of the needle.
I think you're paraphrasing there, actually, aren't you, Graham? I love Graham's research, and I know there is this thing about confirmation bias, but I really think it's very difficult to damage a nerve with a block needle. The only thing I would caution against is not pointing your needle towards the nerve as you're going through a fascial layer. If you approach a nerve with a blunt needle slowly and carefully, it will just move out of the way. The only time you're going to damage it is if you're tensing a fascial layer, you're pointing directly at the nerve, and then you get a sudden stabbing motion towards the nerve as the needle pops through. It's a bit like trying to pop a balloon with a knitting needle. You can approach the balloon and it will move out of the way, but if you make a sudden jabbing kind of movement, you've got half a chance, and that will be the excessive force mechanism that I think that Graham is talking about. So just be careful. We need that balance, don't we, in our needles? And this is, again, where we need to work with manufacturers because if we don't tell them what we want, they won't give us the right thing. If a needle is too sharp, it's got the potential, as Graham says, of being dangerous. If it's too blunt, equally, I think it's got a potential of being dangerous because we're using so much force to push through fascial layers that we might actually end up damaging a nerve.
I've actually measured the force in teal cadavers, and it ranges from 0.1 newtons to 16 newtons to actually enter the nerve. And in 4 cases out of 48, we couldn't even get into the nerve as it was bouncing off the nerve. It was the median force required to enter a nerve is about 2 newtons. So there's a huge, huge range. And for about a quarter of those, they will simply slide into the nerve and you won't actually be aware of it.
Just another question regarding the, just as my colleague questioned about the local anesthetics and about the low and middle income countries, because I've been working in a country before, so usually there aren't a lot of ropivacaine. You wouldn't find it a lot in there. So the question here, would you still go for lidocaine 2% as an example? Even here, not all the hospitals and not all theaters are having ropivacaine. So would you still go for lidocaine 2% as a local anesthetic?
Kieran, do you want to take this one?
That's a good question, actually, because in as you mentioned, a lot of low and middle income group countries, lidocaine is possibly one of the most commonly available local anesthetic, with or without adrenaline, various reasons. With hand on my heart, yes, I have used it plenty of times, including in the subarachnoid space for spinal and things like that. It's worked, but the anecdotal evidence says that when it is in the perineural area, it can potentially cause long-term issues, and that's why we shied away from that when we talk about, especially from NATSTAP. You look at nerve injury in about 20,000 patients. There was very, very little incidence, so that's why we go on. We err on the other side. So to answer this question, yes, politically possibly not, but it can be used, and it has rarely caused any problems. So if that is the only agent you have, you can use. I mean, I'm not talking for the, the Western practice, because we have to be based on evidence and common practice and things like that. But for, if that is the only agent available, it's better to use that rather than using something else. Does that make sense?
I mean, we've got 4, 5 maybe local anesthetics. They all have slightly different properties. So depending on what you want to achieve, you can use that to your advantage. So if you only wanted a block to last for 20 minutes because you just want to put a shoulder back in, then maybe 30 mils of 0.75% levobupivacaine isn't the thing to use. Lignocaine may be the thing to use if you wanted to do a quick onset and then have a selective block that lasts for longer afterwards. So I think there's use in having experience and knowledge of different local anesthetics, so you can use the pharmacology to your advantage to produce the effect that you want, which might not be the same every time.
Yeah, completely agree. I think this links in with what Steve Coppens was talking to us about in the first the recorded lecture, where he was saying that you have a problem with what people call rebound pain after nerve blocks, and so we have to think about what we're using it for. We can use lidocaine, and I have a colleague who works in the Northwest who uses lidocaine for axillary blocks. The axillary or forearm blocks wear off, and the patient has multimodal analgesia in the day of surgery unit before they go home. They can use their hand again, but they've used it in conjunction with good multimodal analgesia. So we have to think about how long we want the block for, but also its place within the multimodal analgesic regime that we're going to use when the block wears off. So I think regional is a good adjunct, and there's been a recent paper published by I know Kareem El-Baghdadi was involved in it, looking at rebound pain and looking at regional analgesia as part of an opioid or an opioid-free regime, and they found that using regional anaesthesia is beneficial, but it's got to be as part of a multimodal analgesic regime. You can't use a long-acting local anaesthetic, pat yourself on the back because the patient looks brilliant in the PACU or even in the day case unit, and then they're in agony overnight. So yeah, by all means use lidocaine, but make sure you've got a safety net of multimodal analgesia when it wears off. But if you're using a long-acting one, you still have to think about what's happening at the back end of that block if the patient's maybe at home. So yeah.
Great. I think. Yeah. One more question.
If we got time.
Yes.
In my routine practice, at the end of the case, thoracic surgery, the surgeons do the paravertebral block under direct vision. They can see on the camera where the needle is going and all. What's your, take on that? Do you think that's the safe way of doing it? When we're talking about nerve injuries and all, they just see that the needle going through the fascial planes, but they actually don't know whether if it has hit the needle or not. It has hit the nerve or not. And do you think it's always effective? Like, is it the safest way and the best way to do it, or should we be saying no? We should be doing it under ultrasound by ourselves.
So, surgically placed paravertebral is a relatively well recognised technique. So you can't say it's. I wouldn't say it's not safe. It's obviously, and it does have the risk of quite significant complications as well as do all techniques. But in general, it's an effective, safe way of doing it. They can't see the paravertebral space, so they can't inject it under direct vision. They just know if they've gone too far with the needle. So they don't actually know where it is. They don't know if it's gone up the catheter's gone up the intervertebral foramen or whatever. It's the same as the rectus sheath surgically sited blocks. They can't see that plane because it's in the middle of, at the edge of the muscle and through an area they can't see. So it's not under direct vision. It's under assisted placement, which is exactly the same as ultrasound, which is not exactly, as we've learned this morning, direct vision, but it's a little bit more information than what they've got. So, I prefer to do it myself, but that's just me.
Yeah, just to kind of echo that, I think this is analogous to local infiltration or LIA for joint arthroplasty. If it was my knee, I would rather have an anaesthetist with an ultrasound machine who could infiltrate at the back of my knee. They can see the popliteal artery, they can see the sciatic nerve, and they can avoid both of those structures, rather than a surgeon sticking a sharp beveled needle through the back of my knee capsule and infiltrating. But that said, that infiltration is a well-recognised technique with a low complication rate. And what we don't actually know yet is what actually is the incidence of permanent nerve damage following regional anaesthesia, do we? And so, NAP8 we're working on NAP8 at the moment, and hopefully we'll get some answers to, what our incidence of permanent nerve injury is after regional anaesthesia, and then maybe we can start having more conversations about how it compares with surgical techniques.
We did an amputation last week, an above knee. I put a femoral catheter in, worked perfectly. Surgeon put a catheter in from the bottom, didn't work at all. It eventually did with huge doses of 0.75. So just because they're putting it under direct vision doesn't mean to say you actually know where the tip of that catheter actually is.
So I guess we will all agree that there is an opportunity to audit it, the effectivity, if it's effective in a lot of patients or not. and about the nerve injury as well going forward?
Yeah, so I mean, I think you can audit it, but the incidence of nerve injury is very low in both of these scenarios. So what we need is a national audit project with a big denominator. So we need to know what that denominator is, so we can actually say with some degree of accuracy what the incidence of permanent nerve injury is for these procedures.
What we do have from the American from American local anaesthetic toxicity databases is we know that basically if an anaesthetist in America does a nerve block, it's extremely unlikely to cause local anaesthetic toxicity. But when you get local anaesthetic toxicity, it's in situations like the local infiltration where the people that draw it up got the wrong concentration, or in a office setting where they get used to the fact that you can give these high doses of local and most people are fine. So I think, us being in control of the local is always important. Good. Right. Well, I think that's lunchtime then. So for those online, we'll see you after lunch at 1:30. 1:30, yeah, 13:30 GMT. Is it GMT? Yes, it is. Yes, it is GMT at the minute. And for those of you here, we'll have lunch and then we'll come back. Great. Thank you.
afternoon. Welcome back. I hope you are enjoying the World Day of Regional Anesthesia. And so far, we have had the morning session with live scanning, live lectures, and also the pre-recorded lectures from ESRA Society. So welcome back to the afternoon session. So we're going to start with the Beyond Club, where we have 2 live lectures, and then we have a pre-recorded lecture from Professor Nuala Lucas, and another lecture, which is again online, but is joined by Dr. Ing Yong. So to start with, let me invite Dr. Jonathan Womack, who is enthusiastic regional anesthesia anesthetist, and also RA lead in the past at RVI, our local trauma hospital, tertiary referral center. He's also a board member of RA UK and has been involved extensively in regional anesthesia education, research, and also promoting safer regional anesthesia with a lot of work in trauma and in the surrounding perioperative analgesia areas. So he's going to share his view about the regional anesthesia for trauma, especially coming from the tertiary referral center. Thank you, Jonathan, for joining us.
Thank you very much. Regional anesthesia for trauma. So I do work, as Kieran said, at a major trauma centre, which sounds really, really exciting. We've got a helicopter on the roof. We have major trauma calls and all this sort of thing. When I was a medical student and the first day I did the trauma list, I was really excited. I thought it was going to be this sort of thing, and this did happen in Newcastle a couple of months ago, and it did have an impact on my day because I had to take a different route to work because the A1 was closed. But no one from this came to theatre, and no one was on the trauma list. This is what I did on that day instead. So neck and femur fractures. So I'm going to think about what we do actually see, what sort of patients we see in trauma and how they benefit from regional anaesthesia, and then maybe extrapolate that out to outside of the theatre environment. So in the UK, we used to have quite a good repository of information about trauma. So there was something called TARN, which was the Trauma Audit and Research Network, and they produced yearly reports. And since COVID, that's turned into the National Major Trauma Registry, because it's moved host from within universities. And they get 110,000 cases of a year submitted to that. So all of the trauma centres submit data to that. So that's a really, really massive potential source of information. Unfortunately, it's never yet published any of that information. So we're still waiting on the first National Major Trauma Registry report. So we can't have any UK data. So if the best option in the UK is to look at Ireland, because they did use the same methodology. They copied the TARN UK methodology, and they've been releasing reports about that recently. So the most recent one was the 2021 data. So trauma tends to affect men more than women. So 57% of trauma cases, major trauma cases in Ireland in that year were men, and the mean age was 62, which is possibly a little bit surprising, or possibly not. However, when you break down the demographics, it's actually more interesting than that. So trauma seems to, as a broad sweep, affect young men and old women. If you look at this here, so when you get older than 85, it's actually more women that have trauma, and below the age of 50, it tends to be men. So, if anyone in the room, do you want to guess where trauma tends to happen the most, and what the most common mechanism of trauma is in the UK or Ireland? This is falling. Yeah. So most of it happens at home. 55%, and the most common mechanism of injury is falling less than 2 meters. Okay, which is really not very far, is it? That obviously changes with age. So you see that the over 85s almost all fall over, and the younger people have fighting and road traffic incidents, which explains why young men are a problem. So you see that actually, as a group, the over 85s are really strongly represented. 34% of trauma cases are over the age of 85. Now, if you're going to die from trauma, sorry, that was mortality actually. So essentially, a really significant proportion of the mortality is over 85s, and if you're going to die, you're most likely to die from a fall of less than 2 meters, which is quite remarkable, despite the fact that on the surface of it, other things are more dangerous. Now, from a regional anaesthesia perspective, what are we interested in? So you can see that quarter of those cases are head injuries. So we're probably less interested in those because there's not so many blocks that are useful. Same with face. But certainly the chest and limbs, so nearly half of these patients may well benefit from a block. And also 8% are multiple injuries. So what can we take home from all of that? Well, trauma affects pretty much all demographics, but disproportionately older patients, and they have a worse outcome, and they have lower impact injuries, so it's less exciting injuries. So where does regional anaesthesia fit in? Well, I found this paper, it's from a while ago now, 2008, but it's difficult to find other information on it. And this basically showed that 91% of patients going into an emergency department in 2008 had severe pain, and 87% of them leaving the emergency department had severe pain. So what that teaches us is that we're not very good at dealing with severe pain in the immediate acute setting, and I think that's because people are thinking about doing other things. Now, I want you to think about the treatments for severe pain. So we have one of the oldest treatments, which is morphine, and we know that the ancient Egyptians were interested in morphine because you'd have to be high on drugs to draw this picture, and there's some poppies on it. So morphine's been around a long time, it works. The WHO pain ladder, which is a sort of standard way to treat pain, but essentially, if you look at it, just encourages you to give some sort of opiate. And on the surface of it, this drug is really great, isn't it? It doesn't look dangerous at all. WHO says it's a good idea. It's on the WHO, not only the pain ladder, but also the drug checklist. It's really easy to give, it's cheap, and you just titrate it to effect. So what is the problem with morphine? Well, morphine-related deaths are increasing in the UK. If you look here, this is from BNF, from Drug Safety Journal in 2023. Essentially, opiates cause around about a quarter of deaths in the UK that are related to medicine-related drugs, which is an enormous amount, and that increased during the pandemic. Okay, so opiates cause a lot of deaths. They also almost always cause side effects, which anaesthetists were really familiar with. Nearly every route of opiate delivery gives you good side effects. So if we're not going to do opiates for trauma, what are we going to do instead? Well, one of the popular things is ketamine. The only thing I'm going to say about ketamine is before I wrote this presentation, I met a patient who had his ankle pulled in ED, and he described having ketamine for his ankle pull to be. He described the hallucination that he was an email on a desktop in a burning building, and he couldn't bear the thought that he would die being unread. And that was his hallucination, and he said it was, despite the fact that it was very surreal, it was the worst thing he'd ever experienced, and he never ever wanted to have that again. So whilst ketamine gives you good conditions, it has the potential to be extremely unpleasant for the person that receives it. I think you have to be really careful about using it in those sorts of, from a patient experience perspective, albeit that sometimes there's not a good alternative. So what is the benefit of regional anaesthesia? Well, let's think about the stress response. So we know that tissue damage and nociception results in a stress response, and that causes neuroendocrine and inflammatory responses in the body. Now, under normal circumstances, if you stub your toe or if you scratch yourself, that's not a problem. But we are not designed to survive major trauma. So major trauma results in a exaggerated response to injury, which results in a loss of negative feedback and ultimately harm. So whether that's catabolism, muscle wasting, high cardiovascular demand, or impaired healing and susceptibility to infection, it's all negative, okay? Not only that, but we know that that whole process also fires up your pain pathways to develop the risk of chronic pain after injury. Now, again, hard data to find, but estimating the risk of chronic pain and disability following musculoskeletal trauma in the United Kingdom, 2 out of 3 patients with major trauma end up with chronic pain after major trauma. So it's a really significant issue. So the benefits of regional anaesthesia, I don't think are that surprising to a group of anaesthetists, but pain relief, opioid reduction, reduce the nociception, and then moderating that stress response, and particularly through a sympathetic block potentially as well with some blocks. You're blocking it at both ends. You're not only blocking the pain pathways coming in, but you're blocking the neuroendocrine response to it on the way out as well. So that's potentially very favourable. But is there any actual evidence that that makes a difference? Well, actually there might be. So there is at least a sniff or a hint of difference in outcome with patients receiving blocks for hip fractures and for rib fractures. I wouldn't say it's definitely proven, but if I had to put my house on it, I would say it's much more likely that it does make a difference to mortality and outcome than it not making a difference. And certainly for the National Hip Fracture Database, the recommendation for a block for a hip fracture patient is described as being the single best evidenced technique that an anaesthetist can do. The evidence isn't very good, but it just shows you that really anything that you do as an anaesthetist in terms of long-term outcome is poor evidence. It's certainly good pain relief, but it could well make a difference to outcome. And really, if you think about the patients that we're putting these blocks in and the ones that benefit, it's the people that we talked about before. It's the elderly patients with the low reserve who are most harmed from these things. And really, it doesn't matter if it's hip fracture, rib fractures, sternal fracture, pelvic fracture, humeral fracture, anything. As long as we can give analgesia that avoids opiates, then actually it's probably going to benefit, and we'd have a good educated guess that this can make a long difference, a long-term outcome. So where does regional anaesthesia fit in? Well, regional anaesthesia we can use either as an anaesthetic technique or an analgesic techniques. So we can either be using that analgesia pre, during, or after the operation, or we can be using it as an anaesthetic technique, and we can use this in theatre or out of theatre. So it's been described in loads of different places, and there's a massive utility for this. So things like fracture manipulation is really, really good for it. It's much better than sedation, and the same with dislocation. We know of the role in amputation analgesia. We had a bit of talk about that earlier in the day, didn't we, about that? Anaesthesia, obviously, and post-operative analgesia don't really need mentioning. But physiotherapy and flap perfusion are other post-operative benefits that may well be good. However, why isn't everyone in the UK not rushing down to do a block in A&E straight away? Well, there's a couple of issues. The first thing is technical proficiency. We've had a bit of discussion already today about how difficult it is to actually deliver blocks. So we did a national training survey with the new curriculum. So the idea of the new UK curriculum is that every anaesthetist should be able to perform a chest wall block, an upper limb block, a lower limb block by the end of their training. So this is where we were in, I think it was 2 years ago, wasn't it? 2023, probably. 2023. This is where we were 2 or 3 years ago. So you can see that at the end of training, so at stage 3, residents in the UK mostly can't do a chest wall block or an abdominal wall block by the end of training. And you've got a reasonable chance of someone else being able to do an upper limb block or a lower limb block. And that's based on 20 blocks. So 20 blocks is basically the absolute minimum to be able to do a block, really, isn't it? And that's a group of people that are, their whole job is anaesthetics. It's not even just, A&E who may be having to learn a load of other things as well. So the idea that you can train up a group, another group of doctors or other people to do it as well, will look to be particularly challenging as well. This is anaesthetists who, have a high component of their curriculum is regional anaesthesia. Still many can't do it by the end of their training. The next issue is duration of action. So for a lot of trauma, we're going to need a duration longer than the duration of a single shot block. So that really means that we're looking at catheters and or whatever else is in the future. I think at the moment the liposomal is off in the UK as a general rule. So we're pretty much looking at catheters. Local anaesthetic systemic toxicity is obviously a really bad thing, and you can definitely die of it. And when you look at who gets local anaesthetic systemic toxicity, you'll see if it's red, you're more likely to. But fascial plane blocks in the elderly, where you've used a catheter technique, put you in a higher risk group. So we have got a negative for that. Having said that, with all of these things, these are unlikely events to occur, but they're disastrous when they do. We've done a lot of trauma blocks, and I've never seen anyone with local anaesthetic toxicity beyond perioral tingling. But it's definitely a risk. The final thing is motor blocks. So motor blocks definitely negative in someone who's got a lower limb injury, especially if they had a mortality from falling from less than 2 meters. If you're going to make them more likely to fall from 2 meters, that's probably not a very good idea. Especially if they're anticoagulated. So we know that trauma patients are likely to be anticoagulated. And that has been in the past a reason why people haven't done blocks. Thankfully, we've now got guidelines, European guidelines and American guidelines that suggest that fascial plane blocks and non-neuraxial blocks may well be safer to do than central neuraxial blocks. It's not an absolute contraindication. It's also worth remembering that patients who are anticoagulated who have major trauma are more likely to come to harm than other patients. So it might be up to 5 times the mortality if you're anticoagulated and have a high INR compared to the standard patient. So these are patients actually who may well benefit from regional anaesthesia because they are the higher risk, so therefore the ones that you maybe want to target. So with any of these, I think it's worth thinking about risk versus benefit, always, everything that we do, and having a very clear discussion about that. There are lots of benefits to regional anaesthesia, but ultimately it's pain relief, and there are risks of it as well. There's always risks. But if we do decide to proceed with the regional anaesthesia technique, it's also worth remembering that our risk-benefit doesn't stop there, that risk mitigation is really important. So that might be communication about what to do if the hemoglobin drops, to be aware that hematoma is possible, what to do if they have breathing difficulty with an interscalene block. That, when risk mitigation doesn't doesn't finish with the block. It's about how you manage the block afterwards as well. Graham talked a bit about a sock that could tell compartment syndrome. That's one of the reasons why people are not so confident to put blocks in patients that are at risk of compartment syndrome. You can see that some of the early signs and symptoms may be masked potentially by a block. This article here, Impact of Regional Anaesthesia and Masking Compartment Syndrome, review article that was a couple of years old now. 6 case reports ever where regional anaesthesia has been involved with compartment syndrome. In 3 of those, breakthrough pain was a feature despite a functioning block, so i.e. pathognomonic of compartment syndrome. The one that started it all, which is the problematic one really, is a compartment syndrome, a tibial shaft fracture missed because of a femoral nerve block. Now, if you understand your anatomy, then it's difficult to believe that the femoral nerve block would have been analgesic and also would have masked the compartment syndrome. So that was the first case report for it. There are, in the UK, guidelines about how to use regional anaesthesia for compartment syndrome, but certainly it's not quite the absolute contraindication. It does require good communications with your surgeons and a good working relationship with them, though. So there we go. That's major trauma and the role of regional anaesthesia. It's not this, it's this. We've thought about the demographics of trauma, the rationale for regional anaesthesia, and the potential challenges in adopting it. Thank you very much.
Thanks, Jono. Our next speaker is Dr. Fiona Macon. She's one of our acute pain and anesthesia consultants and also acute pain lead at South Tyneside and Sunderland NHS Foundation Trust. As we understand the role of trauma and also surgery on chronic pain, especially with the persistent post-surgical pain and chronic post-surgical pain, it has a huge impact, and she's going to share with us about our transitional pain services and how it can actually transform the incidence of chronic post-surgical pain and its management. Thank you, Fiona.
Right. Hello. My name's Dr. Fiona Macon, and I work, as Dr. Canetti said, at Sunderland and South Tyneside hospitals in the northeast of England. And I'm going to talk about transitional pain services, preventing chronic post-surgical pain. So to understand where I'm coming from with regard to transitional pain services, it's probably best to have a little look at what chronic pain is. And I think we all know the definition of chronic pain. But most importantly, the definition of chronic pain was highlighted and given its own chapter in the ICD-11. But we know it as pain that persists past or reoccurs for greater than 3 months. And there's an importance about having it highlighted in the ICD-11. It means that we can actually gain data, research, and quantify what happens to patients with chronic pain. Now, it was only about 10 years ago I was looking at data that said the prevalence of chronic pain was 1 in 5 patients, but actually it's actually increased to 1/4 of our population of adults in the last 4 years. And our health burden because of chronic pain shows that basically 50% of GP consultation is related to pain. And by proxy, £4.7 billion per year is spent on treating that symptom, generally put down to musculoskeletal conditions. But more importantly, there's a personal burden, and patients who suffer with ongoing pain, so that their function in their personal lives in society is diminished, and their well-being diminishes. Chronic post-surgical pain is a subset of chronic pain, and again, that's been highlighted in the ICD-11, and it's under MG 30.2. What is chronic post-surgical pain? It's persistent pain that continues after the trauma or the surgery, up to 3 months afterwards. The pain began or increased in intensity after surgery, and the pain is in the area or in the area of innervation from the surgical site. It will continue to persist but often get worse after surgery, but you have to exclude other factors that could have caused the pain, such as infection and malignancy or pre-existing chronic pain conditions in that area. Why is this important? And what highlights the patient who's at risk of chronic post-surgical pain? This is from a recent BJA education article, and it categorises quite nicely the risk factors to chronic post-surgical pain into the patient factors, and none of these areas are new to us. We know that someone who's from a deprived area, who smokes, who's of a lower educational level, as it comments, has other comorbidities, and also smokes or drinks, is more likely to suffer from chronic post-surgical pain. Females are more likely to suffer with chronic post-surgical pain. Those who are unemployed, we are getting increasing data on there's a genetic component to chronic post-surgical pain. The anaesthesia that we deploy is important. And looking in that outer blue circle, there is evidence about regional versus general, as we've actually already heard. And the type of surgery that you undertake. Now, that could be laparoscopic, it could be versus open surgery, and we know there's more evidence towards laparoscopic procedures actually reducing the risk of having chronic post-surgical pain. How long the operation is, and any complications. And then looking at the other areas that we know, such as trauma, that can cause that chronic post-surgical pain. The types of surgery that are more likely to cause chronic post-surgical pain are amputation, caesarean sections, mastectomies, knee arthroplasties, cholecystectomies, and inguinal hernia repairs. So why we keep on going on about chronic post-surgical pain? That actually chronic post-surgical pain is one of the greatest risk factors after surgery, and yet it's never mentioned on a consent form. It can last for months, and again, it's a burden to the patient, it's a burden to society and to our healthcare. So we're going to talk about chronic post-surgical pain. We know it begins with some sort of trauma, acute pain. It leads on to chronic post-surgical pain, and there must be a bit in the middle, and that's transitional pain. So if we can identify an area between acute and chronic being transitional, and the chronic bit of the initial trauma is our problem to the patient and to society, then surely we can work around trying to reduce and prevent pain going from acute pain into chronic post-surgical pain. So what can we do? We've got the acute pain, we've got the chronic post-surgical pain. Where should our service help out? It can help out in that transition bit between acute and chronic, but it also, as we said, we can highlight risk factors for patients for chronic post-surgical pain. We can also front-end it, and we can highlight those patients before they come into surgery. Unfortunately, we can't always highlight who's going to fall 2 meters and break their neck or femur, but we can highlight those who are having elective surgery. And this can be in an envelope of a transitional pain service. And if we look at what we already do, and we look at the surgery we already do, we can come up with a model a bit like this. The surgery in the middle, we can adapt our anaesthetic skills, and we've talked a lot about how regional anaesthesia can help. We can adapt our surgical approach, but we can also make contact with the patient, identify patients who have risk factors for chronic post-surgical pain, and then we can, once they've had the surgery, we can follow them up and hopefully all prevent or reduce chronic post-surgical pain. So what does this look like, and who has already done this? So transitional pain services. The main pioneer is a gentleman called Hans Clark out in Toronto, and they've got a transitional pain service, but mainly looking for mopping up people who've had an incident or a surgery and now are in that transitional pain zone between acute and chronic. Transitional pain services have the ability to pick up these patients, manage them, and again, resist them going into that chronic pain area. And there's increasing evidence and increasing interest. So from multiple studies showing the feasibility of services, to the Toronto guys picking up their data and showing actually really great outcomes, to reducing patients being a burden onto themselves and society. They've shown in back surgery, in knee surgery, in caesarean sections, that their outcomes are beneficial. And we'll see it in actually a lot of the guidelines that we see through opioid stewardship, because if they're not in pain, they're not going to have opioid consumption, as great as we've seen in the past. And we'll see it in PQIPs. And it was actually saying about individual, in recent years, individualised pain management schemes for each individual patient. What are we doing in the Northeast? So, we're part of a deep end network project, TAPER studies. It's quite a large acronym, but it's the primary care professional experiences for reducing opioid and gabapentinoid prescribing in socioeconomic disadvantaged communities, mainly in the Northeast. So we are part, in our region, of a TAPER study, and that is working with primary healthcare services, i.e. GP trusts, GP's practices, sorry, on the recognition that in the Northeast, 2/3, we have a very large cohort of patients, as in we have the largest, out of the 2/3 registered drug poisoning deaths in 2021. In the Northeast, we had the greatest proportion of those happening here, out of England and Wales. So we know we have a problem with drug addiction leading to death. Who prescribes the pain relief? It's primary and secondary care. And we know that when patients come in for an operation, they're more likely to be prescribed opioids and go home on opioids. And we also know that patients that come in on opioids are going to persist being on those opioids and generally increase them. So we've worked together from our secondary service, pain services, with the primary services to try and highlight those patients coming in for elective surgery, contact the patients, counsel them, work with social prescribing to reduce their opioid intake before they come to theatre for their operation, and then follow them up afterwards. Now, we're in Sunderland and South Tyneside, we're still in that phase of actually doing the project, but our colleagues over in the RBI in Freeman, part of Newcastle upon Tyne Healthcare Trust, have already completed their TAPER study. And so what they did, they worked hard with the primary healthcare services, and they identified the patients that were on waiting lists and who were on opioids or gabapentinoids. They used social prescribing support. The acute pain services communicated with the GPs, educated them on opioid de-prescribing, educated the social prescribers on how to support patients who are on opioids to reduce their opioids. They contacted the patients, they came in, they asked if they wanted to be part of the scheme, and they followed them up with the results afterwards. Their results were inspiring. 9 out of the 14 deep end network GP practices, as in GP practices for very deprived areas, took part. 198 patients were invited to speak with the social prescribers and the GPs after having education from ourselves. 67 out of the 127 patients that accepted to be part of the trial accepted social prescribing. It's really easy to sort of underplay the role of social prescribers. We think by monitoring or adapting what we prescribe is really important. It is. But if that patient is requiring pain relief, not for pain, but to take them out of a situation which is wholly unideal for them, as in they're living with abuse, they are looking for work, but they can't get work. Their burden from other caring responsibilities is too much, or they're selling their medication for drug money or for just supporting their family. So often is the case. Actually, the social prescribers can come in, help them look at what benefits they're allowed to have, make sure that they've got a warm home, that they have food that they can access to feed their family, and actually support their mental health. Their requirement to run to medication to help their situation is reduced. So, the role of the social prescriber speaking to the team, and that's Angela Telford and James Prentice, who worked in the Newcastle Trust on this project, really were impressed about the role the social prescribers played in this study. So they helped with mental health, they helped with their referral to weight loss programs, smoking cessation programs, sleep clinics, benefit advice, getting them out to exercise classes, really basic, just helping people live their lives. But the other part of really interesting work is just by coming and talking about their opioids, patients, we're talking about, they got 90 patients out of the 127 that accepted the study. 90 of those patients said, yeah, we'll come and have a chat about it. And out of those 90, there was a 64% reduction in opioid and gabapentinoid prescriptions. 30% of those patients stopped taking opioids altogether before their operation. And 3 out of those 90, patients accepted deprescribing support. And one of the big helpers were just helping with communication. So patients often wouldn't know why they were asked to go to physiotherapy before their operation, because they thought they were going to do physiotherapy after they'd had the operation. But with the support from the social prescribers and the primary health care, that they were allowed to sort of accept that physiotherapy, knowing that was going to benefit them for after surgery. And by reducing the opioid consumption before surgery, reduced the intake of opioids after the surgery. So taking this really positive result, and we're still in our taper study, so we're in taper 4. We're quite excited to see what our results are. Taking what we've done pre-operation of identifying, coming up with an analgesic plan, having some social prescribing involved. Social prescribers are often volunteers or a Band 2 healthcare service. So really quite low cost, just a casual lay person coming to talk with patients. Having psychology help and physiotherapy input can help us on the way of delivering a service that can help patients actually function after their operation rather than be burdened with chronic post-surgical pain. We rely on our anaesthetic and surgical colleagues for appropriate multimodal analgesia and appropriate surgical intervention. Myself, I lead on an acute pain service. We review these patients as they come into hospital. We greet them when they come in. We see them after the operation, making sure that we're adapting their analgesia and giving them a game plan, giving them a discharge plan of how to take their opioids, when to take their opioids, and when to reduce them down. And to also take advantage of other things, using physiotherapy, using the other adjuncts, and allowing them to think positively that pain is going to be there, it's part of the healing process, but actually will get better as you mobilise. And then following them up afterwards, giving again a clear opioid tapering plan. Calling them up, making sure they're back in touch with their social prescribing. If they need psychological help or physiotherapy, that they're getting in touch and having touch points with those professionals. But most importantly, is collecting the data on what we're doing. As I will show you, we are at the beginning. There is increasing interest because of the new definitions that we have, and people can collect data referencing those new definitions, such as chronic post-surgical pain. GIRFT in the next 2 years is collecting data, collecting thoughts from patients and professionals about how we're going to move forward managing chronic pain, and chronic post-surgical pain is a limb from chronic pain. but we need investment. And it is ultimately multi-service basis, not just one service. It's across the services. So I'll leave it there. There are my references. Okie dokie.
Thank you, Fiona, for an excellent session on the transitional pain service and where we are heading with that. With that, we'll go on to the next session, which is update in obstetric anesthesia. We have Professor Nuala Lucas's lecture, which is already pre-recorded, which I'll play it for you.
Hello, my name's Nuala Lucas, and I'm delighted to be with you on 3rd World Day of Regional Anaesthesia and Pain Medicine. Over the next 20 minutes, I'm going to be talking to you about a little bit of what's new in the literature for obstetric anaesthesia. And to try and frame this conversation, I want you to think about a case. Sarah, she's 32 years old, having her first baby. She's got a slightly elevated BMI with mild preeclampsia, and her labour is being induced at term. Unfortunately, she develops some fetal distress, and she goes to have a caesarean section. And the areas that I'm going to look at are pain during caesarean section under neuraxial anaesthesia, airway management during obstetric general anaesthesia, obstetric hemorrhage, and post-caesarean section analgesia. So first up, this really nice systematic review and meta-analysis published last year in Anesthesiology that aimed to provide an accurate estimate of the incidence of patient-reported pain during caesarean section under neuraxial anaesthesia. They looked at a huge number of studies over a considerable time period and ultimately included 34 manuscripts from 20 different countries. Now, before I talk to you about the results, I just want you to think for a moment about what you might estimate the incidence of pain during caesarean section when you do a spinal or top-up and epidural. And the reason I say that is that I was surprised about the results. These authors found that there was a pooled incidence of patient-reported pain of around 17%, so about 1 in 5 women. For spinal anaesthesia alone, it was a bit lower, around 1 in 7, and for epidural top-ups, it was quite a bit higher, around 1 in 3. Now, this systematic review did suffer from the usual problems of systematic reviews, significant heterogeneity. So while these figures may seem quite high and perhaps not what we were expecting, I think they do draw attention to the fact that it is still a significant problem for our patients and for us. Now, before I draw conclusions about this area, I want to consider another very interesting manuscript that was also published last year. And this paper aimed to look at whether patient-anaesthetist interactions, including unconscious attitudes, influence the way we manage intraoperatively pain with IV analgesics or anxiolytics. What they did was a prospective observational study, 502 patient-anaesthetist pairs. The patients all received a fairly standard spinal anaesthetic with local anaesthetic and opioid, and the block was tested in the fairly usual way. Anaesthetists were then able to give adjuvant analgesics or anxiolytics according to their own preference if the patient experienced pain. There was no specific written protocols to guide what they did in this scenario. And how they assessed the patient anesthesiologist interactions was by using custom transference and counter-transference questionnaires. So a counter-transference questionnaire assesses the clinician's emotional response to the patient. I felt close, attached to this patient. I felt protective. I liked the patient. And the transference questionnaire assessed the patient's feelings and expectations projected onto the clinician. I felt the anaesthetist understood me, cared about me, I trusted them. And to try and provide an objective assessment, they captured the results of these questionnaires on a Likert scale to quantify the interpersonal tone of the encounter, and then looked at the association of these results with whether a patient received any additional analgesics or anxiolytics and whether the anaesthetist gave them. So what did they find? Well, perhaps consistent with the findings of the previous systematic review I mentioned, around 10% of women reported intraoperative pain. 22 received intravenous supplementation of any sort, and perhaps surprisingly, anxiolytics were given 4 times more often than IV analgesics. And remember, an often repeated mantra in this scenario is it's pain, it's not anxiety. There was a lower odds of supplementation when the patient had a higher income or shared a language with the anesthesiologists. And I think perhaps most concerning, anesthesiologists who felt more attached, close to their patients, perhaps liked their patients a bit more, were more likely to give medication. And I think this is probably the most concerning thing, whether you like your patient has an impact perhaps on how you treat them. So pain during caesarean section, what now? Well, I think we need to be honest and provide preoperative information. No matter how good your spinal or your epidural top-up, how adept you are, and you're using a good dose, there are limitations to our techniques. We block nerve fibres that carry pain, but we do not always block the nerve fibres that carry push and pull and pressure sensations. And remember, if somebody's squeezing your hand very firmly, that's pressure, and it can be quite uncomfortable. It's not pain in the same way as a scalpel might be pain, but it's uncomfortable nevertheless. So I think we need to be honest with our patients about the limitations of our techniques, but also reassure them that if they experience pain, tell us and we will treat it. I think we've got to be cautious about under-treating pain. If the patient reports pain, we should stop the surgery, acknowledge it, inform the surgeon, and use fast-acting IV analgesia when needed. And my preference in this scenario is fentanyl. And I think we have to be careful about avoid defaulting to it's just anxiety. Now, the final point, I haven't written it down, and I want to say it with some caution because I'm certainly not encouraging people to give a general anaesthetic. But I suspect that we probably need to use, certainly in a well-resourced environment, general anaesthesia a bit more often than we do. But I'm not actively encouraging general anaesthesia. And finally, I think we need to measure and learn. We need to track our local rates of intravenous supplementation. It may be entirely appropriate, but if the rates are going up a lot, we might need to think and consider why this is and perhaps do something about it. Now, the next thing I want to talk about is airway management during obstetric general anaesthesia. These are 2 manuscripts looking at the use of video laryngoscopy in the first one in obstetrics alone and the second one in non-obstetric patients. And video laryngoscopy is very much one of the zeitgeist areas of modern anaesthetic practice. Now, despite the fact that we all worry about the obstetric airway, video laryngoscopes have been relatively poorly studied in obstetric patients. And that's one of the reasons why I like this very nice science letter that was published in ANA last year. It's a retrospective before and after single academic institution study. And they looked at the use of video laryngoscopy in centres in their centre before the COVID pandemic and then in the period after the COVID pandemic. And their primary outcome was the proportion of video laryngoscopy or direct laryngoscopy use with the usual sorts of airway secondary outcomes. So what did they find? Well, perhaps unsurprisingly, video laryngoscope use increased from around 25% to just over 70% in the period post-COVID. The first pass success rates, there was no difference whether or not a videoscope or direct laryngoscopy was used. The laryngeal view was a bit better with video laryngoscopy, but surprisingly, or not, depending on your views on this device, intubation was reported as slightly more frequently occurring with video laryngoscopy. So what now for airway management in obstetrics? Well, to me, if you've got a video laryngoscope available in your institution, it does make sense to use it. And the particular reason I think about this is the shared view. Someone else can confirm that the tube has gone down the right hole, and that if there's a problem with ventilation afterwards, at least you know the tube is in the right place. But one thing I think about videoscopes, and I think this about a lot of new kit that comes along, we've got to be careful about device hype and not expect magic gains in first-pass success rates just from switching devices. And for me, huge priorities for airway management in any scenario, not just obstetrics, remains good pre-oxygenation, positioning, and having a clear plan B. And if I had to pick one aspect of this out that I would particularly highlight, it's the positioning issue. In all the kerfuffle and excitement about video laryngoscopes, I think we sometimes forget to do those basic things really well. And positioning, getting the patient's head in the optimal position for intubation, and you can do this during the pre-oxygenation period, I think is absolutely critical to ensuring, one of the factors to ensure successful intubation. The fact that this little study found that there were more difficulty ratings with video laryngoscopy perhaps reflects operator inexperience and not true deterioration. And what I've taken from this is that one area I think we should be considering is trying to identify the best devices to use in the obstetric patient. And finally, what I think we've got to be careful about saying is that this study does not prove that VL is superior for hard outcomes in obstetrics. It's a retrospective single-centre study, subjective difficulty ratings, no operator experience data available. Now, the next thing I want to talk a little bit about is obstetric hemorrhage. And I would urge you to take a look at this excellent systematic review published in The Lancet last year. It's a huge analysis of the causes and risk factors for postpartum hemorrhage globally, looking at around about 850 million women. So what did they find? Well, the cornerstone of causes of obstetric hemorrhage remains the 4 Ts. It's a good teaching tool and it's a good clinical tool to use when you're in this scenario. And uterine atony remains the major cause of obstetric hemorrhage globally. Another point I want to highlight is that coagulopathy as a primary cause of obstetric hemorrhage is a very, very small proportion. So if you're in this scenario and the surgeon is saying to you, oh, I think it's the coagulation, urge them to look again. As a primary cause, it's very, very unlikely. The other point I want to make is that in around 8% of cases, multiple concurrent causes exist. So the woman may have an atonic uterus, but she might also have a bit of placenta stuck that's stopping that uterus contract. So just because you've sorted out one problem, if the woman's still bleeding, look again. And I might just quote Rob Dyer, one of the true greats of obstetric anaesthesia, and he always says that one of the most important factors in managing obstetric hemorrhage is factor A, and I'm sure you can all guess what factor A is. Now, in this study, they looked at risk factors that had a strong, moderate and weak association with obstetric hemorrhage, and I'm just going to look at the factors that had a strong association with obstetric hemorrhage. So factors here, some of them mostly unsurprisingly, previous PPH, caesarean birth, if a woman's septic, if she's not had any antenatal care, if she's got a multiple pregnancy. The one I particularly want to mention is anemia. There's physiological reasons that if a woman is anemic before delivery, she is more likely to have a PPH and be anemic after delivery. And I think what I've taken from this is that if you meet an anemic woman antenatally, you should really consider what you can do to support the obstetricians, bring that woman's hemoglobin up. And I think intravenous iron preparations are much safer these days, have a much less risk of anaphylactic reactions associated with them. And I think they have an important role. It takes about 7 days for intravenous iron to kick in, but I think we should be using probably a bit more than we do. How to summarise this manuscript in total on obstetric hemorrhage? Well, uterine atony is the leading cause, as I've said, and we've got to use prophylactic uterotonics. recognise that multiple concurrent causes exist. And I think this really behoves us to use a bundled treatment approach. So alongside uterotonics, think about other strategies that you can do. Consider modifiable risk factors, as I've said, and anemia is the obvious one to me. A final point I just want to highlight is that, as you all know, if you work on a labour ward, many women who experience obstetric hemorrhage don't have modifiable risk factors. And this really behoves us to have advanced preparation strategies, make sure we've got PPH trolleys available, make sure we train together as a team. So when we're in this scenario, our response is really optimal. Now, just before I finish on this topic, I want to talk about this systematic review about the use of tranexamic acid for postpartum bleeding. It's a systematic review again. They looked at 5 trials, more than 50,000 women, and the trials they looked at included TXA used as treatment and prophylaxis. Their primary outcomes were life-threatening bleeding and thromboembolic events. So what did these authors find? Well, unsurprisingly, the use of tranexamic acid was associated with a decreased risk of bleeding and no increase in thrombosis. But before we all start using it for every single patient, while the relative risk reduction was significant, the absolute risk is very low for most women. The number needed to treat for high-risk women is about 500, but for low-risk women, it's around 43,000 to prevent a single severe case. And I think, despite the findings of this study, I think we need to be cautious about uncertain harm in low-risk groups. And what I particularly worry about, if we have loads of tranexamic acid floating around on the labour ward, if we're giving it to every patient, is the potential risk for intrathecal or epidural injection. Tranexamic acid is a horribly neurotoxic drug, and if we've got more of it available on the labour ward, I think there is concern that it might end up in the wrong place. So while I firmly believe tranexamic acid has an important supplementary role once hemorrhage is ongoing, I don't believe we should be giving it routinely prophylactically. Now, the last thing I just want to touch on is post-caesarean section analgesia. There continues to be a bit of debate about the optimal dose of preservative-free intrathecal morphine for caesarean section. Now, the first study I've put up here is a prospective non-inferiority trial looking at 50 mics of intrathecal morphine versus 100 mics. These authors found that 50 mics was non-inferior to 100 mics in terms of analgesia and side effects and satisfaction. The second study was a retrospective cohort study looking at 150 mics versus 100 mics. Now, they found that 150 mics was equivalent to 100 mics in terms of the patient's additional post-operative opioid consumption. But with the lower dose, there was a decreased incidence of nausea and pruritus treatment. So for me, I think these studies very clearly demonstrate that 50 to 100 mics of intrathecal morphine combined with paracetamol and nonsteroidals appear appropriate for elective caesarean section. And if you increase the dose above that, you don't get added benefit, but you do get an increased risk of side effects, including nausea and pruritus. For me, I think that using 50 mics of intrathecal morphine really does start to use absolutely tiny volumes of injectate that you're potentially adding to your spinal local anaesthetic. And I tend to stick to using 100 mics. It's 0.1 of a mil of the preparation we have in my hospital, and it's just a little bit easier to draw up and prepare. Now, the very final thing I want to touch on is the use of paracetamol in the antenatal period. And this received quite a lot of attention when some news from the US, Mr. Trump suggested that use of antenatal paracetamol was associated with the development of autism and ADHD in children subsequently. This excellent systematic review and meta-analysis has recently been published just in this month in Lancet O&G Women's Health. What these authors found was that there was no association between prenatal paracetamol exposure and autism, ADHD, intellectual disability in sibling comparison analyses. And these findings were consistent in low risk of bias studies in those with more than 5 years follow-up, supporting current guidance that paracetamol remains appropriate first-line analgesic and antipyretic when used appropriately in pregnancy. And I think we can absolutely refute Mr. Trump's suggestions. So, Sarah's journey. What can we tell her before she embarks on all of this, perhaps? Well, I think let's be honest that pain during caesarean section probably occurs a bit more frequently than we may have previously believed. It's got a slightly higher incidence with epidural top-ups. We've got to get better with our discussions. We've got to be proactive about intraoperative supplementation and honest reassurance. Anaesthesia for GA section. VL use has risen sharply. The views you get are better, but outcomes are similar. And I really would emphasise this particularly. Training and planning matter more than any single device. Let's not hype these devices too much. Obstetric hemorrhage, uterine atony is still the leading cause. Use TXA in high-risk women and take care when it's around the labour ward. If it's given intrathecally or epidurally inadvertently, the result is almost universally fatal. Post-caesarean section analgesia, intrathecal morphine, 50 to 100 mics is effective. Higher doses increase side effects without extra benefit. Thanks so much for listening and enjoy your day.
Joining us with her exciting and very informative session. So next we are going to move into the next talk. It's by Dr. Su Ying Ong. She's a pediatric anesthetist. She works in NHS Lothian in Edinburgh. She's also associated with RA UK, and she's a practicing regional anesthetist, especially in kids. Unfortunately, she couldn't join us live today, but hopefully she'll join us later for Q&A session. But she has kindly sent us the link to her talk, which we'll play now.
For having me. My name is Su Ying. I'm one of the consultant pediatric anaesthetists in Royal Hospital of Children and Young People, Edinburgh. And I've done a year of fellowship at Alderhay Children's Hospital. And I do a regular orthopedic list and a lot of regional anaesthesia teaching locally, as well as in workshops and conferences. I'm also the co-chair of the APA GBI Education and Training Committee. I'm here today to hopefully talk to you about a brief overview of regional anaesthesia in pediatrics, looking at why do we do regional anaesthesia in pediatrics, what are some of the challenges, pediatric plan A blocks, some example cases, and some of my top tips. So why regional anaesthesia in pediatrics? Regional anaesthesia has become a cornerstone of modern anaesthesia. Unlike adults, where regional anaesthesia can be done as the primary anaesthetic, in children it is almost always done under general anaesthesia, mainly to provide high-quality pain relief during and after surgery. Speaking of superior analgesia, the most significant role is by providing targeted pain relief by blocking a specific nerve and numbing certain areas. So it can often be a lot more effective and much better than intravenous medications like opioids. And that brings us to by using blocks, we're able to give an opioid-free or opioid-sparing anesthesia. As we all know, all the negative side effects of opioids, which includes things like respiratory depression, nausea, vomiting, constipation, and sedation, which is often more of a concern in kids. So doing regional anesthesia will be able to minimize all these effects. We can also use less GA drugs because most often than not, we don't paralyze kids. So we can run them on a deep sedation level when we have a good working regional anesthesia, which is always a good thing for developing brain. it's much better for the patient. Regional anesthesia contributes to a much smoother wake-up for the child, and things like reducing emergence deliriums, keeping them comfortable, so when they wake up, they're happy, and they're not sore, they're not confused, and that then again leading to facilitating faster discharge, because they're less nauseated, they're more comfortable, they can eat and drink quicker, and they can go home quicker for the day cases. And for the more major cases, like orthopedic and major abdominal surgery, we can facilitate early mobilization using regional anesthesia, which could all lead to earlier physio and earlier discharge as well. Some of the challenges that we face in regional anesthesia and pediatrics. We're concerned about local anesthetic toxicity and nerve injury because we do a lot less in kids than we do in adults. But we have done multiple big studies which has shown that regional anesthesia is safe in pediatrics and very, very few complications. And most of the complications are related to local anesthetic toxicity from caudal. So if we aim to go as peripheral as possible, it's actually a lot safer. And this paper has led to the consensus from ESRA and ASRA that there's sound evidence to recommend that regional blocks can and should preferably be performed under anesthesia or deep sedation in children of all ages. And as we all know, this year we will have the NEP8 coming up as well, which will inform us more about the safety profile of regional anesthesia and the complications. So we'll be looking forward to that. There's also the perception that children are not liking the sensation of paresthesia post-op, and that parents and patients will be reluctant to consent knowing the risk. From my experience, with adequate information of explanation of the benefits versus some of the risk, most of them do consent. And our UK do have generic leaflets that we can use, but my colleague in Dundee has also created a really useful infographic which we have adapted for our patient info leaflet, which explain the benefit and the risk. We also believe that technically it can be more challenging. While it may be true in terms of smaller needle movement, because everything is smaller, it require more precise movement. But typically, kids do have nicer anatomy, and everything is much clearer. And also, because everything is more superficial as well, you have easier needle visualization. So I don't think that it is technically more challenging. So it's definitely worth thinking about practicing. There's also a perception that regional anesthesia takes a lot longer, and hence pediatric surgeons are not liking it. I mean, I will have to say, I mean, it's an additional procedure. It does add time. But it is better for the patient. And I always give them the example of their lap appendix. It takes longer to do than open appendix, but the outcome is better for the patient. So after they've seen the benefits, they're now asking for it. And actually, a few of my surgeons are the reason why regional anesthesia is increasing in my department, because they are asking my other colleagues to do them. The other challenge would be training and education, because it's never used to be a core skill, but this is now a change. So we need to upskill in order to train. So now I think in PEDS is a really good place to teach and to learn, because we do pretty much all of our blocks asleep. So it's a much kind of better training opportunity for the trainees. So I think upskilling ourselves is useful. Things like courses, simulation, deliberate practice is key, and therefore we have acquired grant to get a needle trainer, which I use for my weekly block club teaching. And with this in mind, with the Pediatric Anesthesia 2021 curriculum, which suggests that we should all be able to do simple regional techniques for surgeries routinely performed in district general settings. This will nicely bring us to the concept of pediatric plan A blocks, which was introduced by Annabelle Pearson and Steve Roberts in 2022, which is an editorial in anesthesia, in Peds Anesthesia. And it's a similar concept to adults, and where they have we have 7 core blocks that we should all be able to do. And some of the blocks are similar to adults and very transferable to peds, so won't be spending too much time dwelling on that. And some can be done landmark, even though ultrasound would be preferable. So these are the 7 plan A blocks. And there's QR code there. That will bring you to the editorial, which is excellent read. The other thing that is really useful in the editorial is the local anesthetic doses, which you can see there, the suggested doses and the indications of when you can do them. And the maximum safe dose recommended is 2.5 milligrams per kilogram, or essentially a ml per kilo of 0.25% levobupivacaine. So very quickly to go through the 7 plan A blocks, this axillary brachioplexus block for analgesia for the elbow, forearm, or any hand surgery. Positioning is quite similar. The only thing to say is that this is going to be one of the block where everything is just much smaller, everything is closer together, so it's just tiny needle movement. Always aspirin, because there's just a lot of vessels around there, not just your main axillary artery. Popliteal-sciatic nerve block is an analgesia for your any leg, ankle, foot surgery, fracture, tibial osteotomies, tendon transfer, lengthening, clubfoot repair. Only thing is it doesn't cover the medial side, so you need to remember to try and cover up the saphenous if you're doing anything on that side. Position-wise in peds, we almost always do them laterally. Sometimes if I have to do bilateral, I prone them. And the only thing to think about is the bifurcation can be quite low. It's not the standard sort of 6 to 8 centimeter above the popliteal fossa. Femoral nerve block, analgesia for femoral fracture, surgery, any fixation, femoral osteotomy, sufis. Very, very similar to adult. Only thing in peds, sometimes it can be quite lateral, so just make sure you scan a bit more laterally to make sure that you don't miss the nerve. Rectus sheath blocks, analgesia for midline surgical procedures, which we don't do very often in pediatrics, but we still do. Open pyloromyotomy, and more commonly in peds that we do them for is for pec insertion. It can be quite sore afterwards, and we always have to do a bilateral block for this block because of the cross innervation of the nerves. Lateral quadratus lumborum block is a very, very versatile block. Analgesia for abdominal surgery below the umbilicus, anything from the umbilicus down to the groin, like open appendectomy, inguinal hernia repair, orchidopexy, and anything stoma formation, just basically anything from the umbilicus down to the groin. It's a very versatile block. It's easy to do in kids because anatomy is a lot more superficial, and essentially it's an extension of posterior tab, which some of you would have done. And it also has some visceral cover versus tab, which is why it's a lot more useful. Dorsal penile nerve block is analgesia for circumcision and distal hypospadias repair, and it can be done landmark, but ultrasound does increase the success rate. So you can see there from the ultrasound image, it is very superficial, and when we're doing an ultrasound, we just usually go a bit more distal, and it's the only block that I would use 0.5% for, just for the because it's a tiny volume and it's for the speed of onset. Caudal is still a plan A block, and it's a central neuraxial block because it's still a very versatile pediatric block. Analgesia for bilateral hernia repair, orchidopexy, hypospadias, anorectoplasty, and any bilateral lower limb surgery, abdominal surgery for the younger ones. It can be done, usually done landmark, can be done with ultrasound. Landmark technique is already quite safe and low failure rate, but ultrasound does increase the success rate and reduces the attempts and a failure rate. And it also is reassuring if you, then you can see if there's any abnormality to the sacrum, like cord tethering, and you can also reassure yourself when you look at the ultrasound, the dural sac is actually quite far from your needle insertion point. And with the recommendation of using NR fit, some people are not comfortable using the needle with a landmark technique, so using ultrasound, doing it like any other block is also quite useful. Some of the example cases that you may come across, the kind of blocks that be useful to use. The more commonly we general surgery and orthotrauma less. So general surgery, umbilical hernia repair, rectus sheath, bilateral rectus sheath blocks, inguinal hernia repair. Plan A, I would say lateral QL block is going to be the best, and you then there's nothing wrong if you are more comfortable with caudal. It's also the other plan A, or if you are familiar with doing either inguinal or either hypogastric. The 2 QR codes up there brings you to papers that gives you the evidence that actually QL is superior versus caudal for hernia repair, and also versus TAP and either inguinal or either hypogastric. So my recommendation would be QL. Circumcision, ultrasound guided dorsal penile block, or you can do landmark technique. Orchidopexy, again, QL, and remember to give your surgeon some local for the scrotum because it's not covered by the block. Appendicectomy, lateral QL blocks. I say blocks because if you do open, then you do single side. But I do bilateral QL blocks for laparoscopic appendicectomy, and most of them will not require intraoperative opioids and reduction in postoperative opioids. We have looked at about 200 cases, and there is clear benefit in complex perforated cases in reducing the opioids, probably because of the visceral cover. Orthotrauma, ORIF supracondylar or radius ulnar fracture, axillary brachial plexus block would be your plan A. If you're more familiar doing supraclavicular, nothing wrong with that. Or if you're like me, big fan of infraclavicular, again, nothing wrong with that. Any X-fix for open tip fib fracture. Popliteal, I usually put in a catheter and also doing femoral nerve block or adductor canal to cover the medial side. Femoral fracture, femoral nerve block, and depending on incision, you might have to cover the lateral cutaneous nerve of the thigh. Or you can just do, if you're more familiar with suprainguinal fascia iliaca block. ORIF ankle, popliteal, again, if it's a medial ankle, don't forget to cover your saphenous. One thing I do quite a lot of is a pelvic femoral osteotomy for DDH. Again, caudal is your plan A, but if you want to, if you're like me, you prefer to block single side, because if you're doing one side, you can just block one side, and peripheral nerve block is 6 times safer than central nerve blockade. You can think about doing anterior QL block. Some of my top tips. Positioning and ergonomics. So we always think, oh, we're already taking so much time. We'll just quickly bash this block in. But actually taking your time to set up will actually save you time in the long run because you can see your pictures better. You can do your needling better. So I always say, just like intubation, you want to make your first attempt the best attempt. Probe movements wise, remember the various probe movements, making small adjustments to visualize the nerve, which is a lot of nerves exhibit anisotropy. So tiny movement will bring the nerve brighter, and also to find your needle tip. Sometimes you need more pressure than you think, especially doing QLs, which is usually why I get a lot better picture than the trainees when I do them. Needle-wise, big and blunt is better than small and sharp, and also think about your length. So the big and blunt needle reduce the risk of skewing the nerve, and in terms of length, if you think about that you have to use a long needle, just go for the long needle, because you can make a long needle shorter, you can't make a short needle longer, and then you have to start again. The probe footprint wise, the larger the better. we are so used to using small footprints probe in pediatrics, the hockey sticks, for example, and we like to reach for them because we think it's kids. But if the larger linear probe fit on your kid, just use it, because I always say the more you can see, the better it is. Local anesthetic and adjuncts usually use 0.25% levobupivacaine because the kids' nerves are incompletely myelinated, so you don't actually need anything more than 0.25% to have a good block. And as a general rule for me, you can look at the table, but as a general rule for me, 0.1 to 0.3 mils per kilo for nerve block, 0.3 to 0.5 mils for plain block, up to 1 mil per kilo max. And I always use IV dexamethasone, 0.2 milligrams per kilogram, up to the adult dose of 6.6 milligrams, and they're as good as perineurodex in adult studies. I always say that always check your block, intra-op, post-op if you can. It's okay to fail, but it's not okay to recognize that you've failed and act accordingly. Like, you can do other things like repeat the block and also give opioids. I have nothing against opioids. If we need it, we need it. And also using multimodal analgesia. Even with a good working blocks, I still always use multimodal analgesia like clonidine, dexmedetomidine, and magnesium, paracetamol, and non-steroidals. Sometimes ketamine as well. I think in summary, regional anesthesia is good for kids. Embrace the Plan A blocks. Always weigh the risk versus benefit. A sleep is safe. Go as peripheral as possible, and a follow-up is important. These are some of my useful resources that you can find. The Pediatric Plan A block from IRA UK. Now they have the Plan B, C, D block upcoming, which is really good. Each of my page will see, the QR code will bring you to the ESRA one page for each of the Plan A blocks. Baby blocks, US based, really, really useful. APA GBI webinar that you can look up for. These are the more kind of adult, non-specific sort of PEDS one are the Enzo app, Nysora, the Block It Like It's Hot podcast, and some of the YouTube videos from Keaton Chint and the RFPM Duke Anesthesiology. Thank you very much. This is my email. Feel free to email me if there's any questions, and I'll take questions. Thank you very much.
Thank you to Sue. She's actually online with us now on Teams. Thank you to all the speakers. Now we'll take questions.
Just got to take all the microphone all the way to the back.
Hello. Hi. Hi, that was a really nice talk. I'm thinking about using more abdominal trunk blocks in pediatric general surgery procedures, things like inguinal hernias and so on. Is that something you would use a QL block for? Because where I've run into resistance from the surgeon is they don't like to have anything injected into the tissues before they do the operation, because they rely on the feel of the tissues to do the operation. But the QL is obviously a long way away from the site of a hernia or orchidopexy, etc. So is that a block that you're using for those operations?
Yes, definitely. That's the block that we use for a lot of our general surgery because it's so versatile. Anything from the umbilicus down to the groin. So definitely inguinal hernia is, there's evidence that it's better than other blocks. And also, like you say, it's quite far back. So our surgeons are actually really happy with it because it's not obscuring their field and it actually works really well. And even like other abdominal procedures, you can put catheters in from posteriorly and it's completely out of their way. So my surgeons are actually loving the QLs.
Great, that's really helpful information. Thanks.
Hi, so a question for Fiona. Thanks. This is Ash Gupta. I'm the anaesthetist at Gateshead. So obviously the transitional pain service is a reasonably newer concept, which more people are getting aware. It makes all sense. So, one of the slides, you had this pre-op surgery and post-op where we can make, intervention and hopefully help in reduction of chronic pain. So in the surgery section, you had appropriate multimodal analgesia and acute pain service review. So again, my question as a regional anesthetist is where exactly the role of regional anesthesia fits in the, that's the only place where we can intervene, and how does that affect, and is there any specific mention you think we should mention it more clearly rather than saying multimodal? I don't know if I've made myself clear there.
Can you hear me on? All right. Yeah, yeah. No, thanks, Ash. I think that's a great question. And I'm a big fan of working together with my regional colleagues for surgeries that we know are really high risk for persistent post-operative pain. In the areas that you're talking about, actually you're wanting to know about, and when we just sort of say, it's like ask for a second pair of hands or multimodal analgesia, regional anaesthesia is really important to be part of those big high-risk groups, such as your amputations, which we already do, so certainly at Sunderland and South Tyneside, that we have those indwelling catheters in infusing local anaesthetics. So amputations are the big hitters. We don't do any breast surgery where we work, but that would be certainly somewhere that I would consider that to be really useful. And then looking at your orthopedic side of surgeries, the knee replacements, what kind of block can you put in there, and making that a standardised process. So I think, one, looking at your own data, looking at post-operative persistent pain in these patients that we've already highlighted nationally that are at risk, but look at your own system. Are you together in your thinking? Have you got a standard within your trust? And if you don't, get the key players within that service together and ask what people can offer. I think actually coming together and standardising what you do is a better way than having an odd sort of someone doing multimodal and some people not, but actually bringing people together in the same room who are all invested with that patient's outcome, and looking at your big hitters. So vascular amputations, orthopedics, specifically knees. The other ones, as I said, inguinal hernia repair, laparoscopic cholecystectomies still. However, with those, we don't have a standardised process, but for us it's something that we could definitely look at. I'm not entirely sure where regional will come in on that, but that's where myself and people like Dr. Haslam actually work together, and we talk about our outcomes and see if there's anything that we can improve on, certainly for day case surgery as well, for that's another area that we like to look at and improve on. So the main areas that we look at are vascular amputations, knees, orthopedics. I think that helps answer the question, doesn't it?
Just following up on what Fiona's saying there, we try and work together as closely as we can, and we're sitting here in the room today, so I think that's testament to that we are friends. And I think what Fiona's saying is absolutely right. You know, we may be experts in regional anaesthesia, but that doesn't make us experts in the treatment of transitional and onto chronic pain. It doesn't make us experts in treatment of neuropathic pain. We know it's like when everything you see is a nail, then all you've got a hammer. It's the other way around, isn't it? When we've got a hammer, everything looks like a nail, and we want to block everything, and that's great. But one size doesn't always fit all, does it? And so we were talking about things like, lower limb arthroplasty, and we'll have that discussion, and it's a discussion to be had with both the whole team and our surgical colleagues as part of that team as well. There's a vogue for day case lower limb arthroplasty, which is great for a number of patients, but it's not, a one size fits all, and so we'll not do motor sparing blocks, which may not be quite as dense and effective in some patients. Some patients haven't been mobilising pre-operatively. They're not going to mobilise very quickly post-operatively as well. And then we'll be having a discussion, about those patients who are coming on long-term opioids and maybe high dose of long-term opioids aren't mobilising. We'll be putting, more traditional, motor large motor nerve blocks in, and talking to our transitional pain colleagues to manage the pain at the back end of that block, and just to make sure we're getting that absolutely right. So it's a complete team multidisciplinary approach, and I think that's the best thing you can do for your patients, isn't it? We're with regional anaesthesia, we're a part of that, but we're not the total picture. Yeah.
Thank you very much. Only thing would be to say that in multimodal, I think people who don't do regional, they very nicely hide behind the multimodal term, and just maybe if we should highlight regional a little bit more in that will make it a bit more educational for the surgeons and us and our colleagues, that it has an important role as part of multimodal, not just standard paracetamol and usual medications.
Ash, I completely agree with what you say, but as you can agree with what Fiona and Nat have mentioned as well, the journey actually starts from the preoperative period. So the high-risk group, when we know that there is a high risk for persistent or chronic post-surgical pain, that usually has to be picked up at the surgeon's side, even before the preoperative assessment has started, or at that time at least, so that you need to put them on some of these agents, or maybe possibly, especially knee replacements. We see there is a lot of allodynia around it, and they go there and do the operation. What makes it worse is the allodynia becomes worse, and that's why the incidence of post-surgical knee replacement pain is significantly high compared to the hip replacement or elsewhere. Also, if you look at the prospect guidelines, they are surgery specific, and most of them clearly mention the role of regional anesthesia along with the other agents, what and all would be necessary. So I think there is an element of using not one size fits all, but at the same time we have to be a bit more selective. It just cannot go on one guideline. As Nat and Fiona said, I think intraoperatively most of us will try and manage as much as possible, but usually it is again nociceptive pain that we are addressing. We are not addressing the acute nerve injury that happens for the patients because of the extent of the surgery, especially the group that you mentioned, like breast surgeries or chest wall surgeries. They are significantly innervated and they have significant post-surgical neuropathic pains. I know that the evidence hasn't really come to that level to say that there is a role for antineuropathic agent trials or using them in the perioperative period for various reasons. That's because there's a bit of stigma again on using these agents, and the studies that have happened so far haven't actually been done to a big level to prove that, apart from the small Scandinavian studies which came in the past. But what we tend to see is, especially after hand surgery and knee surgery, there is significant discomfort or possibly, an element of neuropathic pain that picks up after the surgery, and they tend to come to the pain clinics a bit earlier. Again, the definition, when we say acute pain, it has to be within 3 months, and chronic pain is after 6 months. Our systems don't have a system to capture that, in between it. So is the pain going to disappear? The first question they ask is, how long will I have the pain? Even after a small, neuropathic pain after a block or something. So we normally say that usually it should disappear in a fair amount of 3 to 6 months, or maybe sometimes beyond. And in clinics, we tend to see that, after a year, most of them disappeared. They had, a resolution of symptoms, or they accepted the pain, and pain, goes. And as, Prof said in the morning, it all depends on how close the needle was to the nerve and how many nerve fibers or fascicles have been damaged, or what are the other systems that have been activated. In some people, especially if they have a longer or pre-chronic, pre-surgical chronic pain, or possibly pre-surgical nausea or neuroplasticity that's significantly established, yes, they will have continuation of the pain material of the surgery. The nociceptive component has been taken away for some time, but the neuroplasticity will still continue. I don't know whether that answers the question, but I want to.
Could I ask Sue a question? Sue, yes, can you hear me? You mentioned caudals, and I was just wondering if you could maybe update us. One of the problems was, I know that a lot of your paediatric colleagues like to use a caudal catheter. Is there any progress towards an NR-fit version of that, or do you think ultrasound, the use of ultrasound may make that a non-issue?
So personally, I think ultrasound will make it a non-issue, which is why we try and advocate the use of ultrasound. but I think Annabelle Pearson is also in the process of talking to the Pejang and Bibron to see if it's a possibility, because we have done a survey 2 years ago of all the pediatric anesthetists, and 79% of them said that they use cannula, and then there's no reason to change because there's no real safety issue, and then because there's no safe alternative, which is what they're used to, which is a cannula. Some of my colleagues, even using Landmark, has moved to NR Fit, and again they report no issues and not many change in the way that how they feel, but some are still very reluctant. So we're hoping eventually with if we just keep advocating ultrasound from now on, everyone who learns will start using ultrasound, then that will eventually become a non-issue.
Just one last question to you. So, in the place that I work at, we have a lot of kids for tonsillectomies, for dental procedures. Is there any regional anesthesia modality for those kids rather than the multimodal analgesia that we use?
Certainly for a dental, so my dentists, they sort of do, it's not so much infiltration, but they kind of do some blocks for them. But for ENT surgery, I know some centers should do some blocks for that, but not in our center. So we have not got any regional anesthesia technique for the tonsils. Unfortunately, that would probably be one of the better groups to have some regional anesthetic technique for, but we are not quite there yet in our center.
Thank you.
What I would say to that is not necessarily regional, but it might be a surgical technique. If you use cold steel for extracapsular tonsillectomies, it's going to be sore. But there's more surgical sort of emphasis on cold ablation, which is a different sort of technique, and often intracapsular done on coablation will reduce your post-operative pain and reduce your likelihood of bleeding post-tonsillectomy in children. So we found that a huge benefit in our paediatric cohort in ENT, and their all-day case. They don't go home with Oromorph. They have paracetamol, Brufen beforehand. They have paracetamol and Brufen offered afterwards. They do get a small amount, weight-appropriate opioids intra-op, but they're okay.
Can I ask a question to Dr. Womack, Jonathan? I know we probably underutilize the catheters or continuous infusions, for in the perioperative period or postoperative period beyond certain time. Especially, representing low and middle income group countries where their trauma is very similar to what we sometimes see, or possibly even worse, and they don't have possibly an option to go for a multimodal analgesia. What I mean by that is possibly access to opioids is very tricky in a lot of areas. How would you see, whether that could play a significant role, or, I suspect they might not have access for that as well, but.
Yeah, so I've been to, I worked in Sierra Leone for 2 weeks, so it's not really working, is it? But it's going there and doing some work. Absolutely, in a low-resource environment. So we couldn't get there was no morphine, and we were doing orthopedic operations, so it's a block. Trauma, it hurts before the operation and after it, so the most logical thing to do is put a catheter in beforehand when they arrive in A&E. If you think about labour analgesia, there's a standard in the UK that if you're in labour and you want analgesia, that you can have it within 20 minutes of asking for it, but we don't offer that to other patients in the hospital. I mean, there's some reasons for that, and obviously labour is exceptionally painful, but some of these trauma and may well make a difference to outcome. So on one hand, absolutely, it's a place for it. The downside is that running a catheter service is expensive and resource dependent, and it's quite hard to get right. And you need a pain service, you need the equipment, whether you're running in, you need the right infusion pumps. You need long duration single shots haven't worked with Exparel and those sorts of things. It might be electrical stimulation is something in the future, but that's not going to be cheap, is it? So repeat blocks, that requires you to have people that can do it. So basically in a low resource environment, all the options require resources, and so it becomes really challenging. But definitely regional anaesthesia has a place, whether it's single shot or blocks repeated. That might be something that you could do, or catheters that you top up.
Yeah. Thank you, Jonathan. Yeah, I think that will also possibly play a good role in terms of preventing persistent post-surgical pain.
Absolutely,
if we were to continue for longer. Yeah.
That's for Fiona. Fiona, in one of your slides there was this taper 2 results, and you talked about some 90 patients which were de-prescribed. There was one line written at the bottom. It was like, success was detrimentally affected by cancellation. What was that? If you can highlight on that, please.
Yep. So this goes down to the importance of having a known date of surgery. So when patients don't know when their operation is, or we don't know when their operation, it's a really nice sort of touch point, isn't it? When a patient goes, that's when I'm having my operation, and you can work backwards from that and go, and I'm here, and I'm going to get to there. And what they found actually was detrimental. Them being cancelled. So then what do you do with that? They come in, you've worked up for this, then they don't have the operation, or that it's not when they expected. So it's been moved forward. You get a call, we've got room today, or we've just started the journey of starting to talk about reducing your opioids, and then they're in next week. Mm-hmm. And so that caused, I didn't lead on that taper 2 trial, but I know the people who did, and that was the sort of reference in that line. Those 2 slides were their slides, so I couldn't alter them. So I can't give you much more information other than the anecdotal information I got from them.
Okay. Thank you.
If you don't have any questions, I think we'll end this session. I think we have about 20 minutes break, but can I have a round of applause for all the speakers, and also to Sue for joining us online. Thank you. So we'll join back in, it's 15, 20 minutes.
Anaesthetist at QE Gateshead, and also the privilege to be examiner for the ESRA exam and a board member for the ESRA exam. So this is a session about the Plan A blocks for the lower limb, which will be done with my colleague and esteemed friend, Dr. Kiran Koneti, who's a consultant in Sunderland, who you have been hearing since the morning. So we'll be talking about the Plan A blocks, which includes femoral, and we look at aortic canal and the popliteal sciatic block. And Maria has kindly agreed to help us with that. Right? Okay?
Yeah. Okay, guys. So we're going to start with the femoral nerve block, which is the most common block that we normally do for the lower limb. So Maria is our model, who is a medical student, who is also helping us today. So she's supine with the groin exposed. So
yeah, so we'll start off looking at the inguinal crease, and so the right side of the left side of the screen, this side is lateral, and this side is medial, as probably you can see there. That's medial side. Okay, so we look at the starting thing is the femoral artery. So we go medial towards the inguinal crease. We want to look for a pulsatile vessel, which is our femoral artery, as you can see in the middle of the screen there. And if you remember your mnemonic from medial to lateral, vein, artery, nerve, and the vein is in the middle, on the medial side, that is being squeezed, so that can be easily squeezed. So you can see the artery is pulsatile in the middle, and the big muscle underneath the artery on that side is the iliacus muscle, which is basically iliopsoas coming from the transverse processes and the iliacus muscle. And if we go a bit more lateral first, so and you can see there's a fascia iliaca under the on the iliacus muscle, and a fascia lata on top of it. So essentially, the femoral nerve is sitting lateral to the femoral artery in this corner, squished. Now, something to be aware about. Obviously, here we have a young person where the muscles are fairly well developed. So you see the nerve is squished, whereas in elderly patients, especially the patients which we do for neck of femur and things, the muscles are not that well developed, so femoral nerve is a bit more further down and nicely a bit more saggy related to young patient, just to be aware of. And if you go further lateral, so Kiran will scan a little bit further lateral just to look at the transition of the muscle. As you can see, how the iliacus muscle is finishing here, and you're getting a big sartorius muscle on the further lateral to the iliacus muscle. Just to understand the anatomy. Now coming to how do we do the block. So once we have scanned, as Nat has mentioned in the morning, we do a pre-scan just to understand what the structures are. Once we've identified the structures, we will focus back on where we want to do the block. So we'll focus back again onto the femoral nerve. So you can see the artery in the middle, in here, and the femoral nerve is there. So we will do an in-plane technique. Most people will commonly do in-plane, coming from lateral. So from lateral to medial, and aiming to be in that corner, going through the fascia iliaca. So essentially, either you can just put local around it. Personally, I like to get the local around the nerve, so I'll go under the nerve and over the nerve to get the local nicely circumferentially in this position. Now, the moment the local goes, what you would see is suddenly a sea of local anesthetic and small fibers of the nerve, like islands. So essentially, what are these? These are the branches which supply the various quadriceps of the anterior thigh. And it's very important to ensure that we block at a level where you have a single femoral artery. So if you dip down a little bit, you can see the artery dividing a little bit, and that's what we don't want. We want to block it at a point where the artery is once we come down, you can see the artery is like divided. So what it means is the nerves are already divided. So if you do a block at that level, chances are you might miss some nerves. So it's very important to go cranially enough to get an artery as one single artery, and you can see all the nerves together, and that's the point where you put the local anesthetic around the nerves. Now, in my practice, personally, I would like to use nerve stimulation. I know it's something which not everybody uses it, but that it confirms that when you're getting the needle around the femoral nerve, what you're looking for is patellar twitches, which is confirmed that you have got the deeper branch of the femoral nerve. Sometimes, if you're a bit more not very close to the femoral nerve, you might just get the twitch of the sartorius. What it means is that you might miss the main femoral branch. So it's very important to ensure that you get a nice local spread around that with patellar ridges. Is there anything else you want to add for the?
Yeah, Sash, I mean, as you rightly said, where you go from the fascia iliaca, you will get the nerve, and sometimes if you can go a bit more lateral, we can also get the lateral femoral cutaneous nerve. And there are other approaches as well. But in here, we'll just focus on the femoral nerve for the planar block.
Yeah, so for the planar block purposes, we'll just stick to femoral nerve just to keep it simple. And again, it's a very good block for neck or femur fractures, for anything on the anterior thigh, for knee surgery, it covers all the muscles for the anterior thigh. So moving on, we'll go to the adductor canal. Now I know this block has been a little bit of a contentious, like where do we exactly put the local, and what are we trying to block, and and what are we achieving? So essentially, because as most of you will know that for the knees, we have moved on to motor sparing blocks. We want the patient to mobilize the same.
Is it?
Okay, we can reduce it again, no problem at all. That's fine. So the idea is to mobilize the patients on the same day. See, we've moved away from the femoral blocks for knee surgery to motor sparing blocks. And one of the most important block is the adductor canal. Now, when we say adductor canal, we'll just scan and show you. So main nerves which we're looking at in here for motor sparing is a saphenous nerve plus nerve to vastus medialis, and that's the most important nerve for the knee surgery, which can be used for total knee replacements or the anterior cruciate ligament repair. So just increase again a little bit. So just to, so now most important thing is where do we put the probe? So the position of for the block is we just turn the knee a little bit inside, so just like a frog knee position, so that because we're going towards the middle side of the thigh. So there are various ways of looking at it. So essentially, if you get the artery in the middle, as you can see on the screen there, and then we just go, if we go a little bit up and down and see how the artery is following. So that's the femoral artery. So we'll just go up and down a little bit. So just go down first, and we'll see how it starts to dip down. Keep going down. So at one point, it's going to dip down. Okay, and so yeah. So now you can see how it's going deeper down. And so essentially, that's where the adductor canal or the subsartorial canal starts. The roof of the canal is made by the sartorius muscle, which goes from the anterior superior spine. Yeah, that's fine. Okay. So it goes from the anterior superior spine to the medial epicondyle of the knee, and that's artery sartorius. So so just remind me, this is lateral is that?
That's medial.
That's medial. So laterally you'll have the vastus medialis, medially you'll have the arteria longus, and we're trying to get the local lateral to the artery. So we'll just take this off, and I'll just point out exactly where we're going. So if we go up, so we don't want to block at this point. We will come exactly in the middle of the thigh, where now there are various ways to look at it. Some people will describe it like a prayer sign or a whale's eye sign. So you're slightly above where the artery is going to dip into the adductor canal. You're going somewhere in the middle of the thigh, and the idea is to look at the sartorius on the top and the vastus medialis here, and the needle comes from lateral to medial. So if I just draw a pointer from here, so the needle will come like that. So personally, the way I would do it, I'll come from there, I'll split the sartorius from the adductor longus, slowly coming in, opening that space, and the nerve to vastus medialis, it sits somewhere here. I think we can make out something there. And the saphenous nerve is very lateral to the, just next sitting to the artery. And how do I confirm? I mean, you can sometimes see it very well. I think probably it's here. But again, as I said, in my practice, I use a nerve stimulation. So if you actually get your nerve stimulation here, you will see the twitches of the vastus medialis, and that confirms that you have got the nerve to vastus medialis. All you need is around 5-6 mils for that, and then you can go lateral, further towards this side, and get the saphenous nerve, another 5-6 mils. Now, knee surgery is one place, yes, but the other place where it's very important is for foot and ankle surgery, as a part of the major ankle surgery, where you want a medial coverage for saphenous nerve. I think this place is the most reliable place for covering the saphenous nerve, and all it needs is, in this case, very important, when you come in for this, try not to just aim for the saphenous nerve. Again, you can use the nerve stimulation to rule out nerve to vastus medialis in this case. So all you need to come in, just come in and put 5 mils of local anesthetic,
in this exactly lateral to the artery, and you'll get the saphenous nerve covered very nicely. So for foot and ankle surgeries, purely saphenous nerve, and for knee surgeries, you want both nerve to vastus medialis as well as the saphenous nerve. Anything else you want to add?
Yeah, that's fine, Ash. Fantastic. You've covered everything. So
Okay,
next, as part of the plan A lower limb, we'll go to the popliteal sciatic.
So you can
we'll ask
turn
Maria
to-
to just go on
turn on your side.
Sorry.
Now the popliteal block can be, popliteal fossa, basically what we're targeting is the sciatic nerve.
Let's scan on this.
We can do various positions. In this situation, we are doing it in a prone position. In my practice, I tend to do it in lateral position. It doesn't matter. Some people do it in supine position with the leg up. So the key thing is to scan and look for the sciatic nerve and the point at which it divides into tibial and the peroneal nerve.
Can you go up a little bit? I can't see.
So yeah, right. Okay, thank you. Thanks for it.
Oh, thanks.
So Kiran is just setting things up. So why do we need a popliteal nerve block? So I mean, ultrasound has given us the advantage of to be able to block the sciatic nerve at much lower point. Before ultrasound, it used to be very high proximal the Raj approach and the the other approaches where we went very high, but with ultrasound we can visualize the nerve very nicely in the pop fossa, and we have a landmark which is the popliteal artery, which allows us to see where the artery is, and the nerves is just around that. So as we are scanning, so we start in the pop fossa because at this point the nerves are fairly superficial, and we aim to look for the popliteal artery. So let's have a look. Again, in terms of muscle, as you would see, the muscles are very echogenic, and that's why it can make it a little bit difficult to appreciate the nerve there. Now, lateral side, so if I said, is that medial? No, that's lateral. Yeah, that's lateral, okay. So lateral, you have a very echogenic biceps femoris, and medially is biceps, semimembranosus. And then we look for the artery in the middle. So let's see if we need a depth reduce, or let's see if we can find the artery first. We'll reduce the depth. Okay, all right. And this is the place where one of the block where you need anisotropy. Let me just scan a little bit that way. Let's say something better now there.
1 second, Maria.
If we go in popliteal, yeah, I think I can see something. Okay, so we can see arterial pulsation there. We'll just increase the depth to go a little. Now the artery is deep, and the vein and the nerve is superficial to the artery. So if we just scan a little bit and see if we get something.
Just need a bigger.
Yeah. So look, see, should be able to.
The artery.
That's the artery there. So nerve has to be, I think put it to deep there. Sorry, so
Yeah,
is that now there on the top? I think it should be, yeah, there. I think we can see that, right? Okay, let's focus on that now. Let's just focus. So that is
That's
dividing. That's dividing.
That's
and
the
that,
fibula.
Right. Okay. So let's reduce the depth. Okay. All right.
So what we are seeing is, because sciatic nerve is even though it's a thicker nerve, it's got different echogenicity. So you might need to use quite a lot of manipulation with your probe, mainly to tilt it. Usually, I mean, the anatomy still holds good in terms of.
If you focus here, do you want to just scan up and down a little bit? Sorry.
Yeah.
So the nerve is dividing at this point. So just do it again, and I'll show. Yeah, there. So you can see it divided. So that the tibial nerve goes towards the artery, and the peroneal will go over towards the fibula. So there it's together. So we get it in the middle there. So it is, as you can see, how the muscles are echogenic. So it's about to divide at this point. This is all together. If you go further distal now, and there it's divided. So this is tibial, and this is the peroneal, and that's the beauty of ultrasound. You can say the variations, how easy it is to miss it, and how easy it is to find as well. And again, so once you find the division, you want to block it before it's just about to divide, and that allows to come tangentially at the bifurcation. So the needle can come from lateral to medial just coming under the artery at the bifurcation, and you can actually breach now the tibial nerve, or sorry, the sciatic nerve. I'll just freeze that image just to make it easier to put it together. Okay, and this is the key thing about the sciatic nerve is surrounded by a very tough structure, the peroneural sheath, and the tibial nerve and the peroneal nerve are always two nerves inside the sheath right from the start. So the important thing is you have to breach the sheath at that division point, and that allows the local to spread around both the nerves. And once you have injected the local, and if you go distal, both the nerves will take their own local with them as like a trouser sign, and that tells you that you have got local on both the nerves. If that hasn't happened, that means you haven't breached the sheath and the local is not around with, and that's not going to work. So it's very important for the sciatic nerve in particular to go tangential, breach the sheath at the bifurcation. That allows that safety of preventing to go very close to the nerve. And once you breach the sheath, the local will go around both the nerves, and then you can nicely see them distally spreading and taking the local with them. And again, it's very important for anything on the foot and ankle surgery, major ankle surgery, hind foot surgery, potentially anything below the knee that will cover analgesia as well as anesthesia for those patients. Anything else you want to add?
Dash, I think Maria has had a bit of injury, so I think maybe that's why it's pushed slightly with edema.
No, that's fine. And again, as I said, I will use nerve stimulation in that, and it's very nice to actually see how when you stimulate the tibial nerve, you get plantar twitches down, plantar flexion, and when we stimulate the peroneal, you'll have an eversion of the foot. And again, it is very sort of confirmatory. At the same time, you also know that you've got the right nerve for the right purpose. Right. Is that?
Yeah, that finishes this one.
So thank you very much, Maria, for that. Okay, thanks a lot,
Maria.
to you.
Yeah.
Right. Okay. So, so next session we'll be talking about session 5. So it's our first speaker is Dr. Peter van de Putte. So he is from Belgium. I had the pleasure to see him and meet him at the previous ESRA meeting in Oslo. So there has been a new point of care committee being formed in the ESRA, and Dr. Van de Putte is the chair for the POCUS group. So, and he'll be talking about the gastric point of care as we discussed that in the morning with Rosie. So is that a recorded talk as you? Yeah. So a recorded talk from Peter. Thank you.
All of you. My name is Peter van de Putte. I'm an anesthesiologist and I work in Belgium. My main area of interest has always been POCUS, point of care, ultrasound. I'm at the moment chair, together with my fabulous colleague Rosie Hogg from Belfast, of the new POCUS committee of the European Society of Regional Anaesthesia, ESRA. POCUS means that we are sitting on the bed of the patient and that we are trying in a fast and simple way to answer a clinical question, usually in a binary way, yes or no. Is there a pneumothorax? Yes or no. Is there pericardial fluid? Yes or no. Is the patient fasted? Yes or no. And this will help us to take good clinical decisions and help us when we are called, for example, to the recovery room. Doctor, your patient has a low blood pressure, your patient has a low saturation. Instead of going to the radiology department or needing x-rays, you can, using, for example, ultrasound of the lung, of the diaphragm, you can solve and diagnose very quickly problems. Now, within POCUS, my main area of interest has always been gastric ultrasounds. And this is more than ever, and that's what this video is meant for, because I want to stimulate all of you to learn gastric ultrasounds. We are flooded with patients that are using GLP-1 agonists. And as most of us by now know, these agonists will delay gastric emptying, which means that if we look at these patients, despite they have followed the fasting guidelines and they've been fasted for 1, 2, even 3 days, you will find in their stomachs sometimes a surprisingly large amount of potentially dangerous gastric content. Gastric ultrasound allows us to determine it in a qualitative way. What's in the stomach? Is it empty? Is there clear fluid? Is there thick fluid? Or is there solid food? And if there's clear fluid, we can quantitatively calculate how much fluid is in the stomach and if it's above a dangerous threshold that increases the risk of aspiration. What I want to share with you now is I'm on call at the moment, and I just anesthetized or finished the anesthesia, the surgery of a patient who is on GLP-1 agonist and who had been fasted for 14 hours for clear fluids and 17 hours for solids. But nevertheless, because the patient told me he was on Ozempic, I scanned his stomach. And I want to share with you what I found on the ultrasound machine. What you see here is a still image of the antrum of the patient. So what we do is we do an epigastrial scan in a sagittal way of the abdomen of the patient. And what we need to see in the image is the liver and the aorta. And this is what you see here. The L from liver, the A from aorta. You can also see the vertebra here. And you see between the red arrows a ovoid structure. So when an antrum is empty, it has this small bullseye appearance. And this is definitely, as you can see, a dilated antrum, and there's fluid inside. So this is taken in the supine position. And if we look at the patient in the right lateral decubitus position, it's even more prominent. You see the liver, you can see the antrum here between the red dots, and it's filled with clear fluids, and I saw small flakes of solid food floating around in the fluid, which meant this patient was absolutely not fasted. And therefore, the entire airway management was changed to rapid sequence induction, and I was able to aspirate 150 mL from this guy's stomach. So, in conclusion, what I wanted to share with you on World Anesthesia Day is that we have a tool that helps us to make good clinical decisions, that help us in the guidance of airway management of our patients in situations of clinical equipoise, when we are in doubt. This 50%, is he fasted, isn't he? Patients on GLP-1 agonists, acute abdomens, the patient who had a cookie 4 hours ago, the lady from the retirement home that's a bit confused, and she tells you upon arrival she had a glass of milk an hour ago, while the letter of the nurses states she's completely fasted. So you're in doubt, and then you can use gastric ultrasound, and it will help you in your guidance and offer the best possible way of treating our patients. So thank you for listening, and good luck.
Right, so it's a very nice small introduction of gastric ultrasound by Peter. So our next, again, a recorded talk from Dr. Atma Totangal, who doesn't need much introduction, but I'll just talk a little bit about her. So she's a current RA UK board member. So she's an international expert in pain management and a lifestyle physician as well. So she'll be talking about sex and gender differences in pain and pain management. So yeah, Atma's talk. Thanks, Kiran.
I'm Dr. Atma Totangal. and it's such an honor and privilege to talk to you regarding sex and gender differences in pain and pain management on behalf of the European Society of Regional Anaesthesia and Pain Medicine on the day of World Day of Regional Anaesthesia and Pain Medicine. Mind the gap in pain. This is very important because the gap is not only in pay, but also in pain. That is why in 2024, IASP celebrated it as a global year for educating and increasing the awareness regarding this gap. We say children are not small adults. That applies to male and female as well. Women are not small men. The chronic pain is a gendered epidemic. Fibromyalgia, migraine, and autoimmune pain conditions, which are nearly 100, that affects women 3 to 9 times more than men. The biological foundation in the difference is 2 hormones, which is estrogen and testosterone, which makes the pain processing pathways in the female and male brain different. It also affects the pain threshold, the pain processing, and analgesia response. There is an anatomical and physiological difference as well. The human body composition is different. That includes the muscle tissue, fat distribution, and bone density, bone mass between the male and female. Even the biomechanics is different. In pain perception point of view, in a male brain, the peripheral injury is transmitted through the central nervous system, especially the microglia in experience. But in a female, this is controlled, specifically the pathway is controlled by the T cells, which is starting in the periphery, and it is a part of the neuroimmune response, and that is experienced in the central nervous system later. So all these physiological differences affects how each drug is metabolized, excreted, and it imparts the effect on the human brain, which is different between male and female. The musculoskeletal system difference is a huge part of pain management, as the bone density, bone mass, as well as the skeletal difference makes a huge part. The biomechanics will be different, and this affects the incidence of various joint problems in male and female. The best example is the Q ankle, which is different between a male pelvis and the female pelvis, which affects the incidence of knee pain and osteoarthritis in female, and osteoarthritis of the shoulder and the shoulder pain problems like a frozen shoulder around the menopause in women. The pelvic anatomy, innervation, and also the density of the nerves are different between male and female, and that is one of the reasons it contributes to the sex-specific pelvic and menstrual pain patterns as well. As women, we go through 5 P's of our physiological roller coaster, which is puberty, pregnancy, perimenopause and menopause, pelvic pathologies like endometriosis, and hormonal imbalance like polycystic ovaries, subfertility, or infertility. Once a male attains the puberty, the diurnal variation is very minimal in the hormone fluctuation, but in a female, on a day-to-day basis, the cyclical changes happens, and this is exaggerated during the stages of pregnancy, perimenopause, menopause, and also underlying cause of many of the other pelvic pathologies. This affects the medications or the drug metabolism effect, and also how pain is experienced and processed in a female brain. The other big difference is the sex and gender, along with the cultural biases in pain recognition and treatment. Male physicians rate women's pain as less severe and also more likely to say that it is mainly psychological. This unconscious bias leads to delayed diagnosis and inadequate treatment in female population. Many pain conditions are considered as normal. The best example is menstrual pain, labor and postpartum pain, or menopausal changes and the musculoskeletal changes that happens in the menopausal age group. And this is accepted as a norm rather than seeking any specific treatment. Another classical example is a typical chest pain of cardiac events. Because the male chest pain is described by the male physicians and it is transmitted as atypical, many physicians don't even recognize a heart attack in female population, even though it is the number one cause of mortality and morbidity in women after menopause, and women contribute more than 50% of the population. All widespread pain syndromes are considered as psychological, or says it is all in your brain. The social, professional, and the personal bias influences the pain assessment and management in the form of lack of awareness among the public and the professionals, and also the societal and the structural biases, considering many pain as normal, and the cultural and the lifestyle influences matters as well. Especially for a female, the societal pressure to perform other duties or prioritizing care of others makes it is more difficult for them to access pain management services. The sexual bias in biomedical research is a huge part as well. The opioid paradox, where it says women metabolize opioid differently and we require 30 to 40% higher doses for equivalent analgesia, but yet prescribed less opioids. And male models of both animal models as well as human models are still used for many protocols that are still practiced in our medical practice. Until mid-90s, it was not even mandatory to include females in the research, and female-specific research is still underfunded. Psychological difference is another important factor because men have 52% more synthesis of serotonin than women. This is one reason why depression, anxiety, psychological trauma, and stress is more prevalent among women, which are strongly associated with the chronic pain experiences. Special consideration in the low-resource countries are: one, they may lack even enough health professionals available, limited training opportunities for pain management, especially sex and gender-sensitive care, and lack of national policies and limited availability of painkillers like opioid all contribute to this. There may not be even multidisciplinary services available or supported by the government. So in future, if you want to proceed and apply inclusive, equitable strategies for pain management, what we need to do is identify these current gaps in the clinical guidelines and research and rectify these by future research priorities and also research specifically looking at the sex and gender differences in making newer policies and new pain paradigms. The policy development is one important aspect where the education also needs to be included, both physicians, patients, and other policymakers. The priority of the future research should include the sex and gender differences as well. The principles of the new pain paradigm should start with the assessment where it has to become sex and gender sensitive. The pharmacological management and the interventional management should include the sex gender as a part of the management context. And even the non-pharmacological treatment like lifestyle medicine interventions should be sex and gender specific as well. The future research priorities, this should be mandatory that any intervention that we are researching should have that sex and gender differences as the priority and inclusion criteria. Also, there is female gender, female sex specific condition needs to be prioritized as a research priority as well. In regional anesthesia, we need to think about how we need to change our block techniques, dosing, and monitoring based on the biological sex and gender differences. We all are trying very hard as anesthesiologists, regional anesthesia, and pain physicians to reduce the incidence of chronic persistent post-surgical pain. As it was published by DC Rosenberger and team, the risk factors, if you look at it, the major factors are patient factors and pre-existing pain or undertreated pain. Anesthesia, general anesthesia or regional anesthesia as an anesthesia option does not make a huge difference, but the analgesia option and treatment of pain makes a huge difference for the prevention of persistent post-surgical pain. So if you look at them separately as patient factors, the sex and gender specific and also changing the modifiable factors makes the biggest impact for the prevention of persistent post-surgical pain. This is also evidence-based. As they published this article in BMJ 2025, where 186 RCTs were included, and they looked at the usual care and the outcome, which is very poor. But if you include the lifestyle factors and also which can be made into sex and gender specific, the outcome will be way much better and more desirable. So sex and gender difference, equality versus equity, we are not looking for equality, but equity. For that, we need social justice where the inequity can be addressed. So as take-home message, I will say sex and gender difference has got a huge impact in every aspect of human life. Pain management should shift from the WHO analgesia ladder to personalized holistic pain management. Focus should be on equity, not equality, and the lifestyle factors are very important, and it can be applied irrespective of the sex, gender, socioeconomic, or geographical differences. And final few words, please believe and validate patient's pain report regardless of sex and gender, and avoid normalizing pain as normal or hormonal, or please don't say it's all in your head. Use a well-structured life course, looking through a life course lens in assessment, and make a tailor-made, holistic, multimodal, and culturally appropriate treatment available for them. So today, as a part of our desire to have equity, access, and relief from pain, I request all of you to our call to action, which is we commit to form evidence-based equitable pain management that is recognizing and addressing sex and gender differences. Thank you very much.
Thought-provoking talk from Dr. Thottungal. So just before we finish the session, I would just like to mention that Dr. Peter Van de Putte would also be present at the Bristol ASM meeting of RA UK along with Dr. Rosie Hogg, and he will be obviously talking about and teaching you gastric point-of-care ultrasound. Right. Last but not the least session is again live scanning on the plan A blocks, which is rectus sheath and the rectus spine A plane block, which will be done by Dr. Jonah Womack and Nat Haslam. Over to you, Nat.
Great. Okay. So we're going to start with the rectus sheath block. Rectus sheath block is good for essentially infracostal incision, upper abdomen, particularly a midline incision. Rectus sheath blocks are often put in by the surgeons, but as we discussed earlier, we can see it, not the surgeons, which gives us an advantage over them. It's also a really easy block to do. It's a really nice block to do. I don't do it very often, but I've done it for things like perforated oversewing of a duodenal ulcer. Yep. It's a really nice procedure for that. And a midline laparotomy if you're trying to avoid an epidural. So the first thing that we can see really nicely there with the...
I'll take the nerve blocks off for now.
for now.
Amit and Jeff's talk earlier.
Yeah. We just need to flick it on just before we do the block.
We will do that. Yeah.
So if you put the ultrasound in the midline, we can see the linear alba very clearly. You can see we've got abdominal contents moving around below the rectus sheath and the peritoneum, quite nicely seen. And we've got the linear alba in the middle, which gives us the symmetry. You can see there the two rectus muscles, and actually because Maria's got really nice anatomy, we can see both muscles really clearly. You can see the sheath round the muscle, and then you can see the peritoneum deep to it. So when we perform this block, you can see here that flow from one side to the other is going to get restricted. So what we want to do is we want to move laterally and find the edge of the lateral part of the rectus muscle around here. Now you can see that at this level, above the umbilicus, we've got a muscle coming in underneath the rectus muscle, and that's above the umbilicus. It's usually transverse abdominalis there. And when we move below the umbilicus, you can see that the one that joins first is the internal oblique there, and actually transverse abdominalis is there quite a long way back.
This is a linea semilunaris, isn't it, at the lateral border of the rectus
yeah.
sheath. So this is the start of our tap plane.
So I tend to try and go as lateral as possible, just so that I've got those nerves as they're coming in before they've started to go up through the muscle. And also it means that you're quite a long way away from the incision. We do want to look for epigastric vessels, which you can sometimes see within the sheath, and definitely worth watching out for. If you get hematoma there, it can be quite big and painful.
Yep.
The other way that I have done, and I was taught this by Nat, is if you twist the ultrasound round, you can see the sheath in the long axis view. You can see the striae between.
So this is nice to point out. This is what Jono's found here in the middle is in the longitudinal view. Here is one of the tendinous intersections. So this is what, if you're slim and lucky enough, like Jono, then you'll have a six-pack.
Not anymore.
Me neither. And the reason for pointing out the tendinous intersection is that it's deficient posteriorly. So a question that's sometimes asked is, why on earth do we go to the posterior border of the rectus sheath and inject there when it's so near to peritoneum and bowel content? And why don't we inject at the superficial border? And the answer is because those tendinous intersections stop the local anaesthetic spreading longitudinally along the rectus sheath. So we get, so you can see John is demonstrating that. That's really nice.
Just move laterally slightly.
Yeah.
And the tendon's gone.
So this is where the local needs to be, superficial to the posterior fascia of the rectus sheath.
Yeah. This longitudinal view is a nice way to thread a catheter in. Sometimes the tricky thing about it though is that you can see that the striae of the muscle run in line now with the sheath, whereas if you turn it in a transverse plane, they don't. So you can get a little bit confused. So that's one thing to watch out for if you're doing it in that direction.
Can we repeat that again?
Yeah. So if we're getting a short axis view of the muscle, then the planes within the muscle are coming at us. So they don't look like lines. They look like little. Yeah. Like if we go in the long axis view of the muscle, the fascial planes within the muscle look like straight lines, so you might get confused about what is the posterior sheath. It's not difficult at all in Maria, but in other people, sometimes it's very thin muscle.
So one of the, as Jono was saying, one of the big uses of this is for midline laparotomies, and so we can either do this ourselves in the longitudinal view, and the longitudinal view makes it easier to thread a catheter in. Or we can ask the surgeons to do that at the end of the procedure. So they have the abdomen open, and we talked about it before. They can't actually see the plane, but they can feel the plane. They can feel the inside of the peritoneum with their gloved hand, and they can bring the needle down onto that posterior border. And so that's an alternative way of doing it. We still need to know it because it's useful for those laparotomies where the surgeon hasn't put them in. Maybe they've gone back ventilated as a level 3 and no one's really thought about it, so we do them the following day. It's also useful for pediatrics as well, for things like umbilical and periumbilical hernias. It's a nice block to do for that, in which case you would probably do it as a single shot with the lateral, from lateral to medial, as Jono was mentioning before.
Remember that we generally perform this above the arcuate line, which is, as a rule of thumb, it's about the level of the umbilicus, although that is not true. It is below the umbilicus. But the safest thing to do is do this block above the umbilicus, because as you go more inferiorly, the the sheath is definitely not as thick, so you can easily go through into peritoneum. You have some protection further up.
Shall we just point out that
Yeah.
the artery there as well?
Oh yeah, sorry, yeah. It was there. No?
Just scan down, scan inferiorly. It's there, isn't it? So yeah, so we can see large artery sitting at on the deep border of the rectus abdominis muscle. That's the inferior epigastric artery, and that's quite commonly seen. So look. This is quite an easy block in that it's a fascial plane block, and we don't have to specifically look for the individual nerves. We're hoping to get the local in a correct fascial plane, but do look out for those hypoechoic pulsatile areas because you don't want to get bleeding from this block.
You can sometimes see the superior epigastric as well, obviously higher up. It's definitely worth one for the colour Doppler just before you do the block.
So we are somewhere in the mid-clavicular line, sort of.
I tend to go as lateral as possible, just as the transverse abdominalis is coming in. Because the transverse abdominalis plane is where the nerves are coming in, isn't it? And we want to get them at the posterior sheath as soon as they.
If you don't mind showing on
Yeah,
the
of course. Yeah.
Where would your tip of the?
I tend to go somewhere like that, relatively lateral, on the idea that I'm going to get the nerves as they come into that sheath before they start going up through the muscle. If you go really medially, then they may well have already gone up, become superficial by that point.
So the nerves traverse the rectus abdominis muscle, don't they? So they perforate, as John was describing. They then perforate the superficial border and give a small branch to the midline and a small branch slightly off the midline as well.
So do you aim to unzip this fascial plane?
Yes, yeah, and that's easy to see with a longitudinal scan.
And lift the muscle off the posterior sheath. That's the key. It's not two fascial planes that you're splitting, like a tap plane or something like that. Good.
Great. Okay.
Yeah. Okay. That's rectus sheath. Do you want to give yourself a little?
This will be good for chest wall, chest tube drainage as well. Pain as well.
What, a rectus sheath block?
Yeah.
Probably not.
No. This is for below the xiphisternum. It's not.
Yeah, that's what I'm saying. So, when for cardiac surgeries, when they put the drains, that goes like subcostally.
Depends on how medial they are.
Quite medial.
Yeah, if they're in the sort of vague area of the sheath, I think in medial to the nipple, I think it's probably going to work. But lateral, I would think it's probably less likely.
They're almost parasternal.
Okay.
Bilateral. So that's where most of the times patients don't complain of sternal pain; they complain of chest drain pain.
Which may well be an option.
That's what I'm.
That's actually Turn a little bit that way. That way. Face that way. Right, that's good. Right, this is a slightly unusual position, but I'm thinking about the camera. So Maria's sat up. And we're going to now scan for a rectus spinae block. Now, the most likely time that it's not for you because you're potentially in thoracics, but for most other people that are working in a DGH, probably the most likely time they're going to do a chest wall block is for rib fractures. So I think it's worth remembering that patients with rib fractures find it quite difficult to move. So there's various ways that you can position a patient. You can have them sat up. Sometimes people like to sit up like this. It's comfortable for them. You can get them to roll on the side. And then the other thing that I do, my sort of go-to position is to turn the bed into a chair, sit them right up, and then put the back of the chair down with them leant forward. And most patients seem to be able to manage that because you're never really moving them particularly far from a position. So you're sort of sitting them up in the bed. And then I come from the side. Now, we'll have a very quick scan. So the key thing with the rectus spinae plane block is that we're going to look for the transverse processes. And the important thing to identify is the tip of the transverse process. And the transverse process is going to have a relationship with the ribs. Now, we're going to count our transverse processes, but we maybe don't need to be that accurate with it because we want to be we're going to get spread upwards and downwards with a single injection. So we need to be in mid-thorax or upper thorax or lower thorax, depending on where we want to be. But you can count ribs because you only have X number of ribs. The caveat to that is that the first rib is quite difficult to see, the 12th rib is quite difficult to see, and I would count from the closest one. If you want to do the 11th rib, don't count from the top because you'll get lost. There are a few other ways to find out. Now, if you just drop your head very slightly for me, that's good, just so I can see the screen mainly. So the ribs are going to look quite characteristic. They're going to be curved. So we've got a rib there in the middle of the screen that Nat can highlight.
Can you orientate us, Jono, which is cephalad and which?
So cephalad is to the left of the screen. So I'm going to switch around because actually that's the wrong way for me. So we've got a rib there in the middle of the screen. Now I think that we're probably going to struggle to find one more superiorly here unless we go right the way around and find the first one again. So I'm pretty sure that that's the first rib. So in Maria, that's pretty superficial, but that one can be quite difficult to see. It can be quite deep.
You can see pleura here as well.
Yeah.
To the rib.
Now, yeah, exactly. And so as we start to move down, we'll see these ribs in sequence, and we'll see a nice glistening pleura between them. If I move too laterally, I suddenly hit this this bone here, which is the scapula. So you obviously can't see through the scapula. So try and keep medial to the scapula, which is actually quite hard to accidentally scan the scapula, but it's worth knowing it's there. And then we generally would count down maybe to the 4th or 5th rib, let's say for a mid-thoracic ESP block. Now, once we've decided our level, I'm then going to move in from the rib to find the transverse process. So there's going to be a couple of clues, okay? So the first is that the rib and the transverse process are not exactly at the same level. So the rib is slightly higher than the transverse process. So as we move to transverse process, it's going to look like it's going to jump to the left. The pleura are going to be more difficult to see because the pleura, when you're aiming at 90 degrees to the pleura like this, it's going to reflect back. But as we go medially, they're going to start to dive away from the probe. So they're going to reflect less back. And on the way to the transverse process, we've got a ligament called the lateral costotransverse ligament, which is the least the lesser famous of the costotransverse ligaments, and that's going to make, when you look at a ligament compared to bone, it's going to just be a bit more mushy. It's not going to be like the nice bright white line that gets reflected back. So we're looking for a jump, hard to see the pleura. We're going to look for something where it's hard to see the bone and then it becomes clear again, and that will be the transverse process. So
okay, so we've got a classic rib here, and it's really quite small. It's curved. And we're getting a nice view of pleura just deep to it there.
Yeah.
So
and then,
John, are moving medial?
I'm going to move medial. The other classic way that they describe the transverse process is tombstones. I don't think that necessarily helps because ribs look a bit like curved tombstones as well, don't they? I mean, tombstones look. So we're moving inwards, and then mushy, and then a jump. So that is now the transverse process there.
So we've got a much squarer, flatter transverse process, and this is much larger, the shadows coming down here. You can see pleura is much deeper.
Yeah, and I can angle outwards and try and find the pleura a bit easier there, but I've had to work at that, whereas with the ribs I didn't have to work to find the pleura. So that's definitely a transverse process. And you get slightly tricked by some of these bits of rib here that look maybe a bit like, but the key is that we haven't had the mushy bit yet and it hasn't jumped.
Yeah, there's a definite gap, isn't there, as you go through the costotransverse ligament. So you're going from the rounded small rib to the big square transverse process, which is...
The transverse process is lower than the rib. It's lower than the rib, so the rib sort of sits on top of it. So it moves... Now, above the transverse process here, we've got some extra bits of information. So we've got one muscle layer above it, which is the erector spinae, the group of erector spinae muscles, which is more than one muscle. We've got probably 3 muscle layers there now, haven't we? So we've got above it, we've got the rhomboid, which is going to taper at some point, and it usually tapers at T5, but actually it's not. Maria's rhomboid is massive. It goes a really long way down her back, which is interesting. It's not a reliable landmark, but it's just worth. The rhomboids are rhomboid shaped, obviously in the name, so they taper at depending exactly where you are, where the arms are, and then above it we've got the trapezius.
So we've actually got 3 muscle layers at this level here. We've got trapezius, then rhomboid, then the rectus spinae group of muscles, which is interesting. As Jono says, there's lots of variation on where they taper off. And it's kind of interesting, but it's not really that important because, as Jono will tell you, that's not really where we're not aiming in those 2 top muscle layers.
It's nice information to impress your residents, but ultimately it's not required to do the block.
We always like to impress.
Yeah, exactly. It's extra bits of information to make you sound clever, but ultimately not important. So for an erector spinae block, where we want to be is below the sheath of the muscular sheath, the thoracodorsal fascia that surrounds the erector spinae muscle. So below that. Now you've got a couple of options. So I say like level 1, the easiest way to do it is to hit that transverse process with your needle. It's safest because you've got a backstop against a deeper needle placement, but it can be a little bit tricky to get the muscle to peel off and be certain that you're below it.
Yeah, so that's what the block was first really described clinically by Professor Ki-Jin Chin, who is Professor of Anaesthesia in Toronto, but trained actually here in Newcastle. And he described hitting the transverse process and using it as a backstop. But as Jono says, the problem with that is that you don't often get right. It can be difficult to inject if you're right down on periosteum, obviously. And if you withdraw, you tend to be in the body of the muscle itself. So I think most people are now aiming for slightly off the transverse process and actually popping through the fascial layer and then injecting as you withdraw. There's also this concept of pepper potting the fascial layer to try and get some anterior, some ventral spread. We can block in that area. It's called an ITP, an intertransverse process block. But one of the proposed mechanisms of an ESP block is by anterior spread into the paravertebral space. So there's certainly no harm in making a hole in that ligament, and you might get some leakage of local anaesthetic through, which might give you a longer duration of your ESP block.
Good. That's, I think.
So you can see here's pleura.
Yeah, I'm just angling outwards very, very slightly there to get the pleura in view. So let's have a go at that one.
So the pleura is reflecting anteriorly. So Jono is having to angle the probe laterally to be more perpendicular with the pleura as it reflects anteriorly. So it's difficult to see the pleura at this level.
That one's a bit better.
Yeah. So here's transverse process here. You're actually getting the impression of a ligament down here as well, are you? So this space here will be the paravertebral space. So if we were going to do a paravertebral block, our needle point, end point will be down here beneath the costotransverse ligament and deep, quite deep within the patient. So you can see why, as a plan A block, having a needle end point much more superficially and much further away from the pleura is an attractive proposition. So the ESP block was proposed as a plan A block before there was lots of evidence really for its efficacy. And one of the arguments for using it as a plan A block was it's almost like a gateway into leading you on to be able to do a paravertebral. You become familiar with the scanning, you become familiar with the anatomy, but you've got a much more superficial, much less risky block to do. The evidence is then built for ESP in terms of its efficacy, and now a lot of places will do that as their kind of first line, and then only if the ESP doesn't work will they move on to maybe doing a paravertebral. Paravertebrals can be difficult, can't they? Some patients have some surgical emphysema. If they've got rib fractures, the views aren't always very easy. If you've got some problem with your coagulation, you certainly, everyone's on a DOAC nowadays, aren't they? You don't want to be sticking a needle into the paravertebral space, but you will be happy, potentially, risk benefits obviously, but you'd potentially be happy to do a more superficial ESP block. So although paravertebrals it would be nice if everyone could have them in their armamentarium. The Plan A block is going to be the one that you start with, and there's no doubt now that it's efficacious for a number of different indications.
Good.
So
Perfect.
Is that the only plane you take, you employ, or do you do transverse as well? Like this was
not for an ESP.
Not for an
ESP, it's all sagittal scanning.
You could do a transverse ESP block potentially, so you can visualise the transverse process there, but I don't know that it has really an awful lot of advantage.
I think for the vast majority of patients that we're doing an ESP block on, we're threading a catheter as well. So it makes much more sense to do that in a longitudinal view.
Okay, in line, yeah?
Yes, in plane, and either from inferior to superior or superior to inferior, depending on the level, depending on the position of the patient, as Jono was describing, and depending on your personal preference. That bit doesn't matter so much. Yeah. Okay, great.
Thank you very much for a beautiful demonstration. So what do you not do?
Yes, so we're going to wind up our day there. I'd like to thank Ash Gupta for chairing our last session. Thank you again to Eleni Mocker, President of ESRA. Thank you to Sebastian Bloch, President-elect. Thank you to Nuala Lucas for chairing our meeting. I'd like to say a huge thanks to our sponsors, Pyunk, for today. You can see their sponsored logo behind us. So to Rob and Nima at the back, thank you very much for your support. We couldn't have done it without you, so that's amazing. Thanks to GE for providing the ultrasound machines and the couches. Thank you very much to our tech team. We'll have a round of applause for Chris. It's been amazing. Everything has worked really smoothly. And hopefully we'll see everyone again back next year for the 4th. And thank you, obviously, to the delegates online for joining us. Yeah.
And thanks to Maria for helping us with the demonstration.
Okay, thank you.